tissue so you can tell right side from wrong side. Your patient position has to be parallel. If it's not unfolding, remember the 3 reasons it may not unfold. You can tap or trap, you can use fluid to flip or open, and also remember that air is not your friend. And so with fun and frustrations with learning DMEC, here's what I've learned. Experience is the best teacher. Don't panic. Nobody likes to see the pilot cry. And when in doubt, jugaad. Thank you so much.
That is a wonderful talk, Dr. Audrey. For many of us who are still struggling with DMEC, I think this is quite reassuring that we are not the only ones having these problems. The best thing was jugaad. You have to make do with what you have. I just wanted to ask you one question. I saw that you have 2 S stamps. So you're making 2 windows in the cornea, in the anterior cornea to create these 2 stamps?
Yes, well, actually, that was initially what I did. I don't do that any longer. And the reason was because the ink that we used would disappear. It was a disappearing S. And so at some point, this is a little bit of an older video, one would disappear. So at least 50-50, one might not.
All right, we'll just have a couple of quick questions from the panelists and then we'll move on to the next keynote talk. Any comments? Dr. Fogla does a lot of DMEC.
I think she has covered most of the points for DMEC surgery. And the extra marks that you see is even when the eye bank gives you a pre-strip tissue and they put an S stamp, when the donor scrolls up, if the ink mark has been too dense, I think it leaves behind, further impressions. So you will see, which will look like as if you have made multiple marks, but it's the same mark that has got another imprint because of the scrolling of the tissue.
Sure.
Rishi, I was hoping we could get some tips on the donor preparation or if there's any specific device that she prefers. Dr. Audrey?
Oh, that for the donor prep, basically, there isn't anything specific, just your usual trefines that you use and the little Sinsky to lift up, and adequate staining of the tissue, I think, is really one of the key points is adequate staining of the tissue, and also making your mark whatever letter you like to use so that you can easily visualize it.
Thank you.
All right, we'll move on to the next talk. The next keynote speaker, Dr. Rishi Mohan, will talk to us about tear film homeostasis, restoring tear homeostasis. That's his topic. Please, Dr. Rishi.
All right. Good morning, or is it good afternoon already? And good evening in the US. The talk that I have been given today is treating dry eye and the restoration of homeostasis of the tear film. And I thank Rishi and the HOA for giving me this opportunity to be a part of this wonderful meeting. It is very promising as I look through the agenda, and I hope that I'll be able to convey certain aspects of the restoration of homeostasis in the tear film. I have no financial disclosures of relevance to this presentation. And we do know that the homeostasis of the tears at the ocular surface, am I in full screen mode for everyone?
No, it's not on slideshow mode.
It's not, isn't it? So let me see if, is that better now?
Yes.
Okay. So we do know about the lacrimal functional unit, which comprises of 3 main components: the ocular surface tissue, the tear secreting glands, cells, and the neural connections or the secretomotor aspects of the lacrimal function unit. And we are also aware of this very nice diagram, which has been set up over the last few years, which tell us about the core mechanisms of dry eye and how they interact with each other to produce the damage that we see on the ocular surface. We do note that there are external influences as well, the meibomian gland dysfunctions, and then there is a host of external influences which are environmental or otherwise, which can impact the presence or absence of the tear film instability, the hyperosmolarity, the inflammation, and then finally the apoptosis that is responsible for the signs and symptoms of dry eye. The key factors, of course, when we are talking about homeostasis, there's not much that you can do about apoptosis, but you certainly can help these two key factors. One of them is hyperosmolarity, and the other is inflammation. So these would then help to restore the functionality of the tear film. So let's talk about hyperosmolarity to start with. And we do know that in the healthy eye, the osmolarity is between 296 and 302 milliosmoles. And in dry eye disease, this value is generally believed to be between 316 and 360. However, at the top of the cornea or at the apex of the cornea, the tear film osmolarity may be very, very high, and it's very, very difficult to evaluate that. It's estimated to be 3 times higher than what it is in the area of the tear meniscus, where the samples are collected in clinical practice. So osmolarity is important, and it does matter. And we know when the proportion of water to solutes in the tear film is the same, the system is said to be in what we call an isotonic state, and all the cells maintain their integrity. But what happens in a hyperosmolar state, there is a dehydration of the ocular surface cells. And as these ocular surface cells lose water, they shrink and they become dehydrated. So it's impossible for a tissue to shrink in a certain circumstance. So there is something that happens, which is called the regulatory volume compensatory mechanism, wherein the normal cell, which is exposed to the hypertonic environment and is dehydrating and shrinking in size, will do what it calls a regulatory volume intake by taking in salts. And this restores the cell volume, but the salts, which are metabolically active, will produce a decrease in cell function, they will produce stress activation, and they will produce cell damage and death. And this is what is eventually what we call apoptosis. So this is what happens in a hyperosmolar state. This hyperosmolar state then leads to certain further activations of the inflammatory pathway by introducing acute epithelial disease and then producing a chronic ocular surface damage, which is then T-cell derived. And then that involves a second wave, like the COVID that we're talking about, of new mechanisms of creating dry eye and perpetuating the dry eye cycle. So can we do something to protect against hyperosmolarity? So if you look at the same hypertonic exposure and dehydration and regulatory volume increase that happens with the intake of salts, we can actually provide the cell, or the cell can provide itself with another mechanism, which is a regulatory volume increase with what we call compatible solutes. And this can restore the cell volume by bringing in osmoprotectants, which are taken up by cells and restore the cell volume and stabilize the protein function without actually interfering with the metabolism of the cell. So compatible solutes are small, non-ionic organic compounds that build intracellular osmotic strength without actually participating in the cell function. And so they don't damage proteins. And this property is called osmoprotection, where the cell function can be managed or maintained without damage under hypertonic conditions. So numerous tissues experience hypertonicity, and these cells protect themselves by either synthesizing or importing compatible solutes. But the corneal epithelium, unfortunately, does not have the capacity to manufacture its own compatible solutes. And so the role of osmoprotectants in patients with DED builds up, and the osmoprotective effect depends on how much osmoprotectant the cell takes up and how long it is retained. So there are various osmoprotectants that are available: glycerols and erythritols, which are small polyols, and L-carnitine, which is a much larger amino acid and can be retained for longer periods. So the efficacy of osmoprotection can be looked at by various ways, the laboratory studies and by clinical evidence. So if we look at the hyperosmolar stress in corneal epithelial cells And we look at human corneal epithelial cells here, which were incubated in isotonic and in hyperosmolar media in the presence or absence of these osmoprotectants, suggests that the addition of osmoprotectants like L-carnitine and erythritol in hyperosmolar media significantly decrease the ratios of phosphorylated to the total MAP kinases. So the MAP kinases are enzymes which suggest inflammation, and this will go up substantially when there is a hypertonic exposure. But in the presence of these osmoprotectants, there is a protective influence, and this is seen across the board with both kinds of MAP kinases that were studied. The superiority of osmotically regulated tear preparations over passive tear substitutes is also seen in other corneal dehydration models, such as this one, wherein in a situation where there was no dehydration of the cornea, the epithelium was about 9% of the total cornea. But as the dehydration happened, it went down to about 8%. And when it was rehydrated, either with osmotically regulated tear preparation or another tear preparation which did not have osmotic regulation, there was an improvement in the score. However, the ones with the osmoprotectants scored better than the ones without. Osmoprotectants also suppress the production and activity of MMPs, which are induced by hyperosmolarity in human corneal epithelial cells. So the suppressive effect of osmoprotectants, L-carnitine and erythritol, on mRNA expression can be seen in this study. And here we can see as the hyperosmolarity or the osmolar levels starts to go up, the expression of all these MMP13, MMP3, and MMP7 go up substantially. But even at 450 milliosmol exposure in the presence of L-carnitine and erythritol, the expression hardly increases beyond baselines. And that suggests that there is a huge protective influence of these osmoprotectants. There are clinical evidences as well, which suggest that the efficacy of osmotically regulated preparations with moderate to severe dry eye are superior to those which are not having these properties. And here we can see the OSDI scores and the number of drops being used being reduced in those using these specific preparations. And then in a switchover study of over 5,000 patients who were switched from one type of osmoprotectant drop to one that did not contain one, showed that 85% of patients reported an improved comfort and 75% reported improved clinical signs and symptoms, with a significant reduction in the tear breakup time from baseline. So these are some of the naturally occurring compatible solutes that are available in various species, and the ones that are clinically significant to us and that we have incorporated in many of our preparations are L-carnitine, erythritol, glycerol, and trehalose, which is a small sugar. So the kinetic properties of compatible solutes are extremely important. And we can see that there are many compatible solutes based on their molecular size, which can move in and out of the cell membrane fairly rapidly. And those which are slightly larger need specific water channels where they can move in with a little more regulation. And the ones that are more slow and need active transport mechanisms for them to move in and out of the cell. And these combinations of osmoprotectants with different kinetics may actually work better to increase the overall protection in dry eye. So conventional artificial tears have a limited impact on the ocular surface, and the suggestion from all these studies and work would be that we should consider using lubricants which are replete with the proper combination of osmoprotectants. So in summary, hyperosmolarity and osmoprotection, the surface damage is mediated by hyperosmolarity, which is a key mechanism in the evolution of dry eye. And cells utilize short-term and long-term regulatory mechanisms, and hypotonic solutions only provide very transient relief. Compatible solutes help regulate the osmolar balance, and there is sufficient clinical evidence of their beneficial effects, both in vivo and in vitro. Let's talk of the second key mechanism which is there in the production or the perpetuation of dry eye disease, which is inflammation. So dry eye, as we know, is a chronic immune-mediated inflammatory disease, and it results in an autoimmune inflammation, which reduces the mucins. It alters the concentrations of the growth factors and reduces the amount of tears, which then leads to an incremental inflammatory output from the lacrimal gland and affects the entire ocular surface. The ocular surface immune homeostasis is regulated by the lymphocytes and the CD4 regulatory T cells, and there are many stress factors that disturb this finely tuned homeostasis and balance which exists on the ocular surface, which include the environmental challenges, infections, endogenic stress, autoimmunity, and certain genetic factors. This increase in tear film osmolarity sets up innate inflammatory events, which is what I had shown in the previous slides. And the reduction in corneal sensitivity also promotes neurogenic stress and the impairment of the ocular surface homeostasis. So if I go back to one of my earlier slides, one can see here that by the end of the 7th or 8th day, the dry eye and hyperosmolar stress sets up an influx of bone marrow derived T cells and the cytokines which are associated with the advent of these activated T cells, which leads to a chronicity of ocular surface damage due to inflammatory influences. So over the years, techniques have been developed to diagnose inflammation, to identify and validate the ocular surface markers, and to further understand the DED or the dry eye disease inflammatory mechanisms, and to assess the clinical efficacy of the treatments. So the inflammatory markers are extremely important in trying to see what sort of benefits we're going to draw. And HLA-DR is a biomarker of inflammation, which gets upregulated in dry eye disease. And the increasing expression directly correlates with increasing severity of the dry eye. When we talk of the inflammatory therapies and we start to evaluate these biomarkers, we look at topical corticosteroids, we look at non-steroidal immunomodulators, and there's a whole list of them. And the newer molecules, the inflammatory modulators such as tetracycline, and now the LFA antagonists like lifitegrast, which I'll just briefly speak about. So we start with topical steroids, which are most commonly prescribed short-term treatments for managing dry eye associated inflammation, even though they are not explicitly indicated for treating dry eye disease. They have been shown to have clinical value in short-term use. Long-term use, of course, not being recommended due to the steroid-related side effects. The newer steroids like fluorometholone and the surface active steroids, as well as the milder steroids, which do not penetrate too much like loteprednol, may have a lower likelihood of creating these side effects. The key non-steroidal molecule that we have used now for more than 2 decades is cyclosporin, and is an immunomodulatory drug with anti-inflammatory properties, and it reduces many markers of inflammation. It reduces hyperosmolarity. It has anti-apoptotic effects and has resulted in recovery of the reduction in goblet cell density. But it does take a few weeks for a significant impact to be made on the ocular surface. And some of them, patients do have mild complaints with its usage as well. The mode of action is essentially it blocks certain nuclear translocations and stops T cell activation and blocks certain cytokine and chemokine production. The effect here we can see in immunostaining in activated T cells in the conjunctiva of a patient at baseline, and at 6 months after treatment, one can see a substantial reduction in the number of activated T cells. One can see in the decrease in the number of cells expressing HLA-DR after the use of the cyclosporin 0.05%. And multicenter randomized studies of the efficacy and safety have been done, which have shown that there is significant reduction in corneal staining, in Schirmer's values, and in the vision blur. Even in dry eye disease progression and in regression, a lot of these studies have revealed that there have been improvements across the board. So cyclosporin A reduces the number of activated T cells. It reduces the tear levels of multiple inflammatory cytokines. It decreases ocular surface staining and reduces apoptosis and increases tear production. The candidates who are potentially beneficiaries of the drug are those who have a chronic dry eye which don't resolve easily, the potentially contact lens intolerant patients, the postmenopausal women, the ones who have very occasional symptoms or very severe symptoms which have non-functional lacrimal glands may not be as benefited with this medication as the bulk of the candidates who lie in the middle. Just a word about the use of cyclosporin in terms of its onset of action. More than 70% of people felt that relief was only there after the 3rd or 4th week. And that is important to know because we must counsel our patients when we suggest this medication that it does take a while for the impact to start to appear. Tacrolimus is like cyclosporin and is a viable alternative for patients who are intolerant to cyclosporin or who have an allergic response or where the response to topical cyclosporin is poor. Omega-3 fatty acids, I brought in a couple of slides just to bring in the fact that we have used this for more than a decade, and then a study suggested that they are not as good by Penny Aspel's group. However, I still continue to use it, and I do find that it has some benefits, especially in those who have meibomian gland disease, where I tend to prescribe it more freely. It has a multifaceted role in attenuating the core mechanisms of dry eye disorders by producing the changes as are listed here in the slide. Lifitegrast is still not available in India. I'm hopeful that it will be included soon. It is an antagonist of ICAM1 by creating a antagonism by mimicking the binding domain to LFA1 and acts as a competitive antagonist to block the binding between LFA1 and ICAM1 and results in a reduction in the T cell migration and the cytokine release and reduction of further T cell recruitment. I think this talk wouldn't be complete without briefly mentioning at least one product, which is sodium hyaluronate, which is more and more evidence suggests that there is an improvement in tear film stability because of its mucoadhesive and mucomimetic properties. It has a long retention time and symptomatic relief, and it actually helps the epithelial regeneration by using certain specific aspects of its character, which is its affinity to the CD44 and how the CD44 is a glycoprotein which is encoded on the surface as an adhesion molecule, and the sodium hyaluronate actually attaches to the CD44 and helps regulate the improvement on the ocular surface by improving the adaptability of the epithelial cells.
1 minute more, please.
Yeah. So protecting against the mechanisms of dry eye disease is the goal of treatment is to improve the patient's quality of life and symptoms and to reestablish the homeostasis and the integrity of the ocular system, and what should aim to prevent the patient from entering the vicious cycle or promote the exit from it. And this is a list of therapies which can be used to target these pathophysiological mechanisms. And the ones that would be of particular use to us would be osmoprotection and tear substitutes, the use of oral tetracyclines and other antibiotics, and the use of steroids, cyclosporin, and omega-3. Other than the other adjunctive methodologies that we may have, the environmental modification strategies, and that would really conclude my talk here. So thank you very much for your kind attention, and I'm very happy to take any questions on this.
Thank you, Dr. Mohan. That was lovely. I think you covered a dry eye topic very, very well and touched upon some important aspects. Any comments or questions from the panelists?
Only comment or a question I can add is Rishi is, it's very nicely comprehensively covered by Rishi, but all of us should remember that dry eye, when we're talking this treatment, we're talking without the background or underlying disease, meaning those which have an underlying systemic disease, we need to pay attention to that. So this is a caveat for our audience.
Yeah, absolutely. I'm in full agreement with that. Many of our dry eye patients have underlying systemic issues of an immune nature. And if they are not addressed, then the treatment would be inadequate or would be incomplete.
All right, so we're running a little late, so we'll move on to the next part of the program, which is interesting panel discussion we've tried to keep. It's called Kera Shockers. So I've requested some of our young presenters to present some cases from their practices, which will be a little shocking. And we've got an expert panel which will be commenting on these cases and giving their inputs. Each case, I think I'd request the panelists and the speakers to keep it to 8 minutes, since we have about 40 minutes left in this session. We'll start with Dr. Muralidhar. He's a consultant at the L.V. Prasad Eye Institute, and let's see what he has to show.
Dr. Rishi, can you see my slides?
Yes,
Hello?
they are visible.
Okay, yeah. At outset, I would like to thank HOA and Rishi for giving this opportunity. I'll be sharing this rare form of oculoneurocutaneous syndrome. I don't have any financial disclosure. As our previous speaker highlighted, so a gamut of systemic and ophthalmic conditions can have this kind of manifestation. In all these cases, if you look at ocular surface breakdown is very ominous. It's very important to recognize the underlying systemic cause, as Dr. Sangwan already pointed out. Some of them can have a life-threatening consequences. So our proband was an 8-year-old boy, hails from West Bengal, byproduct of a second-degree parental consanguinity. Right from early childhood, child had recurrent episodes of redness, watering, photophobia, and they sought, the many institutes, and nothing actually helped him. Gradually, his condition worsened and deteriorated. When I was first seeing this case, he had right eye anterior staphyloma, left eye had adherent glaucoma. We could also see the perioral keratopathy kind, so that actually suggestive of a non-infective etiology, and did have a keratinization over the conjunctival surface as well. And including as a pupil was completely obscured, child had no vision at the time of presentation. A similar milder variant, unlike keratomalacia, if you look at entire ocular surface is keratinized. And cornea is a lustreless, does have a sterile infiltrates, and a previous episodes of similar recurrent in nature. And early on, some of the subtle cases can have a non-dentic lesions. It's very important to recognize at this stage, or else, reversible consequences on a ocular surface. We would think about, one is a vitamin A deficiency, which all of us know the various clinical gradings and a manifestation of vitamin A. It could be herpetic, and as we very familiar with dendritic pattern recognition in something like a geographical survey, where still the heads have the dendritic feature that helps in diagnosing it very accurately. It could be other systemic etiology, wherein you have a self-inflicting trauma, dry surface, no tear production, and completely dry ocular surface. Again, it is a congenital corneal anesthesia. They can have initial epithelial breakdown. If we don't address, it can actually progress into, again, irreversible corneal damage and neurotrophic keratitis. Coming back to our case, so if you look at carefully here, so the right eye has a anterior staphyloma, adherent glaucoma, and a dry ocular surface, varying degree of keratinization, and look at various bony prominences where you can see hyperkeratotic lesion with a varying degree of scarring. Again, at the angle of the jaw, we could actually see it. This is a typical tyrosinemia topi, which is similar to what we see actually in a gout. And a palmoplantar hypokeratosis. And the palms, again, in a prominent area, you can actually, where you have a bony prominence, you can actually see deposits. A yellowish, well-distinct, well-defined deposit, it can continue to progress. So signed for a metabolic screening, and did have both urinary and a serum very raised tyrosine level, and I did ask for a genetic screening. So one of the basic abnormalities that tyrosine aminotransferase, either it could be deficient or it could be inadequate, that in this particular case, very severe form. So one of the largest series to the date, nearly 90% of them have ophthalmic manifestation under 1 year. Neurocognitive, which sets in about second or the third decade, and a skin manifestation typically seen after 5 or 6 years. So this everything, if when we put entire perspective of the case, so you have a neurocutaneous syndrome related to the type 2 tyrosinemia. So since you don't have any definitive treatment at this point in time, early recognition and restricting the, the diet, basically low protein diet, is a key in minimizing the irreversible consequences. Unfortunately, even in the largest series published from the West, 2/3 of these cases are early and not been able to pick up early on until you have irreversible skin and cognitive issues came up. That's how the diagnosis was made. So whenever you see a child with an unusual keratopathy and where without skin manifestation, and they are not responding to the conventional treatment like a supportive measures, like a preservative, so
Murli, we lost your audio for the last few seconds.
to take Dr. Rishi? Hello?
We can hear you now. Can you repeat the last slide, please? So there seems to be some issue, but I think all of us have seen the presentations. I'd request Dr. Namrata to comment on this, and also Dr. Sangwan. Murli, would you just like to say the take-home message again? We couldn't hear you.
I think we seem to have lost Rishi's, Murli's line. Can you hear me, Rishi?
Yes, we can hear you. So please go ahead and comment on this, Dr. Sangwan and Dr. Namrata.
I think this is a very, very good tip that Murli has shared, that a child with unusual keratopathy, with these associated, signs, which many a times most of the clinician would have not seen, because these things are very rare. So working them up for metabolic disorders, or taking opinion from our pediatric ophthalmologist. They sometimes have, they see syndromes, or they are more well versed with those syndromes than the weak cornea specialist. And also looking for a collaboration with an endocrinologist. Those things will help us in better management of these cases. But Murli has done a very good job in working up, and he has a collection of wonderful cases at LVP. Thank you, Murli.
I think it was a beautifully documented case, and there's really a lot to learn. I think Dr. Rishi Mohan has something to say.
I was just one stick. And here also, again, with the same protocol, you can see how beautifully the cornea has scarred and vision has improved to 6/18, and the patient had some amount of cataract also in this particular case. And this is the fourth case, though it doesn't have longer follow-up, but the same thing. You can see a typical central scar that was very aggressive, a short history of non-specific. He told that he had a bath in a pond 2-3 weeks back or so, and he told he immediately developed this 2 days after that, and that treatment protocol, we could heal this case also. So to show you typically how this heals, for example, this was a recent case we saw where you see this person was a 16-year-old male who told while he was dusting his house, something fell into his eye and he rubbed it, and by morning when he woke up, this was the clinical picture. So that is how aggressive Pseudomonas can be. Overnight, you can see this picture. See this picture, you should have very high suspicion for Pseudomonas. And once you confirm it on grams, we start our protocol of gram-negative bacilli, tobramycin, and along with that, we start steroids. And this is how it will heal in as early as 5 days. And his vision has improved to 636 now. So to our assumptions from the study are topical steroids will definitely have a role in Pseudomonas keratitis, as all of us know that the inflammatory part here is more than the infectious part. And it also prevented perforations in all our cases. And all our cases, if you see, were circular and central, and the vision improved significantly in all our cases. The only thing you have to be cautious is never start steroids without having a microbiological support of at least a gram stain. And always remember, Pseudomonas, though it can be a same organism that is affecting different individuals, it can act in a different way in different individuals. For example, you take Mahatma Gandhi and Osama bin Laden. Both of them were Homo sapiens. They were very serene looking. They had huge followers, but both of them were also killed. They had unnatural deaths, but the impact on us was totally different. So in the same way, though it is Pseudomonas, what we feel is when you suspect that this particular kind that is aggressive, central, and it is circular in presentation, in these cases, in our limited experience, we feel that steroids will definitely have a beneficial role. I thank my mentor and teacher for teaching me this wonderful pearls and guiding me in the management of complex microbial keratitis cases. And last but not the least, I thank Rishi Swarup sir for giving me this opportunity.
Thank you, Madhu. They were wonderful cases and beautifully documented. Unfortunately, we are very short on time, so I'm going to have only one comment from Dr. Rishi Mohan while the last presenter, Ashish, loads his talks.
I think a brilliant series of patients and a very good similarity in the clinical picture, even though the histories were quite diverse. I think the key element is the aggression with which this organism attacks the cornea. The use of steroids is always a double-edged sword, Madhu, and I think from a general panelist point of view, I wouldn't want to give a takeaway impression that steroids would be a line of treatment that we should initiate early. What if we are wrong with our clinical impression and we actually make the disease worse? So I'm totally with you on the microbiological workup. You must have a backup which has given us a positive on the identification before one starts an anti-inflammatory like a steroid. But a wonderful case series, greatly enjoyed that.
Yes, thank you.
Have the last talk loaded, please. Ashish Nagpal's talk.
Yes, sir.
Thank you so much, Rishi and HOA, for having me here. I think they'll be uploading the talk. And I think we can play it all through. You don't need to pause it. I guess we can have
a very good afternoon. Thank you very much for including me in this lovely Kera Shockers session. I have a single case. Let me quickly go on to it. So this is the brief history. This lady was referred to us. She was one-eyed. She had already been on treatment for 2 months, diagnosed as a scleritis case, an infectious scleritis, investigated, everything was negative. And even a biopsy had already been done, which had suggested a mild ulcerative and granulation tissue and necrotic debris. And this is what her clinical picture was when she came. This is the fluorescein stain. And you can see on the slit, you can see there was interesting looking water level in one of the infiltrates or the bullae sort of a thing on the corneal epithelium, which was interesting to me. And at that point in time, I was very confused as to what is happening here. And she was on many medications, as you can see, natamycin, azithromycin, Zymaxid, cyclogel, everything. So what we did was we asked her to take a drug holiday. We stopped all the drops for 2 days and saw her. We only continued lubricating drops and atropine eye drops. And on day 2, fortunately, there was interesting resolution. As you can see in the whole picture, the epithelialization was good. The corneal lesions were gone. And she kept on resolving till day 7. And you can see it. So we were very happy that maybe it was related to some drug toxicity, which overlying an infectious scleritis, which may have been resolved. And we were very happy, and this was the end. But then she came back again after a week on day 15, that she was fine for 5 days. And again, she had these symptoms. You can see this clinical picture. And so that time we decided to go ahead and take a scraping for microbiology to rule out any infectious cause which might have been missed. And then she came back again after 7 days. She was more or less the same, symptomatically a little better. She was on lubricating drops, cyclogel, and we had added moxifloxacin eye drops. After the scraping, the microbiology did not show any growth or anything on any of the stains or slides either. And day 4, then when she came, she was a little better. As you can see, the epithelial defect is resolving. There is some corneal haze which is clearing up. So again, she was resolving the second time, and by the day 28, another 4 days, she was much, much better in terms of the epithelialization and the area of the scleritis, which was in the inferior fornix. But interestingly, at this point, the culture showed up aspergillus, which though scanty, but that was the only thing we had. And so we started her on oral ketoconazole because topically on the picture, she looked as if she's healing. So we did not start any antifungal eye drops. So this was day 28. And then again on day 31, she was better, resolving again. So we continued the same, kept her on follow-up. But again, she came back after almost 20 days with symptoms again. And you can see this epithelial defect in the inferior fornix. And this is the clinical picture and congestion and some corneal involvement, which kept on sort of worsening. It was not resolving. There were some areas even in the inferior fornix and the tarsus as well. So this was the 3rd time that she had come with the relapse. And so at this point, we would like to open the case to the panelists to ask, what do they have in mind? What are the questions? What would you like to do?
We can go ahead probably and see the outcome.
So after this whole discussion, as you can see, we were suspecting there's something we are missing. So after a discussion with the colleagues, and in fact, we had presented this case in one of the meetings when Dr. Sangwan was present, and he had suggested to check the pH, and that's what we did. And it turned out to be very, very acidic in the atropine eye drops, mind you. So after that, what we did was we did talk to her, figured out how she lived. She lived alone. She didn't live with her son, who used to bring her to us very religiously. So what we did was we couldn't get into the social or the other aspect of it, but we wanted to save her eye. So what I did was I started her on preservative-free lubricants of the Novelia, which cannot be tampered with, which is what I hoped for. And then I started her on that. And I also counseled her not to use any drops, any other drops, whatever happened. Do not put any drops. If anybody puts in your eyes, only use this drop. And you can see what gradually her epithelial defect has healed. And this was day 90. I did not start any topical steroids, though I wanted to, because I was concerned about contamination again, that somebody might be doing a foul play. So we continued her I gave her some oral steroids with management of her diabetes so that we could reduce some inflammation. Did not give her any topical medication apart from the preservative-free brand. And fortunately, she resolved and she has not come back again with any of the similar symptoms. Hopefully, everything is fine. So to conclude, this is not something new. This is something which has been reported very nicely by Dr. Geeta Iyer from Shankar Nethralaya. And this is a case which once you have experienced it, you will always keep it in mind whenever things are not behaving as you normally expect them to. Thank you so much.
Beautifully documented case, Ashish, and I'm sure all of us have seen some patient like this. One comment by Dr. Sangwan, and then we'll have to hand over to the next people who are already waiting.
I think it's very well documented case and really well managed, Rishi. Thank you.
Thank you. Thank you, everybody. This was a very good session. I think all of us enjoyed, and I'd especially like to thank the keynote speakers and the presenters and the panelists. Hand over to Dr. Challa for the next session on cataract nightmares.
Yeah, thank you, Rishi.
Thank you, Rishi.
Thank you, Rishi.
Thank you.
Thank you.
So this session is about cataract nightmares. We have two keynote lectures, one by Dr. Sri Ganesh and one by Dr. Haripriya Aravind. Welcome, Dr. Chitra.
Hello, hello.
So we have panelists, Dr. Chitra Ramurthy from Coimbatore, Dr. Parul Sharma, Dr. Harshul Tak, Janin Patel told to be joining a little late, Dr. Pradeep Swarup, Sri Ganesh is joined. So we'll start off with the keynote lectures first. After the keynote lectures, we can have discussion. Then if any questions are there, we can answer. Then again, the panelists, they can present any cataract nightmares they encountered, a small video clipping, and we can discuss about them one by one. Okay. So we'll start off. We'll start off with the keynote lecture, first keynote lecture by Dr. Sri Ganesh. We all know Sri Ganesh is a reputed cataract and refractive surgeon, well renowned not only in India but the world. He is a very innovative guy and out-of-box thinker. He's like Elon Musk of ophthalmology. So he told he'll be joining a little late. He's there. Sri Ganesh is there.
Yeah, I'm here.
So we'll play the recording.
Yeah, you can play the recording. Thank you very much for the invitation. And I think we'll play the recording, and after that I can take any questions.
Yeah, fine. Vinay, you can play that.
Yes, sir.
Good afternoon, dear friends. And at the outset, I would like to thank Hyderabad Ophthalmic Association and Dr. Challa for inviting me to give this keynote lecture on femtocataract surgery in complex cases. Let me just share my screen and we'll get started with the presentation. I have no financial interest in this talk. We will look at different scenarios of complicated cataracts. The first is posteropolar cataract with the PC dehiscence. Posteropolar cataracts are common in younger patients, can be bilateral and have about posterocapsular dehiscence in about 27% of cases. And the femtolaser is very helpful in such cataracts. This is the, here I'm using the Catalyst femtosecond laser, and the docking has been done, and the scanning is being done. When you do the scan, you can actually make out that there is a PC dehiscence there, and you can see that the vitreous opacity is also, and I like to increase the safety margin from 500 to 800 microns for such cases. And I know that there is a PC dehiscence because of the image on the OCT. And we have now commenced with the capsulotomy, and you get a nice 5 millimeter capsular excis, and nucleotomy, and then the softening and the arcuate incisions to correct astigmatism. Following the femtosecond laser, I make a temporal clear corneal incision of 2.8 millimeters, and you can see that there's a free-floating capsulotomy. There is some amount of pneumodissection, so there is no need to do a hydrodissection. And I split the nucleus because there is already the nucleotomy which has been done. So it is easy to aspirate these tubes. And usually the posterior polar cataracts are softer cataracts. So you don't have to use much phaco energy, and then most of the cataract can be evacuated. And there is a vitreous prolapse, so I'm doing an anterior vitrectomy to clear the vitreous after removing the nucleus. Then the cortical cleanup is done by dry aspiration. So dry aspiration is a good technique to prevent further vitreous prolapse, and a thorough cortical removal is done. If there is vitreous prolapsing, then you will have to do a vitrectomy, and you should be careful not to aspirate vitreous while doing the dry cortical aspiration. Following this, a 3-piece IOL is placed in the sulcus. This is a Sensor 3-piece lens, and a posterior capture is done, and you can see that the lens is very well centered. This is the first day post-op result with a beautiful centration of the lens, and the patient had 6/6 uncorrected vision. The next situation is femto for subluxated cataract. This was a patient who had a shuttlecock injury and came with subluxation of the lens, almost more than 180 degrees of subluxation and a lot of tilt. This is the OCT on the femto, and you can see the amount of tilt and decentration. Here, while doing the capsulotomy, you can opt for a custom centration and then adjust the centration so that you are centered to the lens and the capsular bag. And here I'm using a 4.8 mm capsular excis. You can see the severe tilt and decentration, more than almost 270 degrees of subluxation. So that is a custom centration. And nucleotomy and softening. So then you proceed with the capsular excis, and you get a perfect capsular excis in these cases. Otherwise, doing a manual capsulotomy is difficult, and if you don't get a good capsulotomy, then it will be very difficult to manage such cases. Even putting the CTR is difficult. So once the femto is done, then we shift the patient to the microscope. A clear corneal incision is done, and I use a capsular excis forceps to again remove the capsule, because you may not have a free floating capsular flap, and there may be tissue bridges. Then I use a hook to support the capsule, and then phacoemulsification is performed. If there is, you remove part of the nucleus, and then you can put in the CTR. This is the CTR being inserted by a bimanual technique. This helps to reduce the tilt and the PC from suddenly coming up when you're removing the rest of the nucleus. Removing some of the nucleus provides a space to insert the CTR. The nucleus is completely removed, and then a thorough cortical cleanup is performed. Since there is an extreme subluxation here, I prefer to fix it with CTS. So here's I'm doing a Hoffman pocket, and then a little bit of antravitrectomy to remove the prolapsed vitreous from the equator. A 9-O-proline suture is passed through the Hoffman pocket and railroaded into a 27-gauge needle and brought out through the main incision. This is an older video. Now I prefer to use Gore-Tex to fixate the CTS. That is a CTS. And once you have secured the CTS, the suture, you can insert the CTS into the area of maximum subluxation. Place it into the capsular bag. See that the eyelet is above the anterior capsule there. And then pull on the suture so that you have adequate centration of the capsular bag and adequate tension. And then the suture is fixed in the Hoffman pocket. And you can see that the bag is very well centered. Now we are putting in an extended range of vision lens, the Symphony lens, because this patient wanted independence from glasses. I'm using triamcinolone acetate again to check for any vitreous and clear the vitreous. And that is the end of the procedure. You can see that the lens is beautifully centered. And this patient again did very well with 6 parts uncorrected vision. And those are the pictures on day 1. You can see that the lens is very well centered and you can see the capsulorhexis. The other situation is phaco and small pupil. Here I'm using the BHEX ring from Suven Bhattacharya, and I just inserted through a side port. This is a patient who has undergone the iridotomy also, and a very small pupil with posterior synicate. So once you put in the BX ring through the 1 mm incision, you can go ahead with the femto because the wound is very secure. And then you have an adequate pupil to do the capsulorhexis. There are a few points. One is that you need to adjust the pupil size manually and also expand it and center it. Then you also have to manually set the surfaces like the anterior and posterior corneal surface and the anterior capsule surface, because once you put the ring, any ring, there can be distortion of the anterior capsule. So you may have to set it manually and also increase the width to about 800 microns so that you do not have any capsular tags. So once you have set the surfaces, then you can again verify the parameters. Here I'm using pupil maximized center, and then I go ahead with the capsulotomy and the nucleotomy. I have an adequate pupil size of about 5.5 millimeters. And then I make the clear corneal incision with the diamond knife. And again, here I'm using the capsulorhexis to peel off the capsular flap because there might be tissue bridges and you don't want to run off. So that's the capsular flap being removed. And you can see that the pupil size is adequate. I do a gentle hydrodissection and the nucleus is mobile. I go in and do a chop. Again, because of the nucleotomy, the lens fragments are already separated. You just need to complete the separation and then bring the nuclear fragments into the safe zone at the level of the pupil in the center and then evacuate the nucleus. Once the nucleus is removed, then cortical cleanup is done. And after that, single piece foldable IOL is injected into the capsular bag. Removal of the BHEX ring is quite easy, and all you need to do is just hold it with a McPherson, push it so that it disengages, and then you can just pull it out very easily through the main incision. And you have a fairly decent pupil. And these were a few cases, complicated situations using the femto laser. Thank you very much for your attention.
There was excellent surgeries done by Dr. Sri Ganesh. I'd like your panelists to comment, please. Dr. Chitra, you do a lot of flags.
Ma'am, please unmute.
Yes, I do quite a lot of flags, but sadly I missed out on the videos. I saw the last one, small pupil, and the first PPC because the signal strength was poor here. So going further, Dr. Sri Ganesh, would you prefer to do all your posterior polar cataracts to best of your ability by flags, knowing the greater ease which you have in doing this?
Yeah, the the advantage of using the femto for PPC is that you get a perfect, well-centered capsulorhexis, and the size is always, you can adjust your size to 5 millimeters or 4.8. The advantage is even if you have a large dehiscence, you can place a 3-piece lens in the sulcus and then do a capture in the capsulorhexis. With a manual rhexis, it is difficult to get the exact size and centration. So that is one of the advantages. The second is because of the OCT, you can actually visualize whether there is a dehiscence, and then even you can see the opacities in the anterior vitreous, which will give you an idea whether. So you can be careful, and there's no need to do a hydrodissection because there's some amount of freeing of the nucleus because of the pneumodissection, which happens, the air bubbles which are there. And since the nucleus is already cracked with the nucleotomy, it's much easier to kind of evacuate this nucleus. You can also use cylinders. Some of the machines like the Lensex have a cylindrical pattern. So you can also use the cylindrical pattern and then evacuate from center to periphery the nucleus. And you can use this technique also. So it is a boon to have a femtosecond laser in PPCs.
Do you always prefer to do a dry aspiration in these cases, or sometimes just injecting a viscoat keeps the vitreous at bay and you can go ahead and do your slow parameters IA also, bimanual IA can be done?
Yeah, in PPC, if it's a small dehiscence, then without any vitreous prolapse, then you can put viscoat to push back the vitreous anterovitreous face. And if the anterovitreous face is not broken, then very carefully with lower parameters, you can do a bimanual IA and remove all the this thing. And you can also cortex, and then you can also do a posterior capsulorhexis, so that then put the lens in the bag so that the PC is strong. Of course, if you have a larger dehiscence and you have vitreous prolapse, one is dry aspiration. The other is you can also have the irrigation in the through the side port and go through the pars plana and do a vitrectomy through the pars plana, and then clear the vitreous through the pars plana, and then put the lens in the sulcus. So these are different approaches, but in this case, I did a dry aspiration.
About Sri Ganesh, if at all the dehiscence is very small as seen on OCT, is it possible to do a primary posterior capsular CCC with the femto itself?
With the femto, it is difficult because you will have to use a second license.
Oh, okay.
And you cannot do a femto when the nucleus is there. So some of the cases where they have done it in pediatric cataracts, they remove the cataract, put in the IOL, and then do it, then dock. So what happens is the posterior capsulorhexis which you have done, actually it rolls up. So Bukardik has done this, and he has published on this also. So after completing the case, then you can actually do the posteriorhexis. But then we prefer to do an anterior vitrectomy also in pediatric cases, so that you don't have opacification of the anterohyaloid. So I don't think this technique is really good, using the femto to do a posteriorhexis.
Okay. Any more points from panelists?
Ashul has a doubt?
Yeah. Dr. Shri, nice videos. I'd like to know what is the difference in the PCR rate if you compare the femto phaco vis-a-vis normal manual phaco? What change you have seen in your cases, like in posterior polar cataract? What is the rate of PCR? Yeah. And yet true posterior polar.
True posterior polar cataracts, the dehiscence is there in about 27% of cases. So majority of the cases, they don't have a posterior capsule, pre-existing posterior capsule dehiscence. So it's always good to do a UBM or an ASOCT pre-op, or intra-op. We have the RTO 800 with the IOCT. So you can use the IOCT also to actually see the posterior capsule. So generally in about 25 to 27% of cases, in quarter of these cases of posterior polar cataracts, you can have a dehiscence. And when you have a dehiscence, you have to be extra careful. Now, if in a posterior polar cataract, if there is no dehiscence, now I do the OCT, I have an IOCT, so I can actually visualize whether there's a dehiscence or not. And then I do a hydrodissection because it makes the surgery faster. If there is no dehiscence, I do a very gentle hydrodissection so that it frees up and cortical cleanup also is easier. But if you do not have access to an IOCT or a pre-op OCT, then you should avoid hydrodissection, because if you do a hydrodissection and you have a dehiscence, you will end up with a nucleus drop.
So I think time we'll go to the next topic. Dr. Haripriya Aravind, who is a renowned anti-segment surgeon from the Aravind Eye Care System. She is known for her landmark study on intracameral MOXIE. Because of the study, all of us are confidently using intracameral MOXIE as a prophylaxis. So I'd like her to speak on management of complicated toric eye wells, twisted toric eye wells. Please, Dr. Haripriya.
Yeah, thank you, Dr. Chella, for this opportunity. Thank you, HOA. So I'll be talking on misalignment of toric lenses. Toric lenses, as we know, can pose a challenge if the IOL position is altered. And if there's a rotation of about 10 degrees, we know that 33% of the toricity is reduced. And with 30-degree rotation, which is still not very uncommon in some situations, about 100%. So the entire toricity may be removed. In these situations, we have surgical options to correct these lenses, and the outcomes can be good after that. So the first case I'm showing is a patient who had about 1.5 diopters cylinder with the dual astigmatism. Post-operative day 30, the patient had again a 1.5 diopter cylinder. So for all our patients with the toric, in order to confirm the IOL position, we also use the eye trace. And we have a software on the eye trace, the toric IOL enhancement software, which gives us the existing position of the IOL, which is on the dotted line. It also tells us how much the IOL has to be repositioned, dialed by about 31 degrees, and where the actual final position has to lie to be able to give a least possible astigmatism. In this case, the eye trace, the software tells us to dial 31 degrees to have about 0.38 of residual astigmatism. So this patient underwent repositioning surgery. This was about 35 days after surgery. In this case, I'm using the gauge from ASICO. The reason I like this gauge is because we have increment of about 5 degrees. The other ones are normally about 15 degrees. They go from 0, 15, 30, etc. Here it's 10-degree increments with a 5-degree marking, so it's easier to be more precise. And the marker here I'm using is the epsilon marker. Again, I like the epsilon one because it is more sharp. So you get a more accurate position. So I use the existing IOL position as my reference mark and mark about 30 degrees away from that, and then use the epsilon marker. The existing incision is open. I normally don't use the open the wound if it is within 15 days because the IOL can be repositioned under BSS. Here, if it's beyond 30 days, then the IOL is adhered to the capsular bag. So I'm dialing the IOL again clockwise 30 degrees to finally lie at the position where it was supposed to lie. So in case you're using a hydrophobic IOL, the adhesions could be much stronger. So that separation has to be done first mechanically before dialing the lens. I'm using a Simcoe here because I just want to remove the visco very gently. I don't want to have any of the visco go behind the lens. Because you want the posterior surface of the IOL to adhere to the capsule as early as possible. So this patient post-operatively on the eye trace, we found the position was almost where it was supposed to be after repositioning to about 2 degrees. And this is a simulated E-vision chart before repositioning. You can see the haze. And after the repositioning, the patient's visual outcome improved significantly. Patient could see 6.6 uncorrected compared to 6.18 pre-op. So in this case, the issue could have either been, there could have been error in the reference or the axis marking, or that patient probably, the IOL probably had a rotation in the early postoperative period. Most of the rotation typically happens within the first hour, and almost all of it within the first day. So any rotation after the first day is very, very unusual. The second case, not always you have an issue with toric lenses only because of the rotation. So the second case is another case. The patient had about 2.25 diopters of astigmatism. So a toric IOL was planned. Following surgery on the 15th day post-op, the patient had a 2 diopter cylinder. We couldn't assess the IOL position because the pupil was small. So again, we used the eye trace. And the eye trace told us the position was fine as per the plan, but the IOL needed about 78 degrees rotation clockwise to have the least residual astigmatism. So we were wondering why, if the IOL was in position, why this issue happened. And then we realized something which was very surprising. So this was like a freak incident where, while entering the data from the biometry onto the toric calculation sheet, the axis was interchanged. So instead of against the rule, or with the rule was entered. So the IOL, in spite of being on the right position, the patient had a residual of 2 diopters. So this patient again underwent repositioning, and the patient did well, 6.6 unaided. Sometimes some of these IOLs may also need an IOL exchange. It depends upon the degree of astigmatism. So the most common system which we use for planning our IOL enhancement or repositioning is on the eye trace using the Zaldivar's caliper. We use the toric enhancement software. What is very widely also used is that people key in the data onto the website astigmatismfix.com. This website is developed by Dr. Burdell and Dr. Harton. And one has to enter the IOL, if it is Acrosoft, it gives you a ready-made off the website. You can click it. You have to enter the current manifest refraction. So the refraction has to be appropriate, astigmatism magnitude and the axis. And then it tells you how much you'll have to reposition the lens. So some of the risk factors for toric IOL rotation could be that one, most important is the reference marking. That's why all the stress on having appropriate reference marking. One can also use the digital markers where it's available. IOL placement also has to be on axis as per the plan. Another risk factor could be patients with high myopia, because in these eyes, the capsular bag is very large, so there's a higher chance of IOL rotation, especially if the IOL overall length is smaller. Retained OVTP could be a factor, so one has to ensure to remove all the viscoelastic from behind the IOL in all patients, but more so in toric IOLs. Overfilled anterior chamber also may not be recommended, so one has to leave the capsular bag and anterior chamber just moderately filled, because this way the addition to the capsular bag would be sooner. There could be IOL factors as well, which influence the toric IOL's position post-op. Of course, the toric IOL's material does matter. So the more the tacky the material is, then I think the adherence is faster. And you have the fibronectin addition helping to stick the optic, the posterior surface of the optic and the haptic to the capsular bag. Like I mentioned, the overall length of the IOL is also very important. So I think there have been instances, I think the IOL from the Technis IOL from J&J and other IOLs who have gone back and tried to make larger lenses to ensure the chance of rotation is reduced. So it's very important that the friction of the toric IOL haptic to the equatorial bag is well established. So there have been a couple of papers. So one paper is from Dr. Chang and Dr. Brian Lee, where they have compared the two hydrophobic acrylic IOLs which are widely used in the toric platform. And they reported that the repositioning surgery was about 1.6% with the Acrosoft toric versus 3.1% with the Technis. That's when the Technis IOL was remodeled to ensure they had a different IOL design. And they did this about 20 days following the primary surgery. The other series, which is large in the literature, is a series from Japan. It is a multi-centric trial, all retrospective, and their rate of repositioning is low because they had no specific criteria for repositioning. Recently, we have just published, it's still online, not in the print form yet, we've just published our data of comparison of surgical repositioning rates and outcomes of hydrophilic versus hydrophobic single-piece acrylic IOLs. So our criteria for repositioning is if either the patient has more than 15 degrees of rotation, or if the patient's vision is 612 or lesser, or the patient has an astigmatism of about a diopter or more, or if the patient is asymptomatic. So in our data, we analyzed about 5,500 eyes which underwent toric IOL implantation. Of these, 95 underwent repositioning. So as of date, this is the largest series in the literature of the outcomes following repositioning with the toric lenses. And we found that the repositioning rate was about 1.76 with the hydrophilic versus 1.51 with the hydrophobic. Of course, we had a higher number who were advised repositioning surgery, but not all of these patients were willing. They were either happy or did not want a second surgery. And this difference between the recommendation or the performed repositioning was not statistically significant. And following repositioning, we found that the visual acuity improved significantly from 618 to 6 partial. The cylinder reduced from 1.79 to 0.7, and the misalignment reduced from 49 to 5 degrees. The other factor, we also saw that following reposition surgery, the visual acuity with the toric IOLs which were repositioned was very similar to those patients who did not require repositioning. So the outcomes following reposition surgery are actually excellent, and it is definitely something which you can offer to the patients who have significant rotation following toric IOL implantation. In our series, we also realized that the highest risk of rotation was amongst eyes who had with the rule astigmatism followed by oblique astigmatism. So these patients are at a higher risk for IOL rotation, probably because of gravity or the way the IOL is designed. These eyes have a higher risk of rotation and therefore repositioning surgery. We also realized the other risk factors in our surgery were patients with lower IOL power, which is high myopes, again, because the capsular bags are probably larger. The higher astigmatism also may require repositioning, because if the patient has like 4 diopters of astigmatism, and if they have, let's say, 10 degrees of rotation, they would probably reduce, they would still have about 1.5 diopters post-op because they are high astigmatism. Versus a patient who has a 1.25 diopters, even if they have 10 degrees, they only have about 0.5 or less of residual astigmatism. So patients with high astigmatism may require repositioning surgery compared to those with low astigmatism. And as mentioned, the patients with the rule and oblique are at higher risk. So redialing of IOL is something which we can offer. As a routine, what we would always do, which I'm sure all surgeons would do, is to evaluate the IOL position on slit lamp on post-op day 1 and every visit at least up to the 15th day post-op when the patients come back. If the patient's IOL position is not on axis or it's significantly larger. So in our study, we took 15 degrees, and other papers as well in the literature, the cutoff they did was 15 degrees. So even 10 degrees could be something where you can consider if the astigmatism is significant. But most patients with 10 degrees or 12 degrees, the astigmatism is not significant and the patients are comfortable. If done, I would recommend doing it within 2 weeks, because at this point the capsular bag isn't adhered to the lens yet. So it is easy to reposition the lens. You can just go with a side port, use BSS and reposition. It's a very gentle surgery and the outcomes are very good. I don't do it immediate post-op because the bag is still open. The IOL may still rotate back if you do it too early. So I'd like the wound to heal so we know the final keratometry and then reposition about 10 days to 2 weeks following surgery. Again, hydrophobic IOLs tend to adhere earlier. So especially for the hydrophobic, around 2 weeks is fine. Hydrophilics are still mobile even a month after the primary surgery. So in conclusion, toric lenses are extremely effective in patients who have astigmatism, and ensuring you have the right patient selection, pre-op evaluation, surgical precision, and post-operative follow-up, these patients have a good outcome. With the precise assessment and refractive outcome following toric IOL repositioning surgery, you find the outcomes are very good even with the repositioning surgery. Thank you.
That was an excellent talk, Dr. Haripriya. Thank you very much. Panelists, would you like to add or comment?
Yeah. Dr. Haripriya, do you use CTRing in cases which have large capsular bag, which have the higher chances of rotation of the toric IOL? Some surgeons are using, even though it's controversial, but what is your experience, or are you using CTR routinely in those cases?
No, we are not using the CTR. I am not sure if the concern is the capsular bag contraction there. I think it does make sense in using it in eyes with pseudo exfoliation or RP, or where you have some zonular weakness. But in high myopes, we are not doing it routinely. I feel it's more because the IOLs are probably not well sized in comparison to the bag, and I mean there is no evidence. But I think we get to find out. Maybe if surgeons who are using it regularly do show a benefit, we can consider.
I have a question, Dr. Haripriya. Do you think the design of the lens would matter, like Zeiss toric IOL, which has a 4-point fixation? Do you think that would be more stable and lesser chances of getting misaligned?
I have used only few of the Zeiss lenses, sir, so I don't know, but definitely IOL design matters. And like I said, even in the same material, using a hydrophobic platform, we have so many hydrophobic lenses. And we find that even the same platform, the rotation is very different with different lenses, like the HOA toric versus the Technis toric versus the Acrysoft toric. So I think it is, I don't know, the refractive index, it's different, how the haptics are made. So I think there are different other factors which could also influence. But I'm not sure if the Zeiss lens specifically performs better. I've had good experience with the few I have done.
Okay.
Which hydrophilic toric lenses were used, Haripriya, in your study?
Oroflex toric, the one made by Orolab. Okay. That is a more cost-effective option. So many of our patients go in. So we don't have to, so patients who are unable to afford Acrysoft toric still get the benefit of a toric lens and better vision.
And toric IOL rotation is something which happens mostly in the first hour. So we started actually patching our patients, and then when we call them downstairs after an hour after surgery, and then we remove the patch. Having said all of it, the amount of repositioning in any of our series must be so small.
And
yeah, Dr. Parul, anything?
No, I was just interested in knowing if we are using a posterior corneal astigmatism correction for, say, against the rule or with the rule, like a 0.3, 0.5 correction. Is it a standard thing, or do you not take that into consideration?
Yeah, we do use the Barrett's when we're using the Acrysoft toric. We are not able to use the Barrett's for the Orolab lenses. So there we plan for a residual of about 0.2 with the rule astigmatism. In terms of repositioning surgery, the advantage of using astigmatismfix.com is that it takes into consideration the posterior corneal astigmatism. It manages for that. But I have personally found excellent experience with the eye trace. We have been doing it for a couple of years now. And the drawback I find with the astigmatismfix.com is you're supposed to key in the subjective refraction and a lot of subjective components to it. And I find that does not give me, I do both, and I find I go with the eye trace and the outcomes are pretty good. So for some reason, I am personally not comfortable yet in using the data from Dr. Birdell's software, online calculator.
There's one more called assort.com. I've used Assort a couple of times, works well.
Okay, I'll try that.
Okay, then we'll move on to the next part of the session. So panelists can play the videos. Dr. Pradeep, you have a video, you can play it. Dr. Pradeep Suru?
Yes, sir. We are playing.
Also, Dr. Challa, there is one comment in the chat box. If you can take it up, where is CTS available, and do we need to put?
Yeah, Dr. Anurag, Dr. Sri Ganesh, Dr. Anurag asked, when CTR is put, why again you need to put CTS?
Interesting case here. So of course this is a white mature cataract.
They can play the video.
This Pradeep's video.
No, that's not my video.
That's what. You have given it there. You can play Pradeep directly. You can share the screen.
We are sharing, sir.
Are you playing the video or should I play it from this end?
Sir, this is RP Chala video.
No, you, Dr. Pradeep.
Pradeep Saurabh. We are playing, sir.
Meanwhile, yeah.
Please. There's one of the nightmares that none of us would like to have, though most of us would have had it at some point in their career. I'd like to know from the panelists that please stop the video. What would you? Why did this happen, and what will you do now? How will you proceed?
Was there a Rexis extension in this particular case? It's not very clear.
No, there was no Rexis extension. Like we had a circular Rexis, and because of which we were able to place a secondary IOL comfortably.
So then in this particular situation, I think you would go ahead and do a anterior vitrectomy and then place a 3-piece IOL on the Rexis, and then ask your vitreoretinal colleague to take care of the nucleus from the posterior approach.
Okay. Now, considering that it's a very hard nucleus, do you think that that would be a good idea? It would be difficult for the retinal surgeon to do it from a posterior approach?
I don't think so.
Yeah, I also believe that the VR surgeon should take over, after this, because the more you try to take it out or do scooping or something, it is gonna put traction on the vitreous base and cause more complications in later post-operative period. So
I think it's still in the anterior chamber only, and I mean it's in the anterior vitreous. It's not yet gone down. Has something gone down yet?
No, it is in the anterior vitreous, but I don't think that we should. The point that I'd like to make here that we should not chase that nucleus at this point of time. Chasing the nucleus or doing a going beyond an anterior vitrectomy would not be a good idea, and not to panic. Can you play the full video, please? And as somebody said, do not panic and have a friendly retinal surgeon around you so that he can take over at the right time. So we just did an anterior vitrectomy and implanted a 3-piece IOL in the sulcus, and then left it to the retinal surgeon to handle the remove the nucleus from the vitreous. Anybody else will have done anything differently?
I would have tried and saved the nucleus and seen, put good, viscoid support behind, and try to get the piece there, try an IOL scaffold and see if that works.
IOL scaffold, anyway, I'll be showing you my presentation, but not when it is nearly there in the mid-vitreous. I don't think we should safe enough.
There's already dropped in mid-vitreous.
It's gone deep now.
I would have given it one attempt, put a straight rod behind and tried to get the main segment out.
No, Dr. Paul, that will cause a lot of traction on the vitreous, not at all.
After vitrectomy.
Okay, that's my presentation.
Yeah.
Thank you for all your comments.
So, who else wants to present? Dr. Chitra, you wanted to present the video?
What? You called us for me?
Yeah, you wanted to present the video, no?
Yeah, I'll show you. A very simple situation, and as we all know, a nightmare in a cataract surgery can land on us on a most inopportune moment. And these are simple situations which I'm showing. Like this was a hard cataract with a last nuclear fragment, and there was sudden AC shallowing, and the nucleus started dropping into the vitreous, but then immediately could be brought up because it was very much there in the anterior vitreous, and there was actually no vitreous disturbance as of now. So the viscoelastic was injected so that the nucleus was right up, and because this was initially a 2.2 millimeter incision, the incision was enlarged to inject a 3-piece IOL, Now you could place the haptic of the IOL on the iris itself, or if you're able to have, there's a visibility there, then you could position it into the sulcus. And then of course it becomes a bit of an anterior chamber phacoemulsification, but it is better than having it sent to a retinal surgeon. We salvage that moment and then go back and clear the vitreous behind the IOL and remove the cortex and ensure that there is no aberrant vitreous strands. Bring the vitrectomy probe in front of the IOL, inject tricot to ensure that a complete vitrectomy is done, and then you have salvaged the moment. Now, this is again another situation of a very hypermature cataract, and the challenge in these cataracts is they do not have that epinucleus cushion or not even a cortex, and that becomes a major issue because you're not able to get a purchase of the phaco probe onto the nucleus, and it starts rotating in this fashion. So again, this is another situation wherein you could get your IOL up in front into the anterior chamber, inject viscoelastic to deepen the capsular bag, and then inject your single-piece IOL as was the plan of action, coat the endothelium with adequate vitreous, and this is a very small, soft nucleus, so you are able to easily emulsify it. So essentially, whether it's a small PCR or this kind of a situation or more different places, IOL scaffold finds its use and bails you out of a tricky moment in cataract surgery. Thank you very much.
Thank you, Dr. Chitra. Any comments from the panelists? Dr. Harshil?
Very nice videos, ma'am. Yeah, ma'am. But the technique which I love to do in these Morganian cataract is, get your chopper from the equator, hold it in the center and get it from, because the only issue is, yeah, it worked very well. Only issue is protecting the endothelium. No, then you need to put viscoat or some good OVD. You need to spend more money for that. So otherwise, if you try to chop it from equator, it works well. Yeah, hold it and get it in the center. Chop it, you can do it. But that's also a very good way, ma'am. Yeah, I was careful.
Harshil, do you have any video to play?
Yeah, of course. So I'll be showing one short. So at the outset, I'd like to thank Dr. Chala and Dr. Rishi Swarup for giving me this wonderful opportunity. Can you see my screen?
Yes. Your video we can't see.
Can you see the video?
No.
No.
You share the screen. Actually, you should share the screen and then play the video.
Yeah.
Why is that? Maybe you have to.
Dr. Parul, otherwise you can. Meanwhile, if you have a video, you can please share it.
Can you see my screen meanwhile?
Yes.
Yes. Yeah, I can start playing.
1 second. Yeah, can you see this?
Yes.
Okay, so what I'll do is these are just 2 short clips where I've put them up to open the discussion for when and how to use capsular tension ring or capsular hook. So this is a case of traumatic cataract with a huge zonular dialysis. There was vitreous already in the anterior chamber. So we are first, after staining, doing a tricot staining vitrectomy cutter, high cut speed, and remove the vitreous from that zonular dialysis. You can see almost from 7 o'clock till 11 o'clock is the dialysis here. It's an intumescent cataract, so the rexis, becomes a bit tricky. So you have to use the double shell technique. And once that is done, then most traumatic cataracts are softer and easier to remove, and we are pretty much out. So just that, in this case, we have used capsular hook, and in this one, I've used capsular tension rings. And then we'll throw open the discussion as to when to use which one. So this is again a young myope with subluxation wide almost 4 cloak hours. And here we are using the Sinskey assisted capsular tension ring as a support. And because the bag was pretty much stable, I could easily implant the lens in the bag, and I don't think we require to do the optic capture in this. So the idea was to ask the panelists what and when do we use two questions. When do we use capsular tension ring in zonular dialysis, and when capsular hook? And the second thing which we can just quickly discuss is what if it gives away, because these are tricky cases, and sometimes your bag gives away along with the CTR. So Dr. Chitra, would you?
Yeah, if it is a small dialysis, and it's always you could avoid delay the placement of a CTR to as long as you can. So if it is a small dialysis, it's a soft cataract, you could just use capsular hooks because it gives that anterior posterior support, and you can do a gentle phacoemulsification and then go ahead and place the CTR. But sometimes the situation, it's a small pupil, a very hard cataract, and you're not very sure about the extent of dialysis. In those kind of situations, it makes sense to place the CTR and then probably even use an additional support of capsular hooks also if you want, and then go ahead and do the surgery.
And one tricky thing with these dialysis and subluxation is, and I've had it twice, where the CTR is in the bag and your bag gives away. Now that's one very tricky thing, and how do you go about that?
No, that means that the area of dialysis was more than what the CTR could handle. Those are the cases wherein you should have put in a CTS also and had it, a scleral support should have been worked out. But sometimes it initially starts off as a small dialysis and you plan a CTR, and then during the course of the surgery, it becomes larger. So those are the times when a capsular hook always comes in handy along with the CTR.
So basically, capsular hook, they give the anterior posterior support, and CTR gives the equatorial support. No, so this is the basic difference.
I think one important thing is to have all the MST forceps scissors ready in any kind of zonular dialysis and subluxated.
Yeah. So
Harshul,
I'm ready, Dr. Chala. Yeah, I can share my video. Yes.
Yeah, sure.
Okay, so can you see my video now?
Yes.
Okay, so this was a case I'm doing under topical anesthesia. These are intumescent cataract, as you can see. So capsular access itself is challenging in these cases. So I go ahead and debulk the capsular bag, finish with the capsular access, then take off all the nucleus, and only little cortical matter which is there. So I'm just doing irrigation aspiration and do on one side, change my hands, and now look. So when I'm trying to aspirate this side, so all the zonules, they also, this is iatrogenic dialysis which has happened here. So now what is the plan next? I'd like to know from the panelist.
You should keep an infusion probe in and take out the aspiration probe and then inject viscoelastic so that and then immediately place the CTR and then complete your placement of IOL with the haptic in the area of dialysis.
Yeah, so the idea now is not to further extend it. So as ma'am said, you should be careful that you don't collapse the anterior chamber. So go ahead and put OVD before switching off the infusion. And once you put OVD, and then you go ahead and insert a CTR there. It is just to around 3 o'clock hour of dialysis. So I go from the side port and put this CTR ring and just give support of the Kugelin hook so that you can put this CTR nicely. So once you put this CTR, it gives the equatorial support to the weak zonules which are there. Go ahead and put IOL there. And now I can see that the rexis is a bit overlapping much on the optic. So I'm just enlarging the capsular rexis. And after that, take off, be careful, you take off the cortical matter nicely, and this finishes the case. So this was just a short video which I wanted to share of iatrogenic dialysis. Thank you very much.
Very nice video, Harshul.
Thank you, ma'am.
Actually, Harshul, have you heard of Arshinov, sideways Arshinov shell technique? So this works very beautifully when you have zonular dialysis, be either before or later. So this Arshinov doc said that do put dispersive OVD over the weak zonules, and then you put cohesive visco from the opposite side. So it just goes and jams up the area very well, as if there was no dialysis at all.
Yeah.
So that's a good technique to use either before or after, whenever you use it.
Yeah, but the message is, as ma'am said, whatever OVD you have, don't come out suddenly, so that you don't further exaggerate or increase. Yeah.
Beautiful
Thank
share.
There is a question to Dr. Chitra.
Yeah.
They're asking which OVD is preferable for IOL scaffolding technique.
Actually, you could use just a regular dispersive viscoelastic. In a case of that second situation, you could use a more a viscoat or similar. We want a better coating of the endothelium, but that should be all right.
Another question,
In the presence of PCR is when we need to plan whether you're going to leave the haptic on the iris or in the over the rexus. So that is the area of concern. And of course, any dispersive viscoelastic, you could keep refilling it also and continue with your surgery and keep your parameters low.
Dr. Anurag had asked one question. When I think it is directed to Fagan, actually. I don't know whether it's there. When we are using CTR, what is the necessity? Yes. So I feel CTR is more to give shape to the bag. CTS is to position it. There was a tilt in that particular lens. So to anchor it to the sclera, CTS is used. So I'll play my video on equatorial capsule rent. Dr. Vinay, Mr. Vinay, can you play it?
Yes, sir. Yes, sir.
Very interesting case here. So of course, this is a white mature cataract, and he's going to use the double rexus technique. He's going to make a small central capsulotomy. And notice this is done with just a paracentesis incision, so that the anterior chamber is highly pressurized. Then the second rexus can be done afterwards, and you can see that looks beautiful. Beautiful rexus here. Sculpting a central groove now for a stop and chop type procedure. Everything looks pretty routine in this case. So nice, good central groove, and then going to crack this and split it into two halves. And as a result of having a thick, fibrous posterior plate, you don't get a good separation here. So that's, you see the nucleus is split, but not centrally. So now more viscoelastics going inside the eye. And then he's going to use a couple of Sinskey hooks to do some manipulation, try to separate the nucleus. Here's where I want you to watch very carefully. As the two halves are separated, look how far apart they are. Look at that huge gap between the two pieces. Wow, where's the piece that's subincisional? There's that last bridge that's being broken. Now we have two fully separated halves. But where's the proximal heminucleus? It's under the iris in the subincisional space. Where did the nucleus go, the heminucleus? Well, half of the heminucleus has gone through a defect at the capsular bag equator. So the subincisional capsular bag equator. So the surgeon here, Dr. Chawla, is going to phacoaspirate and chop up the first heminucleus. They'll just take his time there. And again, the second heminucleus is still under the subincisional iris. Very unusual case. To have a break or a violation of the capsular bag at the equator is very unusual. I'm very thankful for Dr. Chawla for sending this case, because this is something you don't see very often, at best once every few thousand surgeries. So now only half the nucleus is gone. One heminucleus is gone. The second piece is still there, and it's underneath the subincisional iris. Look, it comes forward. As the anterior chamber is depressurized, that piece comes forward again. So as you pressurize, it disappears. So we need to get that piece up. Under the iris goes this Sinskey hook, and we're going to bring that piece centrally. And Dr. Chawla is going to just take his time here, and he's going to do a beautiful technique here. And it's still stuck. There's the heminucleus. You can see it. Now, we don't advocate fishing in the vitreous cavity. That's going to cause issues. But here he's doing it in a very safe manner, and the piece is not in the vitreous cavity. It's through that defect, but it's not floating in mid-vitreous. And here he successfully brought the second heminucleus up, more viscoelastic, create a barrier, keep that second heminucleus up. And he's also very smartly using that nasal angle, keeping that piece pushed against the nasal angle is very good because that prevents it from slipping through the pupil. We don't want that to happen. He actually has an intact central posterior capsule here. So there's the second heminucleus. It can now be emulsified. So this is a very unusual case. I'm really happy that we're able to watch and learn from this masterful technique. It's absolutely safe. Now, would I have faulted you if you said, just let the piece go back and have my vitreoretinal colleague do a pars plana lensectomy? No, that'd be perfectly fine. And in some cases, if you're unable to reach the piece, I agree. Let it go. Don't fish for it. So now that the nucleus is entirely removed, he's going to fill our capsular bag here. And he's going to insert the lens. So there's the viscoelastic being put in the eye. Here comes the IOL. Now, what are your options here? He's going to do a hydrophobic acrylic single-piece lens in the capsular bag. As long as you rotate it 90 degrees away from that defect, I think you'll be okay. Other options would be a 3-piece lens in the sulcus, again, with the haptics rotated 90 degrees away from the defect. And finally, at the end here, the viscoelastic can be removed. So very good technique. We really enjoyed this very unusual case. Again, capsule rupture or capsule defect at the capsular bag equator in the subincisional area. And half the nucleus disappeared and then came back. And at the end, it ended up beautifully. Thank you for watching.
Any comments from the panelists? Hello?
I think everybody is stunned. It was such a beautiful
No, I'm.
and we're trying to figure out where the gap was. When did it go and where did it come back from?
No, it could have been probably also a small dialysis there, and the nucleus fragment was keeping the bag stretched in that location. So, and there was no vitreous presenting, and then it was brought forward. Maybe in a situation like this, unless I'm able to visualize that PCR, I would have thought more chance of the nucleus, a small dialysis being there and the nucleus sinking in that location. I don't know what the other panel.
If there were to be dialysis, usually the posterior capsule will have some fold. Here the posterior capsule is taut because the equatorial region, the zones are holding the capsule both the front and back. So that's why the posterior capsule was taut throughout the procedure.
So did you see in the post-operative like pictures, like where was the defect exactly in posterior capsule?
No, that we need a high-speed ultrasound EBM.
Very good. Very interesting.
Very nice.
So there is some question here. I'll just see. What to do when CTR is not available? Can the haptic of the IOL serve the purpose in iatrogenic zonal dialysis? I think Dr. Harshal, you can answer regarding your case on this.
That extent of dialysis, a CTR, is absolutely mandatory. But if it were a very small dialysis, maybe the haptic of the IOL would suffice to hold it there. So you were not okay with that amount of dialysis and not placing a CTR, because immediately post-op the patient may be all right, but there would be an asymmetric back contracture and a decentered IOL in the later post-operative period.
Yeah. Or maybe, ma'am, if it's not available that time, you can, put an IOL and later on you can put a CTR afterwards. Maybe after a day or two.
I think time is up.
Yeah.
Yes.
Dr. Jennings is still to present, no?
She is not joined. She has some internet connection problem at her home. She called me just now.
Thank you very much,
Thank you all.
Dr.
Thank you.
Kalma and Dr.
Thank
Rishi
you.
Swarup for this wonderful 1 hour session and the opportunity given.
Thank you, everybody.
Thank you very much.
Thank you,
Thank you, Dr. Salam.
Thank
Hand over to Dr.
Swarup.
Kishore.
Thank you.
Kishore to take up the next session. Thank you, Dr. Parul.
Thank you.
Are the panelists and the presenters for the next session ready, please? Dr. Lalit, Dr. Gopal Raju, Dr. Vanita.
Yes, I'm there.
Yeah, Rishi. Yeah, so we begin our next session about 6 or 7 minutes late. We have a very good collection of surgeries, something which is very high fly, something which is to do with some machines which are not there still in most of the centers in India, and the basics also, like for most of the general practitioners. So we begin with Optiflex trifocal lens, which Dr. Lalit Kumar, who is director of the Amrit Cataract and LASIK Center from Chennai, is a young dynamic surgeon. And
thank you for the kind words, sir. Thank you.
Already into doing live surgery in so many places, so I thought he should be the right person to begin the proceedings.
Yes, sir. I will
start off with the process would be that you would demonstrate your surgery, and then it's a deferred surgery, means that ideally it should be totally unedited, but because of constraints of time, we have tried to edit it a bit, and then after the presentation we have a discussion for that particular case, and then we take the questions, if any, at the end of the session.
Sure, sir. Sure. Can everybody see my screen?
Yeah.
Perfect. Good afternoon to everybody. In the first place, I'd like to thank the Hyderabad Ophthalmic Association for giving me this opportunity, and I'll also like to thank Biotech for giving me this opportunity. I'll just start my presentation. Yeah. So a little bit about, before I go into the live surgery or the recorded surgery, I would just like to tell a few words about the Optiflex Trio lens. See, I've been using this lens for past 1.5 years, and it is a beautiful lens. And to come to the point, why do we need a trifocal lens? Basically, we need an acrylic IOL, which gives us good intermediate vision, like the plus 2.5 ad, which is available with some other companies. And it should also give us excellent near vision, like the plus 3.5 or plus 4 ads, which is again available with various companies. So this is a combination of both. So this gives you good distance, intermediate, and near vision, which is actually required in our real life situations. And after the advent of the trifocal lenses, I have literally stopped using multifocal or so-called bifocal lenses. Multifocal is actually a misnomer, and it is actually a bifocal lens which focuses for distance as well as for near. So now with the trifocal, it actually gives you a good range of vision for distance, for intermediate, and near. And I think my request or suggestion to everybody is, I think we should all shift over to trifocal lenses, and I'll just tell you why. In real life, there are a lot of studies have shown that most of the old age people access the internet through a desktop or a laptop. And the ideal distance which is required for this is roughly between 65 to 80 centimeters. Now that is the intermediate vision. So if you're going to implant a multifocal lens with a higher ad, this is not going to give you that intermediate range of vision. And I've seen a lot of surgeons doing this mix and match. So one eye, they have this higher ad, and the other eye, the dominant eye, they put the plus 2.5, which gives you good intermediate range of vision. So there are a lot of mix and match which was going on, and a lot of patients were very unsatisfied. Now, all this can be overcome by use of trifocal lenses. So I'm going to talk to you about the Trio, which I'm going to implant in this particular surgery. It's a hydrophobic lens with a natural chromophore, a yellow chromophore. It has a near addition of plus 3.5, which works beautifully well for a distance between 35 to 40 centimeters for near vision, and an intermediate ad of plus 1.85, which gives you a good intermediate vision between 65 to 80 centimeters. So to get a good outcome with a trifocal lens, we should follow these protocols very strictly. We should have a good accurate biometry. We should have a precise A constant, a personalized A constant, which you can customize for yourself after you do a series of multifocal lenses. And we should use a good IOL formula, preferably the Barrett's, which is the Barrett's Universal 2, which is the best formula. But apart from that, also you can have various formulas for hypermetropic eyes, for myopic eyes, for emetropic eyes. I'm not going to go into those details. A good dry eye workup is very, very important, because patients who have dry eyes don't have good quality of vision. So if a patient has a dry eyes, you can actually find out the cause of dry eyes, such as which can be MGD, and treat it, and then take up these patients for a multifocal or a trifocal implant, aberrometry workup, an angle kappa workup, and finally a good counseling of the patient has to be done. So I'm just going to show you surgery, which was where the Optiflex Trio was implanted. You can actually ask me in questions in between if you want. So this was a patient, a young patient with a NS grade 2 nucleus sclerosis, who was a slightly hypermetro patient. So according to me, there are 4 important things when you implant any IOL or any cataract surgery, which has to be done precisely. First thing is a good incision. That is very, very important. The main incision has to be very, very accurately made, and it can be as small sized as possible, because most of the companies have their phaco tips and sleeves which can go through a very small incision, which is as small as 1.8. The smaller the incision, the better the outcome. The second thing is a good rhexis, rhexis which is visually centered, which is centered to the visual axis. As you can see here, this is around 4.5 to 5 millimeter rhexis, which is nice and round, and it is centered to the Purkinje image, as you can see in this surgery. The third thing, as I was telling you, a good incision, which can be a biplanar or a triplanar incision. My preference is a triplanar incision, which I make it at the limbus, so that the healing is a little faster, and the astigmatism is also less. The other thing is you should do a good cortical cleaving hydrodissection, as you can see here, followed by hydrodelineation, which is my preferred technique, both in posterior polar cataracts as well as in soft cataracts. So if you do a good hydrodelineation, removal of a nucleus of a soft lens is easier. And you can follow any technique of your choice. You can do a stop and chop or a direct chop. My preferred technique is the stop and chop, where I actually divide the nucleus into 2 pieces, 2 heminuclei, and then chop it, as you can see here. Since it is a soft cataract, I'm just using a blunt chopper, and I'm doing the a mixture of a horizontal and a vertical chop. So I don't go to the extreme periphery. I just go to the edge of the rhexis margin, and from there I start chopping. So this is a variant of a horizontal cum vertical chop using a blunt chopper. So once I do these, I just eat the pieces one by one, as you can see here. And since I've done the hydrodelineation, you can see that there is a good residual epinucleus which is still there, which protects the PC from any damage. And make sure that whenever you do these premium IOLs, make sure that the cornea is clear, crystal clear, in the immediate post-op period. To have this, you can use higher molecular viscoelastic agents such as Viscoat, and I use this for all my cases to make sure that I protect the endothelium or coat the endothelium well. And these patients have crystal clear corneas, which is very, very essential when you're dealing with these patients who have very high expectations. Since they are paying more, their expectations are also more. And if you're going to give them crystal clear corneas on that day or the next day, they'll be very, very happy with the outcome. So I'm just removing the epinucleus. And once I'm done with that, I'm going to do the cortical aspiration. I usually do the subincisional cortex first, so that it is easier. Just in case if there is any adverse event during the surgery, it is always tough to remove the subincisional cortex first. So I just remove the subincisional cortex first, and then I go around in a clockwise manner to remove the cortex from all the other quadrants. And a very, very important tip when you are implanting these multifocal IOLs is, see, already these trifocal lenses or multifocal lenses, the light utilization is little less compared to a monofocal lens. A monofocal lens, the light utilization is around 96%, but with the trifocal lens or a multifocal lens, the light utilization is a little less. So if you have to make sure that you remove these cortical fibers by putting the machine in the polish mode, make sure you remove them meticulously, because even a little bit of these cortical fibers actually reduces the contrast sensitivity for the patient. And with the trio lens, the light utilization is a little more. It is around 88%, which is almost close to a monofocal lens. So the trifocals have better light utilization also, and particularly the Optiflex Trio, which is marketed by the biotech company, has a good light utilization compared to any other lens in the market. This has around 88% light utilization. So the injection system is very, very simple, as I just showed you in the video. It is a usual butterfly cartridge, and this butterfly cartridge actually goes through a 2.2 millimeter incision if you're going to do a wound assisted delivery of the IOL. And if you want to go inside the eye like I've done, you just have to extend the incision to maybe around 2.8 millimeters at the end of the surgery. So once the lens is inside, this lens behaves very well inside the eye. It's a very pliable lens. It is and the injection system is also very, very smooth. So it doesn't inject inside the eye with any jerk. So the injection system is smooth, and once the lens is inside the eye, you can manipulate the lens very, very nicely inside the eye. It is a very, very soft and very, very nice lens, and it has a square edge design, which reduces the incidence of PCO also post-operatively. Make sure you remove all the viscoelastic agent from behind the lens and hydrate the wound. Since it was a triplanar incision, you can see that the chamber is formed very, very well with a very minimal hydration. Now that is the advantage when you use a triplanar incision. So that brings me to the end of the surgery. And I would also like to share my experience with the Optiflex Trio. We implanted the Optiflex Trio in around 59 patients. If I'm out of time, just let me know, Nandkishore sir. You can just raise your hand and I'll stop my presentation. So there are, this was implanted in around 59 patients, out of which 25 were females and 34 were males. 31 patients had bilateral implantation, out of which 14 cases underwent a femtosecond cataract surgery using the Lensex machine. 30 patients had around 2.2 millimeter incision, and 29 patients had 2.8 millimeter incisions. A patient was followed up on first postoperative day, 10th postoperative day, and 45th postoperative day. The distance vision and near vision were checked with Snellen's chart. The intermediate vision was checked with something called a good light chart, which is a good chart which you can use for checking your intermediate vision. And the contrast sensitivity was checked using the Apasami contrast sensitivity chart, which is measured in percentage. I'll show you that this thing. A subjective questionnaire was also given to the patient regarding their distance vision, intermediate vision, near vision, and about photophenomena such as glare and halos, and also their spectacle dependency for distance, intermediate, and near vision, whether they had any dependence, and they had to just say yes or no. So out of which 91% of the patients had uncorrected visual acuity of 6.6 partial and 6.9 on first postoperative day. On a post-op 45th day, around 90% had uncorrected visual acuity of N6 to N8, and the postoperative intermediate vision. This was all on 45th postoperative day, not on first postoperative day. 94% of the patient had intermediate vision of 6.9 at a distance which I just varied between 65 to 80 centimeters. And the femtosecond cataract patients had a little better outcome because the centration of the lens was excellent because of the rhexis. The rhexis was always well centered in these patients who underwent femtosecond cataract surgery, and hence they said that their visual quality was a little better compared to the regular phacoemulsification patients. 82% of the patient had contrast sensitivity of around 10%, and 100% of the patients had contrast sensitivity of 20%, as you can see in this chart. This is the Apasami contrast sensitivity chart, which gives the contrast sensitivity in percentage. The subjective questionnaire also gave us very good results. Around 70% of the patients said that they were very, very satisfied with their distance vision, and around distance vision, intermediate vision, as well as near vision. Around 20 to 25% patients said that they were satisfied for all distance, intermediate, and near vision. Their satisfaction level was good, and satisfactory outcomes was only in around 7 to 8% of the patients, but they said they were just satisfied. They were not very, very happy, or they were not good. And poor outcomes was not, none of the single patients said that they had poor outcome with this particular lens. And the photic phenomenon or complaints also were very, very less. 6% of the patients said they experienced some kind of glare, and 3% of the patients said that they experienced a little bit of halos. So 95% of the patients did not have photic phenomenon. So the photic phenomenon is also very, very less in these patients. The reason being, this is a slight because the central button or the central zone is a little larger compared to the other multifocal lens. The central zone is around 1.16 microns in size compared to the multifocal where it is only 0.86 microns in size. So definitely the central zone is slightly larger, and this also compensates for the angle kappa, the borderline angle kappa patients. So this is a much more forgiving lens compared to a multifocal lens. The Optiflex Trio particularly has a slightly larger central zone, which is very advantageous for patients who have these borderline angle kappa. I take angle kappa measurement of anybody who has above 0.5. I generally don't recommend a multifocal lens, and anybody above around 0.5, 0.4, a trifocal works beautifully well because angle kappa compensation is taken care by a trifocal lens. A little bit about counseling before I finish. It is very, very important to understand the visual requirements of our patients. So we can strike a conversation asking him about his profession, his hobbies, because if he has a very active lifestyle, or if he sits on the computer for a longer time, like a person who works in a bank who sits in front of a desktop, he will definitely benefit with a trifocal lens. Give them options, but definitely recommend your choice. Because if we just tell the patient, you choose whatever you want, they're not convinced. So definitely tell them that if it was your father or if it was your mother or if it was your relative, definitely trifocal lens would be your lens of choice. Because if you tell them, they are more convinced that way, and then definitely it will help them in making a decision. Promise them glass independence and not freedom from glasses. So that is very, very important. And the same thing goes with my last this thing also. Always under promise and over deliver. Train your counselors and optometrists to inculcate interest in these patients. So if any patient has any cataract, just make a small mention in your case sheet. And when the patient goes to the optometrist, always tell them that, just put in a word to these patients about trifocal lenses and how they will not need glasses all the time. Or maybe they won't even require glasses if the trifocal lenses are implanted. Talk about economical viability. This is something which I talk to all my patients. So tell them that, if you're going to, come for regular checkup, and if we are going to implant a monofocal lens in your eye, you'll have to change your glasses every 2 to 3 years. And the cost of progressive, if put together, maybe in 20 years, you are actually going to spend the same amount what you're going to spend for a trifocal lens. So just put that message across to them. And definitely you'll see. After I have started using the trifocal lenses in past 2 to 3 years, I would say that almost 25 to 30% or even maybe 40% of my practice is multifocal now. So you just have to spend a little more chair time. You have to tell your counselors that they have to talk a little more to the patients regarding the trifocals, and you'll see that your practice is going to the next level. Thank you.
Yeah, Dr. Lalit, thank you very much for a wonderful surgery. Dr. LVK Raju, who is also a young, dynamic, prolific surgeon, would be the discussant for this case. And probably I should have told this before. I think we restrict ourselves to more surgery and then less discussion so that the questions can be asked. Sorry for that.
15 minutes, sir. So I thought at least, something about the lens I should, and a little bit about the counseling and everything. I just wanted to.
Dr. Raju, you want to?
Dr. Lalit, it was excellent video presentation.
Thank you.
Your voice is breaking, Dr. Raju. So,
Dr. Lalit, I congratulate for your excellent video presentation.
Thank you.
How do you select the power of IOL? How do you select the power of the IOL?
Okay. Sir, I generally...
Is it any different from the monofocals?
No, sir. Sir, can you hear me, sir? Sir, when I used to implant multifocal lenses, I used to make the patient a little myopic. Say maybe the dominant I used to make them emmetropic, and the non-dominant I used to make them a little myopic, 0.5 to maximum 0.75. But with the trifocals, I generally aim for emetropia because it gives you very good results if you aim for emetropia, provided you follow the Barrett's Universal 2. See, not everybody has, even I don't have a Barrett's Universal 2 incorporated in my machine because I'm still using the IOL Master 500. But if you're really interested, you can actually take this data, go to the internet, actually calculate with the calculate for the Barrett's Universal 2 formula. And if you use that formula, which works beautifully well for all eyes, and you get excellent results. So I aim for emetropic correction rather than myopia or hypermetropia in all my trifocal patients.
Rishi, anything you want to ask?
No, I think he has covered it very well, and beautiful surgery. Congratulations.
Thank you. Thank you. Nice to see you, Dr. Rishi.
Yeah, so we move on to the next surgery, which is basically a demonstration of the new variant of the Centurion machine. Incidentally, only Dr. Gopal Raju has it from both Andhra and Telangana. I don't know how many machines are there in India. So just to give a brief introduction, by the time Gopal gets ready, Gopal has done his medicine from Rangaraya, then post-graduation from the RP Center. Then he has also done fellowship in cornea and anterior segment from Madurai, plus an additional fellowship from Spain in refractive surgery. We have been together quite a lot during the days of combined APOS conferences. He has been editor for 2 consecutive terms, and he's been the chairman scientific committee of the newly formed AP Ophthalmological Society. He's a great surgeon. He's been running a hospital, Vishaka Hospital, which does a lot of, apart from regular surgeries, they do a lot of camps and free service also. I present to you Gopal. I don't think Gopal needs much introduction. Gopal, are you ready? Please unmute yourself. Yeah, Gopal.
Can you hear me?
Yeah, we can hear you.
Can you see my slides?
Yeah, we can see your slides. The audio is not very clear.
Yeah, the slides are moving? The slides are moving?
There is an echo, Gopal.
Sir, please remove your headphone from your system.
You can remove the headphone. You can directly talk into the audio of the computer.
Can you hear me now?
Better.
Can you hear me now?
Yeah, it's much better. Gopal, go ahead. And we would like to see the surgery more and the slides less.
Yeah. Good afternoon, all of you. I think first I should congratulate the HOA for organizing the virtual meeting. And also congratulate the team HOA and thank all the HOA team and the other people for giving us the opportunity. This is a new advancement in the Alcon basket. I have no financial interest. If you see the journey of the phacoemulsification systems overall, we have moved from the console crude basic machines to a basic smart machines, then ultrasound delivery also from the traditional warm phaco to a cold emulsification. Fluidics also we moved from the gravity fed to active fluidics, and then the current machines undergo fine tuning mainly to increase the safety aspect. So this is the overall journey of the machines, and this is the journey from the Alcon, from the Universal 2 to Legacy to Infinity to Centurion. And the Centurion now they have moved to active century handpiece. This is another evolution of the fluidics. from the gravity fluidics to pressurized fluidics to active fluidics technology. Now with the active fluidics and the active century handpiece. Coming to the normal handpiece, what is the main difference between the active century handpiece and the normal handpiece? The normal handpiece, the good pressure controls and the sensors at the level of the machines in the cassettes. And there is some time lag between response from the but still they are very safe. You see the response of the gravity fluidics and the active fluidics. The active fluidics perform much better than the gravity fluidics, where the IOP can be controlled separately.
Gopal, we are not able to hear you.
Can you hear me now?
Yes, yes.
Coming to the active century handpiece, it has got the pressure sensors at the level of the handpiece. So naturally the time response is very short, and the feedback is very efficient to the machine, and the fluid displacement is very, very less and very early. To brief you about what is active century handpiece, it's a featuring is a built-in sensors are there in the handpiece itself, and so it's very effectively controls the surge protection and then stability from the starting to the finishing. So there is one more when the sensor is responding from the handpiece, there is additional quick valve response technology is incorporated in the cassette, so by which the entire response and the surge protection and then the volume replacement happens. I'll show you the video. So basically, all the incorporations are in the active century handpiece. It has got a signals to the Centurion Vision System hardware and software. So the fluid pressure sensor detects the changes in the anterior chamber, and the active fluidic technology will compensate the whatever the loss by through the quick valve technology. And this is the highly updated and flexible tubing version. So this is the difference between the earlier the handpieces in the Infinity system and the active century system. The amount of fluid displaced is much less in the active century system. So this is a short video about how so you have a active century software. So you have additional sensor in the handpiece. So basically it's a live real-time monitoring of the eye directly. From the eye anterior chamber, it directly monitors the intraocular pressure. So pressure sensor is maintained in the handpiece and maintains the leakage and all the so we need not adjust the patient eye level. So real-time monitoring of the intraocular pressure. So by which we can very efficiently and safely. The main advantage is we can perform the surgery at a much lower IOP. Earlier we were doing with the 50 IOP. Now we can reduce to 35, 30, and even some of the cases around 25. So coming to the real case, I'll show you how the low IOP, the surgery can be performed under the low IOP conditions. So this is a soft cataract. So with the integration of the Varian, they can guide us how to do the rexes. So you can see the IOP at 36. So even at the 36, we can safely perform the phacoemulsification very efficiently and with a very efficient surge control. The chamber will be deep. So you can see in this case, there were 6 times the active sentry was activated. So that will show us how many times it has mitigated, because all the time it will not be active. Whenever the chamber is collapsing beyond the certain level, then the active sentry mitigation happens. So at the end of the surgery,
the video frame has is in a freeze mode. We couldn't actually see the times the sentry responded. So maybe Vinay, anything to do with
Sir, you will have to click on the optimize screen sharing. You can stop sharing
optimize
now.
screen sharing, I think.
So just stop share and reshare. You can share again now, sir. While sharing, you will have to click on optimize screen sharing for video clip.
yeah, right. Yeah, can you see now?
Yeah, we can see now. Go to the videos.
Yeah.
The slides are not moving.
So I think your internet is a little slow. Sir, you'll have to share again, sir.
Okay. Can you see now? Can you see the video now?
Yes, sir. You can play it now, sir.
Rupak, can you hear me?
Yeah, we can hear you, but the video was not playing properly. We could only see it in pieces. Vinay, can we do something about it, or should we proceed?
Sir, you can send us the presentation, sir. We will play after next talk.
Yeah, next talk will.
Yes, you can mail us the presentation.
Gopal, you can just mail the presentation to them.
Okay, otherwise I'll just share the video now.
Yeah. Yeah, if it is ready, just go ahead.
Yeah, it's ready.
Sir, I think your internet is very slow, so it will not work properly. You can share the presentation with us, sir.
No, this is a large video. It's very difficult. Yeah, we will try sharing the video now.
Sir, you play the video and stop your video, sir, so that it can be a little smoother. You share the video and the presentation and stop your live streaming video, sir.
Gopal?
Yeah.
I think we are running short of time.
Okay,
so
okay.
Try to see if you can send it across, and we'll go on to the next video.
Okay.
Huh? Rishi, are you ready?
Send it across.
Yes, I'm ready.
Yeah. Before you start, I think Rishi doesn't need any introduction. He's done his medical school from Manipal, and then his diploma from CMC Vellore. After that, he has been through various fellowships. He has finished his FRCS. I think he is one of the youngest and most actively sought after corneal surgeons today in the country. He's been faculty at various national and international conferences. He's a regular instructor for Big Bubble Technique in so many international conferences, and we are proud that he is our General Secretary. HOA, he's been primarily responsible for charting out the scientific program of this particular conference. And he will be demonstrating to you pterygium surgery, which is very, very important to all the comprehensive ophthalmologists. Rishi?
Is my video visible?
Yeah.
Sharpness
Okay, so this is a patient of a fleshy pterygium, and this patient also had a conjunctival nevus, which was there before he developed that pterygium, so that kind of got pulled onto the cornea. So as you can see, we are doing a simple pterygium excision in here, and I just thought I'll show a simple surgery because this is the most common thing that everybody sees in the clinic. So my approach to pterygium is, first you have to incise the conjunctival epithelium, only the epithelium right behind the head. In this case, I'm going a little more posterior than I would normally incise the epithelium. Normally it would be just behind the head, but here because we have that nevus also, I decided to kind of incise just behind that. After you've made an incision on the epithelium, you should hold the epithelium up and tent it upwards, as is being shown here, and then use a sharp scissor to kind of just dissect these attachments from the separating the conjunctival epithelium from the subepithelial fibrovascular tissue, which is the basic mass of the pterygium. Essentially, what one must remember is that in a pterygium, it's not the epithelium that is unhealthy. The epithelium may be unhealthy only at the head of the pterygium. But
can the screen be adjusted a bit?
What's happening?
We are seeing the lid more than the cornea and the pterygium.
Yeah, unfortunately, this part of the video is like that. It's going to get better. So as I want to, what I want to show you is that the conjunctival epithelium is essentially, is the video running smoothly?
Yeah, it is running smoothly.
Yeah. So I'll just pause here once. So basically what I wanted to show is that you have to reflect the epithelium of the fibrovascular tissue of the pterygium, because the epithelium is essentially healthy. So the only epithelium you need to really sacrifice is right next to the head. And behind that, just reflect the epithelium off. The next important, so you keep reflecting the epithelium as far back posteriorly as possible, maybe even up to the fornix. I've already done that step. Now the next step is to identify the wings of the pterygium. You can see the superior wing has just been delineated. Okay, so you kind of expose the sclera in that area. Okay, so the sides of the epithelium are being incised, and you can see that wing is nicely delineated. So you kind of dissect the epithelium off it, and then you put any blunt instrument underneath it also to kind of separate the wing from the anterior and posterior tissues. So in this case, now we are kind of lifting the wing up and breaking the attachments from the sclera, and just kind of dissecting the edge of the wing off from the epithelium and the sclera, so that it stands out separately. I'm not cutting the entire pterygium, just the edge of the wing, so that it's easy to grasp the rest of the pterygium. The superior wing is now done. Now, hopefully the camera is going to get a bit better centered. So you can see we have incised the epithelium and reflected it all the way there. And now the inferior wing is being delineated. Okay, so basically you expose the sclera in that area. So you use your scissor, go into the wing and open the scissor there. Okay, now I'm kind of gently breaking all the attachments between the fibrovascular tissue and the epithelium, whatever is visible in that area, pulling the cornea away from that area so that more of the wing can be exposed, putting the scissor there to kind of delineate the wing more. So you can see the large area of the wing of the pterygium is being exposed, and the sclera is now visible, superior and inferior part of the pterygium where the wings are located. So this is the next step. So first is to incise the epithelium and reflect it. Second is to expose the wings of the pterygium. Now you have to basically lift the head of the pterygium off the cornea. Now this is a potential space. So if you just grasp the head of the pterygium with a good tooth forceps and use a sharp blade like this, in this case I'm using a number 15 blade with a perpendicular strokes on the cornea so that you don't cut into the stroma of the cornea, and under traction the whole kind of lesion comes off, especially in the primary pterygium, it comes off quite well. So start from one wing and start peeling the whole head off till you come to the superior wing. This is typically how I do it. And you basically are using that tangential kind of movement of the number 15 blade to dissect the whole thing off without cutting into the stroma or the sclera. So this way it's very safe. You are just breaking the attachments without damaging the underlying tissues. So now the entire fibrovascular mass has been peeled off the sclera, and basically you use kind of semi-sharp dissection here to kind of separate the attachments from the underlying sclera and the fibrovascular tissue surrounding the muscles, the muscle sheath, etc. You make sure that you can see what you're doing. Don't accidentally cut the muscle. So if you have any attachments with the muscle, it's a good idea to hook the muscle with a muscle hook and then separate those attachments using a scissor. So in this case, we are using a cotton bud to kind of just separate the attachments all around. You can see the fleshy mass is actually much, much larger than what is visible in primary examination when you see the pterygium. It looks very small, but the pterygium actually extends way back. And it's important to keep dissecting as far back as you can, because if you remove this entire mass, you get a good cosmetic result. So you can see I'm pulling with the forceps and then breaking those attachments as I'm seeing them, making sure I don't damage the muscle, both behind the pterygium and also anterior to it. And now I'm using a large a scissor to kind of just cut from both ends and come towards the central part in the end. Okay, so you tent and pull and then cut as far back as possible. Just remember that at the nasal edge, you have the caruncle and that tends to bleed. So don't cut beyond the caruncle, otherwise you'll have a lot of intraocular bleeding, and even post-operatively you can have hemorrhage. So you want to just stop short of the caruncle. So you can see the entire fibrovascular mass is now being nicely there. You can see the medial rectus muscle there. You have to be very careful here. You can sever the attachments under direct visualization. If you have a good assistant who can keep mopping that area, it's always a good idea to do that. And then tent up the fibrovascular mass and cut as far back posteriorly as you can. So you can see we've removed the entire thing. And once you've done that, actually, the epithelium is quite mobile. You can actually move it, and you could even do a sliding closure in most cases. But it's always a good idea to put a graft. That is the best way to prevent a recurrence. Now, people do all kinds of grafts. You can do a sliding closure, you can do a rotational autograft. But I think the simplest thing to do is a conjunctival autograft. Some people also like to use limbal tissue, but I found that it doesn't really make any difference. In fact, a lot of studies have shown that including limbal tissue doesn't really make much difference, and you will unnecessarily be sacrificing limbal tissue from the donor side. So you can just take a conjunctival autograft and put it in the location of the excised pterygium. Now this is important. You can use again a number 15 blade in the perpendicular direction to remove all those little attachments which may be there of the pterygium. So do perpendicular scraping like this, and you can see the whole surface can be cleaned up. If you have any small tissues which are stuck, you can use the tooth forceps to kind of peel them off so that the underlying bed is very clean. This is very important to prevent recurrences. A good dissection is, I think, the most important thing. Second thing is you can do a little bit of cauterization near the limbus. So any blood vessels, etc., and any loose tissue will get cauterized. And then again, you can stroke with a perpendicular blade to remove all those loose attachments. If you have any big vessels there, you can cauterize the vessels, but don't overdo the cautery. If you overdo the cautery, that can induce postoperative inflammation, induce release of cytokines like transforming growth factor beta, which can result in a recurrence. So I'm purposely showing you a minimally edited video so that, that's the idea of a deferred life surgery. You can see exactly what is being done at each step rather than just seeing the highlights. Okay, so now the pterygium has been completely removed. Now we are going to harvest the donor graft. So my assistant is turning the eye down to the cotton bud, and you can use a sharp scissor like this to just make a little incision on the conjunctival epithelium. Please don't cut the tenons, only the epithelium. You want the graft to be only epithelium thick as far as possible, or minimal tenons. So use a scissor to make an incision and just short of the limbus, and then you insert the scissor just beneath the epithelium and do a dissection like this. Go in with closed blades and then open it underneath. And you could mark the size of your donor site and then do it, but I've found that I'm usually quite accurate by doing an eyeballing kind of sizing. So I'm kind of taking a rectangular graft. You can see that I'm going far back posteriorly because we have a lot of tissue there, but width is limited. So you put the graft, the conjunctiva, donor conjunctiva onto the cornea like this, and then you cut the edges like so. So you can see there's very minimal tenons on this, and you can pull the tenons back and cut it with the scissor like this. So pull it back and cut. Especially if you want to take limbal tissue, this is a good idea. Then you reflect it back in its place, and then gently you cut it, but just stop short of the end. The last bit should be cut in the end, otherwise your tissue can get crumpled up like this. And then you can just slide it, maintaining the limbal orientation of the graft so that it doesn't lose its orientation. You can take it to the recipient site and see if it fits well. You can see it's approximating quite well, so I'm quite happy with the sizing. Now I'm going to pull it onto the cornea with the donor basement membrane side facing down, epithelial side facing up. And now we are ready to apply fibrin glue. You could also just use a patient's own autologous blood that also contains fibrin. That works quite well, but you need to hold it for a longer time. So we can use fibrinogen and thrombin separately in 2 different needles. That's how I like to do it. I just put it in one area at the recipient site in the bed. First the thrombin and then the fibrinogen. Fibrinogen is a little thicker. And then we just basically slide the conjunctival graft into the space, and then you have to spread it out with 2 forceps like so. so that there's no glue stuck underneath it. Open it completely and then approximate the edges of the donor recipient site to the edges of the conjunctival graft like I'm showing in the video. After that has been done, you'll have these little bubbles in the fibrin glue. Don't bother about them. We can remove them later. You'll have these little blood clots. Leave everything. Once it kind of the glue has formed properly, then you can remove all these blood clots and bubbles, etc. So give a few seconds for it to move, kind of to get stuck, and then you go to the donor site. Even this side, you can put fibrin glue in the same way. First thrombin and then fibrinogen. And then you just approximate the edge using a forceps, hold it there for a few seconds. Again, because you have a lot of glue underneath, if you don't remove it, it'll form a big lump over there. So you can use a cotton bud or a spatula to squeeze out the excess glue from underneath the conjunctiva, like is being done by my nurse here. She's squeezing out the excess glue and at the same time removing the excess blood fibrin from the limbal edge. Okay. So now basically after a few seconds, everything is stuck in place. So you could leave it as it is, or you could put a bandage contact lens to cover that epithelial defect. In this particular case, we were using amniotic membrane for another patient. So I had some amniotic membrane. So I decided to use amniotic membrane to cover the donor site in this area. So I've just put it there, cut it to slightly larger than the desired size. They reflected that area. Then I'll just apply fibrin glue again. Put the amniotic membrane back like so. Stretch it out and then amniotic membrane. Only the area of the epithelial defect is covered. Give some time for it to stick. You can use a spatula like this also to spread it out so that there's no excess glue. Excess glue prevents adhesion. You can see this scissors being used to just trim out the excess amniotic membrane graft. So essentially that's it. You could put a bandage contact lens on top of this to make sure that the amniotic membrane doesn't get displaced. And basically it acts like a biological contact lens by itself and aids in healing. So that's basically it.
That was an excellent step-by-step demonstration of how to do a autologous graft. Rishi, what would you prefer? I mean, like considering the cost factor, and unless you have multiple cases, glue works out a bit expensive. So how about using autologous serum, except that you have to use it for more time?
Yeah, autologous
Does
blood
it
also
really
works
make
well,
a difference?
but sometimes it doesn't stick so well. So make sure that it's stuck well at the end. But otherwise, that's also perfectly fine.
And
what we do
in
in our
that
practice,
case, if you are trying to use autologous serum, then do you still go ahead and do cauterization, or you just try to
you do minimal cautery. You want a little bit of bleeding actually.
Yeah. So
if they are big bleeders, you cauterize only those. But ooze, you leave it.
Okay. Anybody else? Any of the other panelists want to ask?
I do is we reuse the vial actually, although it's not ideal.
Yeah.
But like we use Avastin vials, you clean the surface with alcohol before you draw again, and every time we are drawing with a fresh needle. So that's the way we use it for up to a week now, and then we discard it. So that's another way, and it's because it's not an intraocular procedure, I guess you could do it. But ideally, yes, you should either pool cases or use one for a case.
Gopal or Vanita want to ask some questions on this? Raju?
It was wonderful surgery, Rishi.
Thank you, sir.
I think maybe the dissection of the tenon. Once if you reach the orbital fat, you can just limit at that stage.
Yeah. So yeah, you shouldn't go to the orbit or beyond the caruncle. Otherwise, you'll start getting into trouble. Once you see fat, it's not good news.
Yeah. The number two.
What about how about the blood vessels?
Which blood vessels?
To cauterize.
Yeah. So you can cauterize the big
the blood vessels
you can cauterize the big bleeders, but don't overdo the cautery because that itself will be a stimulus for recurrence.
Gopal was saying something.
You can avoid the cautery completely.
You could do that also. But sometimes you have some big bleeders, If you have a lot of blood clot, the graft will not adhere well.
Yeah. Number three. See, I use just 4 Tanjiro sutures in the 4 corners.
Yeah,
so
you could use sutures in the corners as well for proper edge-to-edge apposition. A lot of people do that.
Yeah, just apply only three knots. So they invariably fall off by about first week or by 10th day.
But I really don't feel the need for it, sir, because I mean, with the fibrin glue, you really hardly ever get any displacements.
Not to save the cost of the surgery, because the pterygium invariably it's a poor-man surgery.
Of course, you can use a suture. No worries.
But to Tanjiro, avoid vitriol, so it can attract vessels and then form a granulation.
Yes. Especially if you're using autologous blood, it's a good idea to just put a couple of sutures. At least at the corneal edge, you can use it.
Yes.
We'll in view of the shortage of time, we'll go on to the next surgery. I think there's nobody better than Dr. Vanitha to demonstrate trabeculectomy step by step. Vanitha is a senior consultant in glaucoma and the cataract specialist at the Center for Sight in Hyderabad, and also Neo-Retina Eye Care. She was trained under the world famous glaucoma specialist, Dr. A.K. Ahmed, and she is a keen innovator. She has won multiple awards. She has won multiple awards both at the state level as well as at the AIOS level. And I personally remember that I was one of the judges when she won the award. So her videos are a treat to watch. And I'm sure everybody would benefit from seeing her surgeries.
Nandkishore, she's won at international level also.
That's what I said. So presenting to you, Dr. Vanitha Pathakwe.
Thank you so much, Dr. Nandakishore, and Rishi as well, and great surgery, Rishi. I just wanted to make one point there. If you're leaving tenons in your the site where you're taking the graft from, why do you need to use either glue or suture? I use conjunctival autograft fairly commonly for bleb repairs and so on and so forth, and we leave the site to heal on its own, and it's
most of the time it's not a problem, Dr. Vanitha, but sometimes you'll get these kind of outgrowths of the tenon, which is basically a pyogenic granuloma at the donor site, which is kind of annoying. Well, also the healing is slower, so the patient will have some discomfort post-op. If you close that site, they become more comfortable faster.
Okay, that's good to know, because obviously I don't do pterygium surgery. At least I can't remember one having done a long time ago. But definitely, then I will try and close. See, we learn something every day. Thank you very much. Okay, so to my presentation, I actually, if you say deferred trabeculectomy, then I cannot show you the nuances that can be used at the same time in several cases. So what I've done is I've actually recorded a video. It's got a voiceover. But before we start, let me just say that I don't have any relevant financial disclosures. We all know trabeculectomy is the most frequent surgery performed, especially in a country like ours, and especially in advanced glaucoma. You don't have a choice. But survival of filtration over the decades has increased simply because we have now learned to use adjuvants sensibly and judiciously, and we may also use that biocompatible collagen matrix called Ologen.
Where choice of anesthesia is concerned, retrobulbar should be avoided, in my opinion. And if you use peribulbar, it should be low volume, simply because you do not want the optic nerve, the bolus of the anesthetic fluid to damage your optic nerve either. And if you're using subtenons, you should be well away from your surgical site, preferably in the inferonasal quadrant. What I prefer is topical anesthesia, and I have been doing so for the last maybe 6-7 years. So I avoid any kind of bolus local anesthetic. And I also avoid stay sutures, especially superior rectus. If one is required, I'm not saying everyone can do without it, you can use 8-0 clear corneal stay sutures. So we'll start the video, and then I'll briefly also present my results. Step-by-step trabeculectomy. Choice of anesthesia for trabeculectomy in adults is usually peribulbar. Approximately 6 years has been under topical anesthesia. I start by preparing the patient in the pre-op area for injected mitomycin C. Paracaine and betadine is used 3 times 10 minutes apart. In a 1 ml syringe, I load 0.05 ml of lignocaine 2% and 0.05 ml of freshly reconstituted 0.4 milligram per ml concentration of mitomycin C for a final concentration of 0.02%. This is then injected subconjunctivally 8 to 10 millimeters above the superior limbus, and cotton tip buds are used to spread it diffusely over superior bulbar conjunctiva. Patient is then shifted to the OR, and the surgery is performed under sterile conditions. Conjunctival mobility is confirmed, and a peritomy is done 1 to 1.5 millimeters from the limbus, leaving a conjunctival frill, wound length usually of 3 millimeters. Deep conjunctival pockets are made by opening up and spreading the scissors. Gentle, non-charring cautery is done. Sclera is then held with a fine tooth forceps, and a number 11 blade is used to create a scratch incision parallel to the limbus for about 3 millimeters. A crescent blade is used for tunneling well into clear cornea. The sides are released well short of the limbus. Under the scleral flap, clear cornea should be visible. In all cases of injected mitomycin C, I additionally use a sponge-soaked MMC under the scleral flap, usually for 1 minute, avoiding the wound edges. And wash thoroughly after removal. However, if only sponge MMC is done, then 4 sponges are ideal. Three are placed deep into the conjunctival pockets. And 1 under the scleral flap for a duration of 2 to 4 minutes as determined clinically. Back to our adult patient, a paracentesis is done. And viscoelastic injected. AC is then entered under the scleral flap. And ostium is punched with a Kelly's Decimase punch. Followed by a peripheral iridectomy. Two 10-0 nylon sutures are then placed at the corners of the scleral flap. The first, step by step the first suture is tied off normotensive, that is, neither loose nor tight. It is the second suture that is titrated for filtration. And then tied off. Both sutures are buried. The technique of releasable is documented in a case of congenital glaucoma, and this is done via a corneal loop. A bite is taken from under the conjunctival frill into cornea, and another one retracing these steps. Following this, a bite is taken from the scleral flap to the sclera and tied off only with 4 throws. Back to our adult patient, Ologen was used in this case. And conjunctival closure was done with 10-0 vicryl in a continuous mattress technique. Such a construction of a conjunctival wound avoids limbal stem cells, and such a closure helps to avoid conjunctivalization of the cornea, affording a good bleb morphology in the post-operative period, examples of which are included at the end of the video. The conjunctival suture is tied off at the end with a loop, which is also squeezed to make the wound watertight. The bleb is then raised and wound reconfirmed for watertightness.
Can we go through fast? Because we have just 10 minutes left and one more video is to be played.
Yeah, sure. This is the end almost. So such as conjunctival technique, what it does, suturing technique, what it does is it avoids these kind of overhanging plebs. Right, done.
That was an excellent presentation. I could understand by now what you meant when you said your technique is slightly different. It was very, very nice and very informative. Anybody wants to ask just one question before we go on to Dr. Nandini's video? Okay. Dr. Nandini, are you ready?
Yes, sir. I'll go ahead and share my video.
Yeah, Dr. Nandini is a consultant from LV Prasad Eye Institute. She is apart from her specialty training in oculoplastics from LV Prasad, she has also finished an observer course from KM Hospital, Mumbai. And she has been with LV Prasad Eye Institute from July 2016. She is spoken of very highly by Dr. Javed Ali. So that gives you an indication of what her capabilities are. And I think we will learn quite a lot. I would request you to go through your video as fast as possible in view of the short time we have.
Yes, thank you, Dr. Nandikishore. So I'll keep it directly to the video. Now, this external dacrocystorhinostomy is essentially a very simple surgery once we understand the anatomy. So before I begin the video, our patient is actually under general anesthesia, but I would be covering certain nerve blocks and infiltration anesthesia that is required if you are taking the patient under local anesthesia. All right. So it is always imperative to confirm the finding, either do a syringing or check Roplas whenever it is positive, confirm the site that you're operating. Once you've confirmed, we go ahead and mark the incision. So what we do is We palpate in the area of the anterior lacrimal crest and we mark the incision there. Now we give an infraorbital nerve block, which is about 1 centimeter below the infraorbital rim and 1 centimeter lateral to the nose. That is the easiest landmark that we can remember. We infiltrate about 1 ml in that area. Then we give an infratrochlear nerve block, which you have to first palpate the supraorbital notch, and you take the center of the bridge of the nose. And just between the two is the landmark where you would infiltrate the for the infratrochlear nerve. So we again inject 1 ml of fluid of our anesthetic agent there. Then we give what is called as the ethmoidal nerve block. Now I'm really sorry for the angle. It's pretty difficult to shoot a DCR video with the angles differing in different steps. So for the ethmoidal nerve block, as we could see here, we have to open both the eyelids and just note where the caruncle is. Just go through the caruncle and direct the needle towards the medial orbital wall. Once the entire length of the needle is within the orbital wall, we aspirate a little and then inject about 2 to 3 ml. Now this is similar to how we give a peribulbar block, and you would see that the eyeball slightly bulges out and the eyelids start to close. After giving the ethmoidal nerve block, the last bit is the local infiltration at the site where we have marked, and along with that we give a dorsal nasal nerve block. Then if you're taking the patient under local anesthesia, take some lignocaine jelly on a bud and apply it into the nasal cavity. Now make sure when we apply it in the nasal cavity to come up and then go in straight, because we want the area in front of the middle turbinate to be anesthetized, because that is where is our site of surgery, and that is where we are going to be placing our nasal pack as well. Now this nasal pack is infiltrated with xylometazoline nasal drops and then is packed in the nose. Now remember not to go vertically down, because that ways we would be directing it into the floor. However, we need to go perpendicular, we need to go parallel to the nose so that it packs in the area in front of the middle turbinate. Now using a 15 number blade, we take the skin incision in the area of the anterior lacrimal crest. Using scissors, just try to separate the fibers of the orbicularis, and a cat's paw retractor is used to lift those fibers away from the underlying bone. Now the remaining fibers can again be separated with the help of the scissor and collect the remaining fibers with the cat's paw retractor. Following that, now this is an additional step. If you have a radiofrequency cautery probe, then you could use that to make a periosteal incision, or you could directly use the sharp end of the periosteal elevator to make the periosteal incision. All right. So now that the periosteal incision is made, we have to reflect the periosteum away from the site of the osteotomy. So now we can see the clear white bone underneath. So slowly reflect the periosteum till we reach the anterior lacrimal crest. Now this is the anterior lacrimal crest. Within the anterior lacrimal crest is the lacrimal sac fossa. Now what I am doing here is a step which you can avoid if you don't want to, but this is a very helpful step in the sense it helps to separate the sac from the lacrimal sac fossa, and also stops the bleeding that is happening from within the fossa after the separation of the sac. So just push in a little bit of gauze between the sac and the sac fossa and just leave it there for a minute or so. Once you do that, when you remove the gauze, you will see a clear cavity there. Now look for the maxillolacrimally suture out there, and then using a periosteal elevator, just go ahead and give a small nick. Now when you're using the bone punch, what is important over here is you go in parallel to the anterior lacrimal crest initially. So just look at this. So we are going in, so this is the anterior lacrimal crest. We go in parallel to the anterior lacrimal crest. We reach the hole that we have created in the lacrimal bone and then turn the rounger perpendicular. So just take a look at the rounger. So we first go in parallel and then we turn perpendicular and then we punch the bone out. Now, when we have punched the bone out, it is essential that we see that there is a grayish tissue, which is the nasal mucosa, which is visible there. So I've tried to keep the video real time, so you would see a little bit of bleeding there. Now, this grayish tissue is your nasal mucosa, and you should be able to see it at every point and at every step when you're doing the bone punch. So what is your inferior extent of osteotomy? So I'll stop here. Can you see this? This is the beginning of the bony nasolacrimal duct. You will see this tissue going inside. This is your lacrimal sac, and this is slowly, this is going into this hole like a bone cavity. So that is your bony nasolacrimal duct, and you just have to de-roof it. That is the inferior endpoint of your osteotomy. The anterior endpoint is still you can insinuate your bone rounger between the nasal mucosa and the bone. All right, now moving superiorly, we continue to remove the bone, and now what we see over here is the ethmoid mucosa. So this tissue color is more gray as compared to what you see on the nasal mucosa. So we need to identify the tissues with colors. So this is the largest ethmoid cell known as the agar nasal. This is by far, I mean, this is how high you should go when you're doing the superior osteotomy. I hope it's now more clearly visible. That's the ethmoid mucosa. And we will remove the bone that is over it.
Can we just fast forward a bit?
Yeah. All right. Now we go ahead and dilate both the lacrimal puncta and insert the probe in. Okay, so now when we have inserted the probe, what is important is this probe should be straight along the palpebral fissure, not vertically down or vertically up. And now when we hit along the wall of the lacrimal sac, there should not be any bone in front of the common, that is the internal common opening. So there should not be any bone in front of this. So we just see mucosa lined tissue in front of this. Now we make the H-shaped flap. This is the lacrimal mucosal flap that we are making. So using a 11 number blade, we've given an incision and then we extend it along the sac on either side. And then we give vertical cuts, that separates the anterior lacrimal sac flap. We get the probe in to know that we've cut the entire extent of the lacrimal sac and that there is no bone or any tissue in front of the internal common opening. We similarly make vertical cuts for the inferior flap and let it drop down. Now, after we have done that, we will go ahead and make nasal sac flaps in a similar fashion. So what we will do is, using a 11 number blade, give a straight incision, horizontal incision at the nasal mucosa, and then using the scissors, we will cut it along the entire extent of the exposed nasal mucosa. We will give vertical cuts on the inferior and the superior flap. The inferior nasal mucosal flap falls back. We apply mitomycin C all around the bony edges to prevent any granuloma formation. and let it be inside for about 3 minutes. This is 0.02% mitomycin C, which we are using. Now, after that, a lot of people do not suture the posterior flaps. Instead, they just cut it off. Now, you could cut it off, or you could just put a single suture through the posterior flaps and let it just drop down. Now, after this, we do bicanalicular intubation. Now, the intubation that I do is slightly different. So, I tend to bring it from the puncta and the canaliculi, and I use the suction cannula from the nose. I feed this probe into the suction cannula and just pull the suction cannula out. This is a non-traumatic way to go ahead and retrieve these ends of the intubation into the nasal cavity. So just once you've fed it inside, just retrieve the cannula and the intubation is within the nasal cavity. So we'll do that. Yes, sir?
Yeah, can we just stop because we are absolutely short of time. We would be, I'll just ask Dr. Ekta if she's there to just make one point.
All right, sure. So anyways, I'm just ending this. We just have to put in anterior flap sutures. And then we can just close the skin directly. In the end, we just need to pack the nasal cavity. You could just put a single suture through the posterior. Pardon? I can't hear you, Dr. Ekta.
No, I didn't say anything. Sorry.
Oh, sorry.
I think someone else among the panelists or someone. Yeah, I think considering the time constraint and considering the space constraint, it's a very nice demonstrated TCR surgery. And I should compliment you, Nandini. That's a very nice technique to retrieve the nasal intubation through the suction cannula. Very nice. In the process, I also learned something. Thanks for your video.
Thank you.
Vinay, please play Dr. Gopal Raju's video.
Yes.
Thank you, Dr. Nandini, for an excellent presentation.
Thank you.
Please play Dr. Gopal Raju's video. And as he's playing, Dr. Rupak can ask a few things from Gopal Raju. Without much discussion, we can
redefined phacoemulsification performance.
This is the recent advances in the active sentry.
The introduction of
basically, the sensors are additionally incorporated in the handpiece itself. So in a real time, it monitors the IOP and IOP change, and that will give the feedback to the cassette where there is an active
and increase safety in every moment.
Gopal will directly go to the video because there is very little time.
Yeah, this is I think for a better understanding, this is a better video than that.
Yeah.
So yeah, please continue. No, this is not upgraded. Please fast forward.
Hardware and software to quickly mitigate occlusion break surge.
So Rupak can be simultaneously discussing.
Yeah, Rupak, you can go ahead. It will feed the signals to the cassette.
How different it is from the regular phaco machine with gravity fluidics?
Yeah, see here in the IOP can be reduced to a much lower level. So normally in the gravity fed, we will be using somewhere 110 centimeters of bottle height, where the IOP reaches 80, 70, 80 millimeters of mercury. Especially in advanced glaucoma cases, sometimes it can compromise the circulation. Whereas here we can reduce the IOP to 25, 30, or even 30, 35. So you can operate between 25 to 35. So which is almost as good as near normal IOP. So that is the huge advantage. The main advantage is when there is an active monitoring of the chamber, so we can safely go ahead and do the surgery. That is the main difference, Rupak.
So that means in higher parameters also there is increased safety margin with the sensors being at the hand.
Yes.
That's a huge advantage, and as well as we can operate at very low IOPs. So that is very comfortable for the patients.
Absolutely no surge, Gopal?
Yeah, absolutely no surge. The response is very fast. maybe you can show the next video, just 1 minute video only, that one.
Yeah. Just
so that
Vinay,
I'll
just
show you
play out that
sir.
video, the actual live surgery, then we close the session.
Yes.
Yeah, that video I operate. Earlier I was operating around.
Dr.
once I
Gopal, you're not
shifted to
audible. Can you be a
Centurion.
little louder?
Yeah. So in the earlier with the Infinity, so we used to operate around 80. So that was Infinity with an gravity fluidics. So we were 109 or 110 centimeters. So that is equal to an IOP or around 80 millimeters of mercury. So then we shifted to active fluidics with the Centurion. So where still we used to operate around 50-55 millimeters of mercury of IOP. Here, if you see the surgery, the IOP is at 30. So even a moderate cataract, we can still operate very safely. This is mainly because of the active sentry. The active sentry with active monitoring of the chamber. So you see, it mitigates around 8 times in this case. So because it will not be active all the time. So whenever it is the surge is going beyond the safety limit, so the active sentry will be activated. So that is called the mitigation, the surge mitigation. So it activates and sends a signal to the cassette where a quick valve technology will activate, and then that will compensate the volume loss. So that is the new innovative technology. Yeah, thank you. I think
that was a wonderful video, Gopal, and I'm thankful to all the panelists, all the presenting surgeons and the panelists. Santosh, I am sorry we are giving you 5 minutes late. Please excuse us for that, and thank you everybody once again.
Thank you all.
Yes.
Santosh, I'm sorry I've given you 5 minutes late.
No problem. Thank you so much. So can we start now then?
Yeah.
Okay. So welcome to our TOSIS session, TOSIS Simplified. And we have a very eminent panel today. As you can see, our first speaker would be Dr. Gangadhar Sundar, who is going to deliver a keynote. And Gangadhar, I don't have to introduce him. He's so very well known already. He has multiple interests, especially in maxillofacial surgery, trauma surgery, TOSIS, oncology, and he heads the department at National University Hospital, Singapore. He's going to talk to us about conceptual approach to TOSIS surgery for about 12 minutes. That's his keynote lecture, and that will be followed by a panel discussion. I welcome Dr. Grover, and I request him to chair the session.
Santosh. Thank you, Santosh. Thank you, Santosh. We look forward to this session. We have such an eminent faculty that we are going to have a great time discussing TOSIS. And of course, no one better than Ganga to start off with. He is best known as the teacher everywhere for everybody, including the entire South Asia, the Southeast Asia, the global teacher who's really done a lot for education in oculoplastics. Yes, Ganga, look forward to your keynote, the conceptual approach.
Can you see my slides?
Good for a while, now disappeared.
Right.
Okay, let me reshare again. Sorry about that. How about now?
Yes, we can.
Right. Thank you, Santosh and Dr. Grover and all our friends over there for the invite. I think what Santosh was trying to get the message across is Jack of all trades is a master of none. So he's asked me to give you a slight overview of conceptual approach to surgical management. I'll share with you some of my perspectives. I bring you greetings from this part of the world. We work at the university hospital where we have both a good mix of pediatric and adult patients with complex patients, hence a good spectrum of both degenerative disorders, post-traumatic ptosis, and congenital deformities. That's where most of our experience really comes from. Some disclosures which are completely irrelevant to this presentation. So when you look at ptosis as such, I mean, the first and most important thing from a resident's perspective is to make sure not to operate on somebody who does not really have a ptosis, the concept of a pseudotosis. And when you look at the true ptosis, the various classification systems, this has always stood the test of time, especially in adult ptosis, the neurogenic ptosis, by default, the most common being an epineuritic ptosis, the myopathic ptosis, which Santosh is going to touch upon. And finally, don't forget, a lot of these post-traumatic ptosis are mechanical ptosis, which with the teacher of time usually gets better. I'm going to touch a little bit about perspectives on certain aspects of neurogenic ptosis, a little bit about epineuritic ptosis, the anterior approach, a little bit on the posterior approach, and the concept of a tarsoconjunctival switch graft technique as well. A unique type of ptosis is the post-traumatic ptosis, which can be multifactorial, and hence you have to address that as a completely different perspective. So when you look at congenital ptosis, there are various forms of repairing, and we have two great speakers following as well, either a frontalis suspension or supramaximal levator resection. This is typically used for children who have very poor levator function. And there's always these controversies, and we're going to hear about it. I generally, for that matter, anybody over 3 to 4 millimeters tend to prefer a supramaximal levator resection before I embark on a frontalis suspension. And I have a very high threshold to do an autologous fascia lata as a frontalis suspension. But you can use alloplastic materials as buying time. It has its own strength and results. So here's a young child who's had a significant ptosis with very poor levator function, where we have done a primary supramaximal levator resection with very satisfactory results. And most oftentimes you get away with a good result. But every once in a while, I see this once in a few years, we end up with a complication like this, where, as you can see over here, you have a reversal of the Bell's phenomenon. And sometimes we forget as surgeons to look for a Bell's phenomenon preoperatively. And this is something that we encounter both, not just in levator resection, but especially supramaximal levator resections and frontalis suspension. The panel discussion later on can talk about the theoretical basis behind it and the natural history of it. And a lot of times, hand-holding the parents and the child is very important. Here are two examples of patients who have ptosis, a post-traumatic ptosis and anophthalmic ptosis. These are quite challenging. And in terms of bad lid lacerations, you can see this full thickness laceration. Prevention is always better than cure. So hence meticulous closure in the first layer itself, first sitting itself, conjunctival closure, followed by a levator primary apposition, not a ptosis correction, followed by a skin closure, should give you very good results in preventing a ptosis. Whereas in anophthalmic ptosis, again, the atraumatic dissection within the orbit is very important. Retracting the levator when you're doing the enucleation itself is very important. I always find this very challenging. If at all there's one condition in which I sit up the patients on the table to adjust, it is the anophthalmic ptosis, because there are dynamics between the ocular prosthesis, the conjunctival phonesis, and how the prosthesis falls off from the superior phonics, which is very important. And that's something I do, and I like to hear from the other experts how often they sit their patients for routine ptosis surgery versus anophthalmic ptosis surgery. Going to the spectrum of ptosis surgeries, you can work from forward, which is what most of us are brought up with, but there are indications for posterior approach ptosis as well. So, and we all believe in certain aspects. And frontalis suspension is something very popular, and especially when you have a suspension material which comes in a packet, with some of them which have their own limitations. And of course, there are other forms of surgeries for ptosis. The anterior approach ptosis can be classified into levator tuck procedures. These are something we sometimes combine with blepharoplasties. Again, one of the speakers is going to talk a little bit about it. To the formal levator advancement when you have patients with good levator function. Levator resection may be attempted when you have moderate levator resection. And when you have relatively limited levator function, then you can either consider an internal sling, which I do once in a while, and not infrequently a supramaximal levator resection. That's a supra-Wittnall's levator resection. You can also go from behind, and we were late beginners for this kind of procedure. Interestingly, the posterior approach is not really new. It has been described quite a bit in the past, and we used to perform the Fasanella Servat procedures ages ago. And here it's a tarsoconjunctival muellerectomy, which is very different from a Mueller's muscle conjunctival resection, which is described by Alan Matterman, which is what is called the Patterman procedure. The main criticism against a Fasanella Servat was that you're sacrificing tarsus which potentially could be used for lid reconstruction in future situations as well. And every once in a while, you developed a peaking mechanism. Hence, most of us are kind of gravitated towards a Mueller's muscle conjunctival resection or conjunctival muellerectomy, but they have their limitations as well. More recently, what has been redescribed as a white line advancement or the levator advancement through the posterior approach. I have very limited experience with it and like to hear from other experts in the panel today. An interesting type of a ptosis is an honor syndrome where you get a sympathetic paralysis and you get a ptosis not just of the upper eyelid, but you get a ptosis of the lower eyelid as well. So in these situations, just doing an upper eyelid procedure oftentimes does not give you the enough widening of the palpebral fissure that you may have to do a similar procedure down below. Here's an example of a Mueller's muscle equivalent in the lower eyelid conjunctival resection, where we have raised the upper eyelid, lowered the lower eyelid, giving nice symmetry in these patients. Frontalis suspension procedures are procedures which are quite common, especially in children with congenital ptosis. There are various philosophies about static with dynamic slings and various philosophies about using autologous out of the packet versus out of the packet procedures as well. And numerous tissues have been described. The major problem downside that you see with material, alloplastic material, is the potential possibilities of granulomas, especially with cortex, and once in a while infections with silicone rod procedures. And interestingly, even after sometimes removing these alloplastic materials, sometimes the eyelids really hold up very well. So again, we're going to have talks on this particular topic, but keep in mind that there is a specific role and indication for these frontalis suspension procedures. But if you do silicone rod procedures, one of the greatest advantages is even if it fails, you can go back and redo the procedures any number of times, although that's not what you want. And that's where autologous fascia lata or bank fascia lata really come in. Here's an example of a child with a chronic progressive external ophthalmoplegia where we have not made a single incision anywhere. They're all just stab incisions, stab wounds in the upper eyelid, in the suprabrow region, and the mid forehead, where we have used an silicone rod suspension procedure, all under local anesthesia with a simple frontal nerve block on both sides, where we got a reasonably satisfactory result. An interesting new procedure, which a lot of people are not familiar with, it's actually not a new procedure, but an old procedure, is switching tarsoconjunctival full thickness tissue from the upper eyelid to the lower eyelid. This is typically reserved for myopathic ptosis, where the goal is shifting the palpebral fissure above without increasing the lag of thalmus. And here we make a skin incision, all again under local anesthesia, both for the upper eyelid and lower eyelid, except for the skin. Everything else from the subcutaneous tissue all the way to the conjunctiva, and if necessary, parts of the tarsus can be resected and reapproximated. So you're raising the upper eyelid, and the same graft can be used to augment the lower eyelid with the lower eyelid tightening, so that you're not only raising the upper eyelid, but you're raising the lower eyelid. So really no change in the lag of thalmus, and hence minimizing the need for keratopathy, postoperative keratopathy in these patients. So this is something that is worthwhile considering in certain special situations as well. Here's an example of a patient where typically myasthenia gravis is usually managed by medical measures, but aging and gravity is always coexistent in a lot of these patients. And even after maximal medical therapy, if you have residual mechanical ptosis with levator dehiscence and the patient is visually bothered, you can adopt various forms of not just upper eyelid ptosis surgery and blepharoplasty, but if necessary, a brow lift, with satisfactory results, not just functionally, but aesthetically as well. Last but not the least, never forget that there's always an option of non-surgical approaches in patients with myopathic ptosis. So hence, I always offer this to my patients first, especially elderly ones, before you embark on a surgical procedure, because the surgical procedure sometimes can be irreversible, especially if we overdone it with exposure keratopathy. So I'm going to conclude my talk as Santosh has given me the time, with certain controversies in ptosis surgery, and the panel discussion can lead it. What if you have a patient with asymmetric levator function in a patient with congenital ptosis? Do you do a similar procedure on both sides, or do you do a slightly different procedure on both sides? What if you have a severe unilateral congenital ptosis with poor levator function? Do you do a unilateral or a bilateral frontalis suspension? How about experience and consensus with the posterior approach white line advancement? Like I said, I had limited experience, but I'd like to hear from the experts. And an interesting concept is we do a lot of MMCRs, but every once in a while we end up undercorrecting them. Should you be correcting them anteriorly because the posterior approach failed? Or can you go back and try the posterior approach? And I have my own preferences, but I will probably wait for the experts to hear them. So in summary, I will always say ptosis surgery is like a box of chocolates, like Forrest Gump said. Yes, we all do wonderful surgery, feel very good at the end of the procedure, but we always dread how the patient is going to look on day 1 and day 3. It's important to make sure that the promise and the delivery are equally met. But most importantly, we should be ready to manage the patient's expectations, because every once in a while we are caught up with a surprise, sometimes a pleasant surprise when you think you've done a bad job, but sometimes a very bad surprise when you think a very good job, but the patient has a dramatic complication either related to hematoma or the local anesthesia or the sutures itself. But the goal of any ptosis surgery first is not aesthetic, but it's more functional, which in turn results into a good aesthetic outcome, which in turn results in a good psychosocial and economic implications for the patient and the family. Thank you very much again for the invitation, and look forward to hearing the other experts.
Thank you, Ganga. Dr. Grover, any of the other panelists have any comments on this?
Ganga, hi. Do you still do the Fasanella?
Ganga, can you unmute?
Yeah, it's been years since I've done it. The only time I do it is when our resident or fellows have never seen one recently and want to see one. Same thing as an external DCR, that's our indication now.
Thank you, Ganga. I think your first 3 words summed it up: challenging but rewarding. So that sums up the ptosis surgery very well. And you brought out the questions very well. I'm sure all of them will be discussed. As for Milind's question, I love Fasanella Servet, and I don't know the reason why Ganga gave it up. All of those of us who have done it have had such satisfying, gratifying results for those category of patients where it is indicated, and have not faced any of the theoretical difficulties which are so highlighted that we find no reason to discontinue it. And this is with an experience of over 250 cases. So I don't see any reason to discontinue it just because some people have a theoretical objection. Some of my patients have had their surgery done 35 years ago with no problems.
The other reason why I don't do over here is because the Southeast Asian population, the tarsal height is much shorter than the Indian or the Caucasian island.
The Indian one is just 8.
Sometimes it's about 7-8 millimeters. And when you talk about the theory of preserving tarsus, which is, it's like almost LASIK surgery. So for me, sorry for saying this, in myopia sacrificing tissues, which is completely innocent in the pathogenesis of the disease, then you feel uncomfortable, especially when you're teaching residents and fellows.
We don't excise more than 3 at any time. So we are always keeping at least 5 or so of the tarsus. And I think that's a very good way of starting a panel discussion, to start with a controversy. Milind?
And anyway, Kasturi is going to talk about it. She's next.
Yeah.
Yeah. And anyways, Ganga, in myopia, we excise the excess of the corneal tissue. We don't excess the one which is required. So exactly
it's not excess.
There is no
Wearing the refractive surgeon's hat.
We're just getting rid of the extra baggage.
Correct.
Right?
Yes, sir. I agree to you.
Kasturi, you can begin.
Okay,
I
should
think
I
we
go
are
ahead?
waiting for you to speak on this subject.
Okay.
And I would also particularly like you to address whether you love to do any Müllerectomy for Müller's muscle resection for congenital ptosis as well, because I have not had great results with that.
So can you see my slides, sir, all of you?
Yes, yes.
Okay. In this meeting, and also all members of Hyderabad Academy. So I'll be speaking basically on the mild ptosis surgery, especially ptosis surgery having a very good levator action. This type of ptosis are at times challenging because you see they are near normal, and the ptosis is usually very minimal. It's approximately 1 to 2 millimeter. So it requires a very important evaluation regarding the amount of the LPS action, and the most important point which Ganga has already mentioned, that is the Bell's phenomenon. So it is very essential that before touching any patient, we need to see the Bell's phenomenon, and only if you're sure that they have good Bell's, then we plan the type of the surgery. So I'll be talking basically about the Muller muscle conjunctival resection, because I also do not much prefer the Fasanella Servet. And historically, we all know that in minimal ptosis, if you have a phenylephrine test positive, you go for MMCR, and if negative, it is a Fasanella Servet. And the mechanism is Fasanala survey is definitely number one, the shortening, the vertical shortening. Number two, the cicatrization. And number three, the advancement of the molar muscle complex on the tarsus. But the advantage of MMCR is that we do not excise the tarsus, and we save the tarsus in case it is used for a later procedure, and also the meibomian glands are not disturbed. And I feel that it is a much elegant surgery as compared to a Fasanala cervet. So this is how we usually do MMCR. We usually do, we evert lid, and then I usually inject a local anesthetic so that we separate the conjunctiva and the molars from the underlying LPS. So once we separate the tissue, and then we clamp the tissue and find out the amount of tissue we need to excise. There are different nomograms, but what I believe is a Jesner's nomogram, that for every 4 millimeter of the molar conjunctiva that has been excised, we correct approximately 1 millimeter of the ptosis, because they really have a very good levator function. So you need to pass the suture. I usually use a 6-chromic or a 6 PDS. You can pass either in a single layer or a double layer. The advantage of passing a double layer is that you can exteriorize the suture. Once the suture is being taken out, I usually prefer this phaco micro knife. This is because you can really cut this tissue out very well. And once this part is being cut, the most important is that we really need to understand what is the pathology behind this surgery, what actually happens to the molars. So what I do, I usually retain the molars and I send it for the histopathological examination and make sure that approximately 8 millimeter of ptosis that I have, 8 millimeter of tissue that I have designed has been excised. So this is a young girl where you can see, just look to the left eye, which is only the eye that has been touched. And you can see this is following a MMCR, where you can get a very adequate and the natural correction. So the mechanism, how it works, number one, shortening of the posterior lamella, number two, plication, and the most important is the internal advancement of the LPS, which transmit the contraction force of the muscle directly to the tarsal plate bypassing the aponeurotic system. So this is how it works very good in the correction of the ptosis. And as I have already mentioned, historically it is done in patient having a response to the phenylephrine. So there are numerous nomograms to it, but as I have mentioned, I followed Dresner's, which is 4 millimeter resection corrects 1 millimeter of the ptosis. So this is one of the lady where you can see she came to me initially for the blepharoplasty, and many times I see this elderly patient, even when they come to the clinic, you see even after dilatation, when routinely when we dilate with phenylephrine, we see there's some amount of, the eye looks bigger. So most of the patient, what we do a phenylephrine test, and you can see that it is much positive. And then she had undergone this same procedure that I have shown here. Am I audible?
Yes, you are.
Yeah.
Yeah,
Okay. Yeah, so you can see this is the same procedure that has been done, and this is a very quick procedure. I feel that this is very nice to be combined with other blepharoplasty combos also. And then once it is being done, you can see post-operative lids looks little more corrected, but after 3 months, you can see a much better correction, and also you can see that it is being maintained for a very long time, and it happens to be a very quick surgery. But a question today, which Grover sir had asked me, that does phenylephrine test really matters? And this is a very interesting paper by Baldwin, where he had shown multiple cases where molar muscle, this MMCR, is a safe and effective surgery despite a negative phenylephrine test. And following this, there has been multiple studies and multiple literature shows that it can be done in minimal ptosis, even if you have a negative phenylephrine test, because the mechanism which I had already mentioned, where the muscle gets in contact with the tarsus and you bypass the section of the aponeurosis, so it leads to a lifting effect. So even with children with a small amount of ptosis, as you can see here, I have done a few cases where I can see an adequate correction and it gives a aesthetically much better look. And Ganga had already mentioned that what is the role of this posterior approach surgery, especially for the anophthalmic socket and for the giant fornix. So giant fornix syndrome also, it works very good. And I feel the anophthalmic socket, if you do this MMCR, you can give a more adequate correction. So with this, I conclude that yes, both are easy procedures, a quick procedure, but I feel I'm more used to MMCR. And thank you very much for the patient hearing.
Thank you, Kasturi. That was a very elegant presentation. I have no doubts that it works very well for the acquired ptosis particularly. I would like to hear the experience of a few people with regard to their experience with this in congenital ptosis of mild nature, mild ptosis, with or without phenylephrine test positive. Any of you who has experience in this?
Shubhra here. Can I come in?
Yes, please, Shubha.
Yeah. So the congenital ptosis, whether the phenylephrine is positive or not positive, the results have been very variable. So in my hands, what I have found is that if there is, if the phenylephrine test is even slightly positive and not strongly positive, one may go ahead and do an MMCR, but it is very variable in congenital ptosis. So I usually don't go ahead as a first surgery of choice in congenital ptosis, but it works beautifully well for a revision ptosis surgery, even if the initial surgery was LPSR or any other form of surgery done in a congenital ptosis. That's what.
That's very useful. Anybody else who has enough experience with MMCR in congenital ptosis? But of course, we are talking about mild ptosis, levator action exceeding 10, or possibly positive phenylephrine test. Anybody else? And then we move on to the next one. Yes, Milind, please.
Yeah, Dr. Grover, as long as the levator action is good and the requirement is 2 mm or less, I find that MMCR does work in these cases. And very few cases where it has undercorrected, I have gone ahead and redone MMCR. And I think that has worked primarily like what Kasturi said, by advancement of the levator.
Would you say it would work in about 90% of those cases of congenital where it is indicated?
Yeah, 80 to 90%, yes. But I have seen cases with undercorrection.
Yes. So that's quite encouraging. I think we should all then make an effort to try it, because it is definitely less traumatic than Fasenala. The reason why we continue with the Fasenala is that the few cases that I did, I was discouraged by the results. So I possibly need to improve upon that or something like that. Maybe we can move to the next one then, if unless anybody else has something to add.
Usha is next. She's going to talk on ptosis with moderate levator action, levator resection.
Thanks for structuring it so beautifully, Santosh.
Can you see my slides?
Yes, sir.
Yes.
So, okay, I'll be talking about the levator resection for a moderate ptosis with a fair LPS action. So now,
can you go to slideshow?
I think it's not. Yeah. Is that okay?
Great.
So there's a mandatory checklist which we need to definitely go through, immaterial of what the type of ptosis is and the kind of surgery that we are going to perform. It would be the amount of ptosis, the levator function, bells as was discussed earlier, tear film and motility, as well as visual acuity, so that we don't have any surprises and complications at the end of the surgery. So now we'll move on to this video where we'll be watching the lid crease marking and local anesthesia, local infiltration, just adequate enough not to distort the anatomy. And then incision, you can either use a blade or you can use the cautery and make an incision. And I go straight to the levator on the towards the lash line and dissect the aponeurosis posteriorly and anteriorly. After opening the orbital septum, I see a bit of fat prolapsing. Sometimes I actually use a cautery to dissect the fat out. That's the septum which we see, which is opened up, and yes, and you can see some fat coming out, and then the fat is popping out once the septum is opened. Not many advocate removal of fat, and it's not very often that we remove the fat, But in this case, the fat was too much, so I had to excise a bit of the fat. Caution here, it might tend to bleed. So cautery is good. And sometimes you can just shrink the fat by using a bit of a cautery, bipolar. And then you start reattaching the levator after you've dissected posteriorly and anteriorly. And the measurement, I will talk about it a little later. One suture in the center and one suture on either side of the central suture. Using a Vicryl suture 60, which is often what I tend to use. You can use Proline as well. And the measurements are based on the amount of ptosis. And once it's sutured, you can always compare it with the other eye. Now excise the extra skin. Sometimes you may have to excise the extra orbicularis. Not to overdo it, but just to prevent the bulky nature. And then you can suture using the skin orbicularis cut into the levator. You can use the same Vicryl suture, which is what I tend to use. You can use the Proline also, whatever is comfortable and convenient. And always compare it with the other eye to ensure that we are not overcorrecting or undercorrecting on the table. So the next one here, in addition, we're just excising the extra skin here, apart from the, this is just an additional blepharoplasty. And again, you need to, I'm just showing a quick version of this, where you just have to measure the amount of levator that needs to be resected and compare it with the other eye, as always. And there are some tips that we need to follow, which I'll be talking about in a while. So here, as we go through the steps, marking of the incision site is very important. Then once you incise, it's the skin orbicularis, then you go to the aponeurosis, and in between the aponeurosis and the, you have the orbital septum, which as you open, you'll see the fat prolapsing. Repositioning is a good idea, but sometimes we may have to excise the fat. Once the aponeurosis is lifted off the posteriorly and anteriorly separated, then you measure the amount that needs to be resected, and then you do the suturing. The contour has to be measured both in the sitting as well as in the lying down position. Now, I would prefer to, whenever I'm in doubt, I always don't hesitate to make the patient sit up and compare the two eyes. So the question of making the patient sit up comes only when there is a doubt, and there's no harm in checking it in both the positions. And for every millimeter, there's a 3 millimeter of levator that's to be excised, is what the literature teaches us, but it's always best when compared with the other eye. And remember, if the levator action is really good, you get a 1 to 2 millimeter elevation post-operatively, that is in subsequent days, and will drop if it is less than 7 millimeters. So you have to really be careful about the amount of ptosis, and the measurements have to be really good. And always it's best corrected when compared with the other eye. And I prefer the anterior approach. Posterior approach advocates are there, but it's always what works well with you is what you should adopt. Thank you very much.
Thank you, Usha, as always, brilliant. Just one quick question to everybody. Do you all have a figure of amount of dissection in mind when you start a levator dissection? We're talking about congenital. And or do you decide it on the table based on what you observe? Two speakers. I will start with Usha.
Yes, sir. So for the congenital ptosis, I don't think it's possible for us to compare it with the other eye. So you need to have an arbitrary amount that needs to be resected. And we do tend to make mistakes. It's like as it was mentioned earlier, we do have some pleasant surprises. When you think it doesn't work, it works very well. And sometimes you almost feel that you've done a great job and you have a very unpleasant surprise the next morning. So you need to have an arbitrary measurement in your mind, which is when this...
Levator action.
Yeah. So
okay.
That's when the algorithm works. That's, I think, helps. In fact, it could help to a certain extent. But I certainly feel that we should have some kind of an experience also helps. So certainly, I think
It certainly does. I think it belongs largely to that category. Any other opinion, please?
I tend to leave the lid at a particular height depending on levator action. That's the only variable I take. If it's 7 to 8 millimeter, I would just correct it fully. If it's less than that, I would overcorrect. If it's more than that, I would slightly undercorrect.
True. I suppose that all of us would be doing. But would you have a figure in mind of how much you're going to dissect, or if you're going to decide on the table, what do you base it on?
I base it on the lid height that is achieved while I pass the suture. I always pass my suture slight under the
first suture being passed.
Correct. I always pass my suture under the Whitnell's ligament and tie the suture tight enough to achieve the correction that I desire. Sometimes the suture is hung back, which is okay.
We'll take one more opinion on this and then we'll move to the next one.
Milind?
So what Dr. Hunavar said is exactly what most of us are doing. So I don't think we'll get another opinion on this.
So I don't have any figure in mind. I largely go by how well defined the Whitnell's is. If Whitnell's is well defined and I have a levator action of about, say, 8, I would stay just short of Whitnell's. And if it is anything like 5 or 6, I would go through the Whitnell's and make it a Whitnell's sling kind of a procedure. And if it is, of course, a very good levator action 10-ish, then I would probably stay a little further away from Whitnell's. If the Whitnell's is poorly defined, or if you find fatty infiltration or something, those are the only situations where I go beyond Whitnell's and go into the category of supramaximals. Otherwise, my dissection stays at or about the Whitnell's if it is well formed.
The one suggestion, I don't know, I'm not very sure, but I tried this. I keep the lid height, since we are not anesthetizing the lid while doing it under general anesthesia, I keep the height exactly at the limbus. So that also helps.
Yeah, of course. At the same time, we are titrating it with the position of the limbus in mind on that side. Yeah, that certainly is a criterion. I think we'll go on to the next talk then.
Word of caution. Can I add one point here?
Yes, Mukesh, please.
Yeah. What I believe is, and I have burnt my hands also sometime, that in under anesthesia, lid tend to droop down. So if we go simply by the on-table correction, I think sometime we may not achieve the good result. So going by general principle will help in pediatric age group. And I think the position of lid after passing first suture will be of importance, because after 5 minutes or so, lid will again droop down. So you have passed first suture, and then you, if you are passing other sutures, meanwhile only lid will droop down to say 1 or 2 millimeter. So that's, I think, my observation under anesthesia. I don't know how other people do.
So because of all that unpredictability comes the tarsofrontal sling, and that is why you, Mukesh, start the talk on tarsofrontal sling. Start the discussion.
Thank you, sir. So I'll be straight away talking on tarsofrontal sling. We all know that mainly available 2 methods nowadays are fascia lata and silicone rod. And most people are now have switched over to silicone sling because of one very simple advantage is that it is extremely easy to perform under local anesthesia, and it gives almost equal result, if not equal to fascia lata. One real advantage, I believe, is it is potentially reversible procedure, which gives us huge advantage in infants and patients with poor bells. Fascia lata, I am one of very few people, along with, I think, Dr. Grover and few others, who are still proponent of fascia lata. This is my procedure of choice in case of tarsofrontal sling. I think more than 60% of my cases, I still do fascia lata wherever I am doing sling. It definitely scores in tighter lid like blepharophimosis syndrome, no question about it. Silicone fares quite poorly in these cases. Its elasticity is almost equal to silicone and nearly same on lid lag and leg of thermos, and virtually it eliminates problems like extrusion, granuloma, infection, slippage, etc. So and forget it. Whenever we are doing sling, principally
Sharma,
yes, sir.
We are not able to see your slides. Have you shared the screen?
Oh, I am sorry if it is so. I have shared the screen. Just a minute.
In the Zoom, you will have to click the green color button, sir.
Yeah, that I am doing.
He's a veteran in Zoom.
While we're waiting for his slides, just to compliment Santosh that this is actually an OPAI session in Hyderabad Ophthalmic Association conference. Actually, the top talent in OPAI and in TOSIS is here. Congratulations.
Couldn't think of a better forum to discuss things.
Yeah.
So, is it visible
we
now?
see your directory, Mukesh. We are not seeing your slides as such.
Is it now?
No.
Click on your PPTX and.
I am already sharing it actually.
You can unshare and again choose only the PowerPoint.
All right.
We missed your Pondicherry meeting, Usha.
Correct. We got it.
Yeah.
Put it on first slideshow.
Is it visible now?
Yeah.
Yes.
So I was talking about silicone sling and fascial data. We all know silicone sling is a very simple and easy to do procedure, and it gives us huge advantage in form of its reversibility. Fascial data, though there are very few people who are doing it, but still I believe in fascial data, and most of my sling patients I do by fascial data. Whenever we are doing sling, principally, we follow these two methodologies. Either we do by Crawford double triangle. This is done primarily in fascial data. And for silicone, I think everybody is doing Fox's pentagon only. There are certain pearls for silicone sling. One very important thing is one should never reuse silicone. One should not sterilize it and then reuse it, because if you are doing it, then there are high chances of granuloma and infection. You'll have to always make a long tunnel and leave your cut end of silicone inside the tunnel to avoid extrusion. And this very important point, which is seldom highlighted, is that I combine skin muscle excision in most cases of silicone sling or facial data sling, except in children, because in I think almost all cases we do get excessive skin there, excessive anterior lamina, and if we do not excise it, then there will be bogey skin later on. So this is a small video clip of silicone sling. A child, embryogenic age. So we mark 2 points on either side of limbus, around 3 to 4 millimeter away. I take these 2 points at equidistance from the sweet point. Sweet point is the point where I think the most where the good lift is there. If you lift lid at sweet point, then 2 points medial and lateral in line with lateral canthus and medial canthus, and one central point. Stay suture. Then you make stab incision. You can use diathermy also, and you can use knife also. This is important. At your central point, you should be making a long tunnel, because your end of silicone should bury there inside. Then one other point which I want to highlight is that always I use both the needles per eye to remove this sleeve from the needle. You can use complete sleeve also, and you can cut it half also. So just bend it. These are malleable needles, and pass it in the pentagon manner. Start from the tarsus plate and then move upward. So if you are using both the needles, then it gives you advantage of going in your natural motion. You are going from downward to upward. So you will be passing your sling in the proper plane. Here supratarsus plane and above levator. So once you have passed sling in pentagon, Also, you will have to ensure that you are not pinching any tissue here at the corner of tunnel. Your sling should be freely mobile. Then you just thread your sleeve by the needle. And if you are using both the needles per eye, then no need of stretching the sleeve. You can easily pass through your other needle into the sleeve. So just do it and titrate. Since it was a child, so I did not do skin muscle excision. Then bury your cut end of silicone rod inside the tunnel which you have made and do suturing. So this is post-operative. You can see fairly decent correction. And this is, I think, 2 months post-operative. So now this is bilateral silicone sling done in the case of senile ptosis. Here skin muscle were excised. You can see these cases. Here we did not do the skin muscle excision and you can see bogginess of skin. And in this particular case, we did skin muscle excision also along with sling, and you can see nice lid crease with good lid fold, no overhanging skin. Another case of unilateral sling, you can see skin muscle excision is done in this particular case also, but unilateral leg ophthalmos is always a problem. So there are certain other problems also. If you do unilateral sling, there will be variable lift at different time period. There will be unilateral brow arching, unilateral leg ophthalmos. So to avoid these, we generally do bilateral sling. We try to convince patient for bilateral sling. This particular patient had presented to us with right eye droop, though there was some ptosis in left eye, but patient was not worried for it. We convinced her for bilateral sling and we did bilateral facial atta in this particular patient with reasonably good result, and she is very happy now that she has undergone bilateral sling. And this bilateral lid crease and lid fold has given us really good appearance. If we do facial atta retrieval, then you have to keep in certain anatomical landmark in your mind. Connective tissue which overlies facial atta is in circular manner, while facial atta fibers are in longitudinal manner. And your skin incision should align with facial atta fibers. Then you will have parallel uncut fibers of facial atta. If your skin incision is oblique, then you will have oblique facial atta fibers which are broken at multiple places and it will not have good strength. So this is a very simple point, but it is of tremendous help. Just 1 minute facial atta clip. We take facial atta through around 2 centimeter incision, 2 to 2.5 centimeter incision manually and routinely. So these are those circular fibers which I was mentioning, and underneath these fibers there are longitudinal facial atta fibers. Then you make 2 parallel nicks into this, and then by employing long scissor, you just glide these scissors, this scissor through the incision which you have made. First undermine your tract, then just glide it as a cloth vendor cuts the cloth. So do it in both the incisions. Then reinsert a curved long scissor. Hold facial atta through your left hand. Insert your scissor with closed lip. Just make a turn and cut it blindly, but you will feel a click in your left hand. So you will be able to retrieve good length at lower end, and same procedure is done at other end also. So here we could achieve around 15-16 centimeter facial atta, but anything more than 10 centimeter is good enough. Then you prepare
Mukesh, we may need to
Strips of this
summarize.
2 to 2.5 centimeter strips are good enough. Sorry, millimeter strips are good enough, around 2.5 millimeter strips. If you are using too thicker a strip, then there will be some bulk in the lid, so you don't
Mukesh,
want it.
we need to summarize.
Incisions are same as we have done in silicone. Here we have not done skin muscle excision in this particular patient because there was some tightening in the skin. Very rarely we do it in adult patients. This is the end of surgery. Yet another patient. So pre-op and post-op pictures of some of the patients. So to conclude now, it is beyond doubt that silicone rod is the best available artificial material, and it really scores over facial atta in its potentially reversibility in infants, patients with poor bells. It's a simpler procedure, but I believe facial atta is still the gold standard. It virtually eliminates problems like extrusion, foreign body granuloma, infections, lipase, etc. In tight lids like blepharophimosis syndrome, it is hugely superior. Though there is some learning curve, it requires GA, general anesthesia in most cases, and you need to give a separate thigh incision, and a scar at thigh, though not very visible, is there. Thank you. Thank you for your patience hearing.
Thanks, Mukesh. I'm sure there are a lot of questions, but I think in the interest of time now, I think we'll have to hurry. I'll
invite Dr. Grover to talk on synkinetic ptosis, which is a very difficult topic.
So I'll be speaking on a video which was prepared for an oration. So forgive a bit of hyperbole. This is about how our strategy for management of Marcus gun ptosis has evolved over a period of a quarter of a century. So it starts with how we started and what difficulties we faced and how we have chosen our current approach. This has been a long journey. Jaw winking, as Santosh said, is a difficult problem because you need to tackle not just the ptosis, but wherever the jaw winking is significant, that is 3 millimeters, 4 millimeters or more, and it is important to the patient, it needs to be tackled as well. Jaw winking is eliminated by the disabling of the levator, and we find the excision of the levator up to the aponeurosis, including the horns, to be the best approach. Initially, the procedure was done as a two-stage procedure by many surgeons. When we tried a single-stage procedure, what we saw was that because we were dissecting on the surface of tarsus, we could not do a closed technique of sling, and we had to anchor it on the tarsus, resulting in complications like entropion and bad contours, flattening of the central contour. So we stopped dissecting between the tarsus and the orbicularis, and we could do a closed technique. Then we evolved this sub 1 inch harvesting technique, which Mukesh has alluded to, because we wanted to eliminate the scar on the thigh. We started doing levator excision with unilateral sling, and the problem of asymmetry, problems of unilateral brow asymmetry, downward gaze, lack of thalamus has already been discussed. We then chose the approach of unilateral levator excision with bilateral sling, and there was this apparent undercorrection that was always visible, which was, of course, because the other side, the frontalis, was not required to be used, and there being no stimulus, there was this apparent undercorrection, even though you had made a symmetrical correction on the table. So we then switched to bilateral levator excision with bilateral fascial lata sling, and this is the approach that we now currently use, and you'll see the video of how we do it. This is we are using double triangle technique, modified Crawford with 4 lid incisions, which have been placed according to where we need the fold. We inject a bit of 1 in 80,000 adrenaline to decrease the bleed. Then we go through this 1 inch incision to expose the fascia lata. And just as was explained by Mukesh, we do a long incision with the long scissors, dissect and close that 1 millimeter incision. We use the 2-strip technique, so we are using these 4 strips. We make the eyelid incisions as marked, the crease incision, and I agree with Mukesh about the need for skin excision, which is paramount as we are shortening the posterior lamina. So we need to shorten the anterior lamina as well. So we dissect anteriorly to expose the levator aponeurosis, posteriorly between conjunctiva umbilis and the levator to expose it well. Cut the horns on either side. And then make sure we excise right up to Whitnall's to get a complete elimination of the levator function. Do it similarly on the other side because we always prefer to do it bilaterally. And we dissect between the 2 outer and the 2 inner eyelid incisions. We make our eyebrow incisions and the central forehead incisions. Large enough pockets to allow the knots to go deep in from the wound. Placed between the outer 2 eyelid incisions and then a right fascia lata needle to pick the strip up to complete the triangle, both inner and outer. The knots are created and the correction is checked, contour is checked, the chest skin muscle is excised. And these knots are secured with white thread after the double knots have been done. And then the central triangle on the forehead is created. All the fascia lata knots are buried deeply. The crease incision is closed and a frost suture is placed. Of course, the procedure is done bilaterally. The advantages of this technique are that it is a single stage procedure which does both the things that we want to do, eliminates jaw winking in 98% or more cases. Correction of ptosis is good and symmetrical. Lid lag and lag of Thelmos is also symmetrical. The results are permanent with virtually no recurrences or side effects. Scar on the thigh is minimal. The examples, one you saw on the previous slide, this is the other one where we have a symmetrical appearance in primary position, also in the upward and the downward gaze, as we'll see. And a fair degree of symmetry of the fold can be achieved as well with elimination of jaw winking. So this is the approach that we currently take, and now we have over 112 cases. This was when we analyzed in March 2017, and we find a markedly improved results with results rated as good or fair, which means a symmetry of 1 millimeter or all asymmetry of less than 1 millimeter not being there is very, very much better. This approach has given us the best possible solution that we think is possible for jaw winking ptosis. Thank you. We'll have it open for discussion. Yes, Santosh?
Thank you, Dr. Grover. I think Dr. Santosh has left because he had to attend the IOS session.
Yeah.
And I'm getting messages from the people in the next session checking with us. So I think I should go ahead with Shubhra's presentation next.
A very good evening to one and all, and thank you for organizing this webinar. It's always a pleasure to be amongst all my seniors and colleagues. So my talk is on aponeurotic ptosis. I would just begin by saying, for the interest of the general ophthalmologist here, is that whenever we approach a case of ptosis, it is very important to understand, is it really ptosis? Should we be operating? And if yes, what should be our approach? So for example, if you see this patient, she was sent to me for the right eye ptosis, but what was actually present was a severe amount of brow ptosis, which needs to be addressed. And if you look at the MRDs, they are actually pretty much equal. Similarly, one more case where patient was referred for the ptosis in the left eye, but what she had actually was a retraction in the other eye, and she happened to be a thyroid patient. And we had to deal with the thyroid eye disease before we could actually, work on her retraction and lid ptosis. So a very, typical looking involutional or aponeurotic ptosis would look something like this, with a high ride increase, ptosis of variable degrees, and the ptosis which will increase in the down gaze. With or without the frontalis overaction, and that's what is the key in understanding what we are dealing with. Now, I'll bring your focus to something which I have been practicing for last 7 to 8 years, is the small incision external levator repair, which I learned during my fellowship and was actually popularized by the group from Madison, University of Wisconsin. And the advantages it has is that you achieve better contour, there is lesser edema, faster recovery, and it's kind of an artistic surgery to do as well. And when the studies were conducted to compare the traditional approach versus the small incision levator advancement or tucking, it was found that it was equally effective in the lid height, though it achieved superior contours, and it was much quicker to do. It is a very good surgery to do in cases of frank involutional ptosis and anophthalmic sockets with deep superior circles, because you don't want to kind of excise too much of skin or deal with the fat, and of course in younger patients. So I'll just share a quick video here to show how it is done. Obviously, we go ahead with the usual steps where we mark the lid crease incisions and we decide the amount of, the length of the incision which is to be taken. We can go as small as 2 millimeters to 3 millimeters. Here I've gone with 5 to 6 millimeters of incision. Giving less than a cc of local infiltration usually works, but if the patient is very apprehensive, we can go ahead and inject a little more and can use the blocks as well. So the usual steps are followed, where we kind of undermine the levator aponeurosis, dissect the pre-aponeurotic fat, and look at the junction of the muscle and the aponeurosis. And a single tuck suture technique or a 2-tuck suture technique is what is preferred. Usually in a frank aponeurotic ptosis, single tuck suture techniques work very well and gives a good contour, unless the lid laxity is more and you need to have an additional medial suture, which may be helpful. So these are some of the results where I had gone ahead with a small incision aponeurotic ptosis, levator advancement or tucking. And this was a gentleman who was almost 95-year-old, and he wanted the lid to be elevated because he had difficulties in reading. This is immediately post-operative. I don't have his later pictures because he never appeared back to me, and probably no news is good news. And even in bilateral asymmetrical ptosis, one can achieve pretty symmetrical results without dealing with any kind of dermatochalasis and just lifting the eyelid up. In cases with blepharochalasis with ptosis, again, it works beautifully, where you can have minimal amount of a single tuck technique with excision of the extra skin, which can be done. So we have published few chapters and papers in various books about evaluation and advancements in ptosis surgeries, and one can go about it. The tips which I want to just give is that in this technique, where basically you walk up towards the aponeurosis, towards the superior transverse ligament, slight medial approach provides better contour, and do not always consider the lid crease as the landmark to start the surgery. Wherever the lid fold falls and you get a good contour is where you can take in the tuck-in and the incision. So thank you very much for your kind attention.
Thank you, Shubhra. That was very good. I think, Milind, you can add certain points to it because yours has an additional element of blepharoplasty. We'll look at that and then we can conclude.
So I'll be talking about levator surgery with blepharoplasty, and okay. So I'll quickly touch upon blepharochalasis, dermatochalasis, any associated conditions with that, and in general about ptosis with blepharoplasty. So apart from the regular evaluation that we do for any ptosis surgery and the measurements, I would always measure the anterior lamellar height, as well as the tarsal plate show and the brow height in these patients. And looking at the old photos always helps in, especially in blepharochalasis cases, to note the findings over time. Now, for the benefit of those who do not quite understand the differences between the two, blepharochalasis usually occurs in the young people, and it has intermittent swelling, whereas dermatochalasis is a gradual aging change. There is thin peppery skin in blepharochalasis, and lacrimal gland prolapse is often seen, whereas that's rare in dermatochalasis. And blepharochalasis can be unilateral or bilateral, whereas dermatochalasis as an aging change is essentially bilateral. If you're suspecting myogenic cause, you can do the necessary tests for the same. And the additional factors that you would want to look for in dermatochalasis cases is what is the angle of the lateral canthal descent as we age. And we all know that the lateral canthus being lower than the median can give a tired or a sick look to the eyes. Lacrimal gland prolapse is particularly common with patients of blepharochalasis because of the excessive fat atrophy due to the swellings. So in the excision, we would want to leave at least 20 millimeters of anterior lamellar height. And so the skin excision is performed first. In the temporal half, we could excise orbicularis for a brow height benefit, to the same incision fat removal if required. And at the lower edge of your incision is where I would expose the levator and reattach to it. I'll skip the quick video. But the additional components that might be needed in this surgery are fat removal, levator reattachment. That's the primary reason why we are performing the surgery. Lacrimal gland fixation and blepharochalasis if that's necessary, and lateral canthoplasty, which I perform in the form of a lateral canthal resuspension. So you start from the lateral orbital rim, you go in the suborbicularis plane, hitch the lateralmost part of the tarsus, again go back through the same opening and come out onto the periosteum again. So it's a miniature version of the tarsal strip. And lacrimal gland, if prolapsed, can be refixated to the superolateral orbital rim just within it. So a quick review of photographs here. These are all cases of blepharoplasty without ptosis. But here are some of the examples of blepharochalasis and ptosis, where you fix the ptosis, remove the excess amount of skin. This lady had bilateral asymmetric, so we operated one eye followed by the other. There is a slight overcorrection on the left, but she is happy. This is a unilateral case with excess and super thin skin, and we also had to operate the other eye to match it because it really drooped after the left correction. Another case of blepharochalasis and ptosis and also vitiligo, which was operated sequentially. In cases of dermatochalasis, whether if it's pseudo, we can always fill the brow and avoid a surgery. Option of not doing anything to it at all and just addressing the ptosis is also to be considered. But when we do levator resection, a very small amount of skin excision and a lateral canthoplasty to move the canthus up definitely helps. And this is the final slide where there was a cord blef done. You can notice the left mild ptosis, which was addressed as an MMCR add-on to the left eye. So just to summarize, for blepharochalasis, we have ptosis, lacrimal gland prolapse, and excess skin to be managed. Dermatochalasis is primarily an aging change with several options of treatment. And associated conditions in these cases are lacrimal gland fixation, canthoplasty, fat removal. And combined surgery is possible in these cases. Thank you.
Thanks for those two wonderful talks. I think we've had a very good overview of what to do in an acquired ptosis with or without associated dermatochalasis or blepharochalasis. I think this is now time to say bye-bye to all of you because we are pressed for time, but would like to thank all of you for this very stimulating session. I'm sure we could have had an even more stimulating discussion with this wonderful panel, but I'm sure we'll get that opportunity to be all together sometime in the near future, possibly physically. And thank you all very much.
Thanks to all the speakers. and the
Thanks
organizers.
particularly to Santosh and Ganga for our keynote address, and for Santosh for organizing it, and Hyderabad Ophthalmic Association for giving us the opportunity to be together. Milind, thank you very much.
Thank you. Thank you, everyone.
Thank you.
We'll leave it to the next session.
Hi, very good evening, and without due, because we are already running, I think 17 minutes late. I think without any delay, we'll get started with our session. And I thank, at the outset, I would like to thank Hyderabad Ophthalmic Association and Rishi for inviting me to organize this session. And I'm really thankful to all the speakers and panelists who have agreed to be part of this program. So today we have with us Dr. Rohit Shetty from Bangalore, and we have Dr. Suzuka Ko from Japan. We have Dr. Himanshu Matalia from Bangalore, Dr. Rajesh Fogla from Hyderabad, and Dr. Kavita Rao was supposed to join us. She'll be missing us due to some other commitments. And then we have our young Vivek Mahendra Singh, who would be one of our speakers as well. Without delay, we'll get started with our keynote talk, and we'll ask Dr. Rohit Shetty to get ready with the slides. So I would like to introduce Rohit. He's been one of the great speakers in the recent times. You see him talk on, every time he talks something new. And he's the vice chairman of Narayan Netralaya, and he's a translational researcher. And his specific interest has always been in refractive surgery and corneal ectasia. He has several publications and awards to its credit. I think Dr. Rohit is going to talk to us today about how will imaging define us in the next 10 years. Rohit, we are looking to hear a lot of new things from you in the next 15 minutes.
Thank you, Dr. Reddy, and thanks the Hyderabad Association and all the co-panelists for giving this opportunity. My talk is about how I see the imaging in 10 years, and these are my financial interests. I do work for research grant with many companies. The biggest disclaimer is, which I want to say is that whatever I'm going to speak today will look totally out of context. And this is what happens to all these people in the world. Every single person, I don't need to explain all these people to you, and we know where their innovation is today, and some from our own domain. So I have picked up certain innovations which I look crazy, but what I've done is I picked up from what is happening around the world, and also some of our work which we are doing, which I feel in the next 10 years would shape up to something very interesting. So I've divided my talk into these things. It's very difficult to combine a lot of stuff in this 10, 12 minutes I have got. Aberration, biomechanics, Suzuka is here, Dr. Suzuka, she's a fantastic speaker, and I'm going to skip a lot of my slides there, and about how you combine all these factors together. So when we go into aberrations, of course, refractive surgery is one domain, and we always know about aberrations. And one thing which we always know is that, you have aberrations, you treat everything. And that is what has been told from every aberration is bad. To cornea surgeons here, if I ask Dr. Himanshu, and I learned a lot of ocular surface from him, and ask him that there are bacteria in your ocular surface, would you want to kill all of them? I'm sure his answer would say no. I would not want to kill all of them, because ocular surface health depend on your bacteria. The exactly same thing. You have gut bacteria. Would you kill all gut bacteria because they're bacteria? today's refractive surgery is all about killing everything, knocking off all aberrations. We have no control on what is good, what is bad. You just knock all of it. But what I see is the present machines today are all kinetic, or static. They just give you aberrations. They don't care about whether you improve or correct. But what I feel in the next 10 years is going to be the aberrometers are going to be much, much more smarter. We use adaptive optics aberrometers in my practice. And this is a small video of how we are able to change the aberrations and pick up which is the good commensal aberration and which is a bad commensal aberration. And this is a fantastic way to see what I should correct. Now, the question is, can all machines actually correct those? Not all. Schwind is one of the machines. I know financial interest, but as technology, they have allowed things to be, you can use, sorry. You can actually use machines to actually correct what is necessary and what is not. So what I've been trying to do is, we've been trying to do it in keratoconus, trying to correct selective aberrations and not to correct all of them. And you can see that these are some of the results of, say, 1 year post-ops, where by keeping some aberrations, we are able to achieve better results than what we would if you correct everything. So this, I think, would be a big change over the years to come. And quality of vision, the tissue change, everything would differ. There'll be a lot of work on AI. I think Dr. Jagdish Reddy is one of the pioneers of AI in this country. And we also been working for the last 7 years on AI prediction. And we thought we built our own AI, and this is something which it's in the final stage, it's an accepted review, is about building our own AI to look at the progresses using all the indices. And we were able to predict a very, very close prediction in terms of which one would progress from the minute the patient comes to you. And what is going to happen is this AI is going to come to your smartphones or your laptops or your computers. And we also build one of it where these AI would be the ones which will help you to predict which one would progress and which one would not. And that is what I think would say every aspect of refractive surgery would have a machine learning or AI in it. Biomechanics, I'm sure Dr. Suzuka will speak about it, but are different biomechanics versions. But what I would like to see is the way the corvus, which is the biomechanical, is going to be. So now it measures only one direction. In the future, I think you'll have multiple directions. Brilliant microscopy is one of the potential futures. I don't know how clinically relevant it is going to be, but we'll have many of his brothers and sisters, which is going to come to the practice. A great change was integration of biomechanics into the refractive surgery, use of your CBI, TBI, and all these factors. Like in this patient, you have the patient like refractive errors like this, but the biggest confusion today is your BAD is normal, CBI is red, CBI. These are the two factors. Now, what do you do with them? The problem is, that is where I think we would probably have a better understanding in 10 years. Why do they have? So what we decided is just a value of deformation amplitude would probably not be the way to go. This was a part of two of my PhD students, Matthew Francis and Pooja Kamar, who did the work, and with the first predictive modeling, where you could predict the amount of change of dotted lines where simulation and real lines were actually what happened to the biomechanics after the surgery. It was very important because we could predict how much of biomechanical drop each surgery would do. So what we did was we built an AccuSim. This is how the future is going to be. Everything is going to be AI or predicting models. I think it's going to be in refractive surgery, cataract surgery, and everything. What is AccuSim? Is one of the world's first simulation model, which is now we are in the last stage of beta testing. It will be probably incorporated into a lot of your Oculus and other system, where you add the biomechanics and topography CSV files, and this is a small video. I'll just play. It's a real time. It happens in the clinic, and now it takes a little time. All these data are added into the patient's, taken from patient's data. And this runs an AI finite element modeling, and it runs in finite element modeling, mathematical modeling, plus it runs an AI on it. At the end of it, it will tell you how much, what procedure would cause what amount of biomechanical weakness. So then I decide on whether I should be, and you can see that I'll just quickly run this video. And this is a report which you're getting now. It will tell you it's not in deformation amplitude. It's a predictive change in stiffness. That means if the stiffness is heavily differed, then what happens is the patient, you should probably avoid a particular surgery. For example, the change in the stiffness, the biomechanical change is 9 newtons per meter square, and here is 26. So you would probably defer, you would do a PRK on this and probably differ on this, because 20 newtons is a huge amount of biomechanical weakness. So this is going to be the way, and this is not just based on a few samples. There are thousands of patients, and this is based on also patients who developed ectasia. So it's a machine learning algorithm, and just like your Hill RBF and one of these formulas, but it gives you a surgeon an idea about what he should do and whether he should do something or should avoid some procedures. The biggest masquerades in during these kind of procedures is refractive surgery is epithelium, because what we are supposed to measure is from your stroma, the garments, but what you're measuring is from the epithelium. And we have new tools now which is looking at the stromal mapping, which is the way we should look at. And for example, you see that this is the area of elevation, and this is matching to this, to the epithelial thickness. This is an epithelium thickness, which is out here. So that means that the cornea is actually completely changed because of epithelium. And what I would like to say in this platform, in the next 3 or 4 years, we'll see a heavy load of epithelial changes happening because of the mask we wear. And the ocular surface is changed because of the mask. And all our topographies are going to look very, very, very odd. And in this case, your biomechanics is normal, even though the bad D is abnormal because of epithelial changes. So epithelium is going to be a very important factor, and understanding the stroma is going to be a very important factor. For example, look at this, looks like a keratoconus, but this is an epithelial change. And look at your biomechanics, it's normal. It's a fantastic case which says that if this case had no epithelial mapping or stromal mapping, and just look at the stroma, it's completely normal. All greens are normal. So that means that we would have ended up calling this as a keratoconus. So the next wave of imaging is going to be not the imaging from the epithelial surface, it's going to be stromal surface, and probably it's going to go deeper. And this patient actually had a microneuroma. We move on to the next generation of imaging. A lot of people are working on collagen imaging. Now we can only do it from the corneal buttons, but we started looking at this is a prototype model where we started looking at the cornea. This is how a electron microscopy picture look, and you can see that is exactly how the patient looks on our imaging model. And this is what happens in a keratoconus, and you can see that loss of signals changes. So imaging the real structure is going to be the next big wave. And I'm very fortunate to use this, and I'm sure there are a lot of people in the world who are using it. Confocal microscopy, various applications, and I'm sure that this is one of the very little used tools because of the cost and other factors. But you can see that, microneuromas to a lot of dendritic cells, a lot of areas of use. I think this is something which probably I'm seeing that there will be a resurrection of confocal microscopy, which will come in a very big way. Now, how do you bring the imaging to the real clinic? And for example, this I've discussed in the many platforms about looking at the tears. They're not true imaging, but what is happening is these are just like your blood reports, but from your tears, and all the molecules you see are the tears. And in this COVID time, we were fortunate that we were able to build it took some 6 years, but we were able to build our own point of care diagnostic kit. And you can see that this is the kit, and this is the ELISA-based kit, which we're doing in the clinic. And now we are able to get all this panel of inflammatory markers in them. So why is it important? I'll give you an example of this newspaper reporter. 6 years back, she wanted to do a report of tears and biomarkers with me. And she said, just do my tears and I want to put it up in an article. I did her tears, everything was normal. At that point of time, only thing which was high was a VEGF in her tears. It didn't. She was not an inflammatory eye, and she was not a diabetic. So I said, this is just incidentally increased in, and I just left it. 1 year back, she comes to me and tells me, a year back, when you took my tears, you found that the VEGF was very high. I want to tell you that just a week back, I've been diagnosed with ovarian cancer. Does it make a difference? We all know that ovarian cancers have been very implicated in a lot of VEGF changes. Avastin was first used for ovarian and GI-based cancers of anti-VEGF. So biomarkers in the tears and imaging could be the next big thing for Alzheimer's. A lot of people working in Netherlands, a lot of people working on Alzheimer's and breast cancer also. So imaging with the biomarkers will be the next big thing. From an ocular surface point of view, along with imaging, we could probably target different molecules with different drugs. We can have liftigravs, a lot of new things which may come up. How do you connect all this? This is very important, is that we have different technologies today, and we have published about some technologies like lysyl oxidase. Now we have imaging. This is what is going to be the connect. I showed you the elephant, the baby, and the mother. Is if you connect the biological tissues to the imaging, that will be the next big connect of the world. And you can see that the lysyl oxidase and how it differs, lower lysyl oxidase, how it differs on the imaging out here. So how is it, why is it important? Why is all this imaging important? In the next 10 years, the meetings like this, I hope it will be a physical meeting, will not talk about the surgeries, we'll talk about genetic modulations. And I think that is where I think we are all heading towards. Happy that we also are part of this lab which has the gene therapy. And I'm very happy that in this last 1 year, we attempted to look at certain genetic genes, especially the genes for gene therapy. And as we move on, this is one of the first mouse models where we have used the gene modulations. And this is a mouse imaging system which we did in our lab to see whether the mouse can change, the cornea can change with this gene therapy approach. So imaging is not about imaging your cornea or retina or glaucoma. It's just about mixing everything. So customization with adaptive optics, I feel, is a huge role. AI is going to pick up everywhere, and AI and machine learning, predictive modeling, I think it's going to be for cataract and refractive surgery in a big way. Collagen imaging and stromal imaging with confocal and machines like PSOCT is going to be a big one. Imaging the tears and combining it with outcomes is going to be the next big one. We need everything, because I feel in 10 years, we'll all be moving towards the gene therapy for many, many diseases, and that is going to be the future. This is the team of people in the lab. I thank all of them for making this happen, and thank you.
Thank you so much, Rohit, for taking us through every possible aspect of cornea that could play a role in diagnosing and predicting the outcomes of refractive surgery. I think we're looking forward in future being more predictive, so that every surgeon can be more safe, perform any procedure more safely, and be more confident with their patients, where you could say that they have a particular disease rather than saying or giving a differential diagnosis will be more clear in future. Thank you, Rohit. And we'll take up more questions as we go by. So we'll move on to the next talk by Dr. Shizuka Ko. So thank you so much, Shizuka, for accepting my invitation and being part of this session. And you're virtually in Hyderabad now. And it's a pleasure to invite you to this session. And I would like to introduce you to the audience here. So Dr. Ko is an assistant professor of innovative visual science at Osaka University. She's been closely associated with University of Rochester, wherein a lot of new products come in play from University of Rochester, which we've been using or we've been hearing over the years. And she's been closely associated with that group. And has several publications and book chapters to her credit. She's also received the Achievement Award from the American Academy of Ophthalmology. She has special interest in dry eye, keratoconus, and several other corneal diseases. Today, she will be talking to us on role of corneal biomechanics and refractive surgery screening. Over to you, Suzuka.
So can you see my slide? Okay.
Yes, we can
Okay.
see your slides and we can hear you clearly.
Okay, great. Thank you.
Thank
Okay,
you.
good afternoon, Indian doctors, and so thank you for the kind introduction, Dr. Reddy. It is my great honor to give a talk today. I'd like to thank the committee members for giving me such a great opportunity. Actually, I am very sorry that I cannot see you all physically. I've been to Hyderabad once 7 years ago, and of course, I enjoyed biryani at Paradise Restaurant. I know this is very famous, popular restaurant there. Today, I'll talk about basics of corneal biomechanics and its role in refractive surgery screening. The cornea is not a piece of plastic. This is a very famous phrase by Professor Cynthia Roberts, who has a great contribution to the field of corneal biomechanics. The cornea exhibits both viscous and elastic biomechanical behavior. Elasticity.
Sorry, Dr. Ko. Yeah, sorry. Your slides were not moving. Now we see your slides moving.
Okay,
yes.
okay. Elasticity is usually used for solid. It is the ability of a body to change its shape when a force is applied and to return into its original shape. When the influence of the force is removed, viscosity is generally used for liquid. It means a measure of its resistance against progressive deformation. What is stiffness? It is the overall rigidity of an object. Stiffness is defined as a measure of the resistance against elastic deformation as a response to the applied force. It is dependent on several factors. When we think about cornea, material in cornea means corneal biomechanics. Thickness is, of course, corneal thickness. Internal pressure means IOP. So stiffness of the cornea is dependent of corneal biomechanics, corneal thickness, and IOP.
Suzuka, it's not moving yet. The slides are not moving.
Moving?
Yeah, it's not moving. I think it's got stuck somewhere, I guess.
Okay. Not working? You cannot see my slide?
Yeah, we can see your slide only. The cornea is viscoelastic. That's the slide we are able to see.
Just a moment. Can I just
Can you stop share and again share?
Yeah, you can start sharing again.
How about, is it? Can you see my slide?
Not yet. Probably it's going to come. Yeah.
I think that so right now, I hope you can see the slide.
Not
8?
yet.
No,
So,
not yet?
yeah.
Okay, just a moment. Can you see my slide now? No?
No.
Nothing.
Not yet.
Not yet. Just a moment. Oh, sorry.
Can you share the slides to us, Doctor? We'll play from here. In the meanwhile, we can go to the next session.
Okay. So okay. Could you go to next session? I think you can speak.
Yeah, we'll no, you can. Do you want to share the slide so that we can move on to the next talk, or?
Okay. So could you go ahead for the next talk? So I'm very sorry. I can fix the my slide. Okay.
No problem at all. So we'll move on to the next talk
Yeah,
so that we can come back and continue the talk.
Okay. Thank you very much. So I'm very sorry.
No problem. Thank you. So we'll move on to the next talk, and then we have Dr. Himanshu Matalia. So Himanshu is the medical superintendent at Narayan Netralia, and he has a special interest. He's an all-rounder, I would say. So apart from being a good ophthalmologist who does everything in cornea and anterior segment, and is a good human being, and we would love to hear from him on the topic, which is his favorite, picking the right investigation modality for phakic IOL implantation. Over to you, Himanshu.
Thank you, Jagdish, and very good evening to all my friends of HOA. By phakic IOL, I mean ciliary sulcus fitted IOL, and I do not have any financial disclosure here. The lens is when we put inside the eye. Before the surgery is done, we decide about the pre-op assessment, and let's start with what we look at in, or what technology we look in the pre-op assessment. The first question arises, do we need a topography? I start with a case here, that a case with both eyes combined compound myopic astigmatism planned for toric IOL. However, the left eye, when the topography was done, when the pentacam was done, showed significant asymmetry. And you know that such kind of thing, the pre-op, the refraction of this patient in left eye was -5 with 1.5 cylinder. But if you look at this way, it's pretty irregular cornea. And the cylinder, what you're looking at, is basically average of the irregularity what you are seeing on the surface. So horizontal axis, which is highly irregular, has a diopter of 6.2 diopter difference in the horizontal hemimeridians. But with the average of everything, whatever you are seeing is basically just 1.5 diopter of astigmatism. So without a topography, if we had just gone ahead and did surgery with this kind of refraction, of course, patient would have severe ghosting and the outcomes would have been really bad. So all such cases which require phakic IOL, I would certainly suggest that we must do topography, whatever topography suits you. In my hand, I prefer pentacam. The reason behind using pentacam, I'll come to that later on, but there are certain parameters which we need for the ordering the lens or for deciding the lens. Few important of them are anterior chamber depth, horizontal wide to wide, which are most important for the sizing purpose. Starting with the anterior chamber depth, which can be measured by using any machines which you have, from your A-scan contact device to your optical device like optical biometers or IOL master, or something like topographers or tomographers. The anterior chamber depth has to be counted from the endothelium, and the safe cutoff value is 3 millimeter. But apart from the anterior chamber depth, there are a lot of things which we look at. One, pre-operatively, a good slit lamp examination to rule out any pseudo exfoliation, any pigments in the angle. Gonioscopy is very, very important. Also, when you look at the picture of your Schimflug imaging on your pentacam, which can tell you about the iris configuration, whether iris configuration is flat, whether it's convex, whether it's concave, and these things would give you a lot of idea about your peripheral anterior chamber depth. Apart from that, if you have anterior segment OCT, you can measure something called crystalline lens rise, where a line joining two ends of the eye pupil and the amount of lens which is projecting forward beyond that is your crystalline lens rise. If the crystalline lens rise is high, the vault is going to be low. So not just the anterior chamber depth, but there are a lot of other things you look in your devices, whatever you have. The other important parameters which we need is wide to wide or horizontal wide to wide. The ideal most method, what the company expects you to use, is your digital caliper, which is the most simple thing to do. Using a digital caliper, which is not very expensive, we measure the horizontal diameter of the cornea between the limbus, in the middle of the limbus, and we take it as our wide to wide measurement. However, I prefer to do it with two instruments. One, your digital caliper, but the second instrument can be whatever you have in your hand, whether a topographer like OpScan, IOL Master, or tomographers like Pentacam. However, please remember these readings are not intervariable. They have quite significant variability, and they do not have significant correlation with each other. So my own eye, if you look at my right eye, the measurement on different devices is significantly different. So what I prefer is I stick to one particular measurement in my hand, which is pentachem. And horizontal pentachem, what you can see here, I do an image inversion of the Scheimpflug image. I take the measurement from there, feed it in my digital caliper, and then confirm that. So my way of measuring is that I take this kind of horizontal image of Scheimpflug image of pentachem, do an image inversion. Image inversion increases the contrast, so you can measure it very accurately, and then feed that into my digital caliper and confirm it. So this way, using pentachem, which gives me a baseline measurement, which I use it for my digital caliper. So why do I prefer pentachem? Well, pentachem helps me in looking at the pre-op irregularity. It helps me to rule out cases for LASIK where I can do LASIK, phakic IOL. It also helps me in measuring the anterior chamber depth, not only the center, the peripheral anterior chamber depth, white to white, and also can help me in post-op assessment of wart. Now, when we talk about white to white measurement, the interesting part is the lens is fitted in the sulcus and we are taking white to white. Now, is there correlation between that? Now, classically, we are taught that white to white, horizontal white to white is a little bit larger, almost 0.4 to 0.5 millimeter larger than white to white. Now, if you look at the literature, the correlation between sulcus to sulcus where the lens fits and white to white what we measure is extremely poor. So whatever we do, there are chances that whatever measurement we have taken may not be the right surrogate measurement for what we put inside. So why can't we directly measure the sulcus to sulcus? Now for that, the instrument used is ultrasound biomicroscope or UBM. One such UBM from Quantil help to measure your sulcus to sulcus very accurately. It also allows you to do a simulated vault for your ICL, and which can possibly help you to choose your model. So does it mean that the mystery is solved and we are absolutely fine? Well, interestingly not, because there is very high repeatability issue with the ultrasound biomicroscope also. It's also user dependent. If user has not taken the measurement correctly, you may have a fallacious measurement. So having said that, the ultrasound biomicroscope is an excellent machine to know about your sulcus to sulcus, but possibly this is still not the gold standard. Now, whenever we do any corneal surgeries, especially the intraocular surgery, these are the cases which we would be scared of, like endothelial guttae or Fuchs endothelial dystrophy. Preoperatively, whenever we do specular microscopy and when we find there are significant guttae and endothelial density is low, please avoid phakic IOL. So a preoperative specular microscope can also be a very good device. If you have it, you must use it. However, clinically on slit lamp, you can see significant guttae if the endothelial density is very low. You would be able to see the difference on the corneal thickness on pentachem also. However, if you have it, you must use it preoperatively. Post-operatively assessment, coming to that, the most important outcome measure for post-operative assessment is the vault, the distance between back surface of lens and the anterior surface of the natural lens. The normal vault is 250 micron to 750 micron. Depending upon individual case, you can have the vault which can be acceptable. Now, if the vault is very high, more than 1000 micron, you can have shallow anterior chamber pigment dispersion, angle closure glaucoma. The vault is low, then you can have cataract and you can have rotational instability in toric lenses. So adequate vault is very important. Interestingly, your Scheimpflug image on pentachem can assess the vault. It may not be extremely accurate because of the low resolution. However, it does not matter because for the clinical purpose, you should be absolutely fine. But in case if you have anti-segment OCT, your measurement of the vault can be much more accurate and can be much more reliable. So before you have any complication or before you decide about explanting the lens, again, the use of ultrasound biomicroscope would be very important, because it will help you to know the position of your haptic, if there is any kinking of haptic, if there are any ciliary body cysts, or what is the true sulcus to sulcus measurement. So even before explantation or with any other complication post-operatively, an ultrasound biomicroscope can certainly help. Finally, to summarize, which are the investigation which I would prefer, that one mandatory part is digital caliper, which is absolutely must for white-to-white measurement. The essential one, which in my hand would be mandatory also, which is Pentakin, which helps you in ruling out any surface irregularity of the cornea, which helps me in measurement of my white to white, also helps me in measurement of anterior chamber depth in center, periphery, angle to angle measurement, and also can help you to measure the vault. The ultrasound biomicroscope is optional. If we have it, we can surely use it, and which can help us to measure sulcus to sulcus, anterior chamber depth, and even angle to angle measurement. It can also help us to visualize the haptic under the iris, and can also diagnose ciliary body cyst, and vault can be measured there too. Finally, anterior segment OCT can be very important tool to assess the vault post-operatively, and it can also help us to measure crystalline lens rise along with anterior chamber depth and angle to angle measurement. Thank you very much.
Thank you, Himanshu. That was a wonderful talk, and a lot of points to take away from the last slide. I think having a verification from two devices from white to white is very important, like so that you know your values are correct, and then verifying them, and sticking to one device which gives you predictable results is also very important. I think thank you so much, and we'll move on to the next talk. Himanshu will take more questions later based on time.
Sure.
Okay, so Suzuka, do you want to go ahead with your presentation? Your mic is mute. Can you unmute, please?
Okay.
Yes.
So now I'm actually sharing my screen. Can you see it?
Yes, we can see your screen now.
Okay. So you can see the slide 4. Okay.
Yes.
Okay. Okay. So did you see this slide? No.
Yeah, we see a slide which says the cornea is not a piece of plastic.
Okay. Okay. I can start here. Okay. The cornea is not a piece of plastic.
Yes.
Okay. So this is a very famous phrase by Professor Cynthia Roberts, who has made a great contribution to the field of corneal biomechanics. The cornea exhibits both viscous and elastic biomechanical behavior. Elasticity is usually used for solid. It is the ability of a body to change its shape when a force is applied, and to return into its original shape when the influence of the force is removed. Viscosity is generally used for liquid. It means a measure of its resistance against progressive deformation. What is stiffness? It is the overall rigidity of an object. Stiffness is defined as a measure of the resistance against elastic deformation as a response to the applied force. It is dependent on several factors. When we think about cornea, material in cornea means corneal biomechanics. Thickness is, of course, corneal thickness. Internal pressure means IOP. So stiffness of the cornea is dependent on corneal biomechanics, corneal thickness, and IOP. The pathophysiology of keratoconus is likely to include the following components: genetic disorder, biochemical disorder, biomechanical disorder, environmental disorders. This is the theory of development of ectasia. Before corneal curvature or thickness changes due to the disease, The corneal stiffness and elasticity is already changed. Therefore, corneal biomechanical assessment is crucial for detection of subclinical ectasia. As clinical significance of corneal biomechanics, assessment of accurate IOP is helpful for consideration of glaucoma risk factor. Regarding to keratoconus and ectasia, it is useful to detect subclinical status and to monitor progression and efficacy of corneal cross-linking. Currently, 2 clinical devices are commercially available for measuring corneal biomechanical properties: the ocular response analyzer and the Corvis ST. In my university clinic, we are using Corvis, so my talk is based on Corvis. Corvis is a novel non-contact tonometer that allows investigation of the dynamic reaction of the cornea to an air impulse. It is based on ultra-high-speed shine-proof technology. Shown here that obtained movies from normal eye and keratoconic eye. This is a dynamic corneal response display. Several parameters are shown. This is the Vinci-Guerra screening report. At the bottom right of the screen, there is a box with 5 parameters. These are first 4 parameters, and colored one at the right end is Corvis Biomechanical Index, CBI. CBI is calculated based on the corneal thickness profile and deformation parameters and ranges between 0 and 1. It is used for detection of clinical and subclinical keratoconus. Let's take a look at these parameters a little bit more. I believe that some of you are not familiar with them. I'm going to explain them very simply as a clinician. Except for ARTH, other 3 parameters are purely biomechanical parameters. We will focus on these 3. Deformation amplitude ratio 2 mm, DA ratio 2 mm is calculated based on the ratio between the deformation amplitude at the corneal apex and the deformation amplitude at 2 mm nasal and temporal from the apex. Softer corneas start to deform only in the center, where the percentile part of the cornea deforms much less. Therefore, the DA ratio is higher in softer corneas than in stiffer corneas. The central radius of curvature is calculated during the concave phase of the deformation. Softer cornea exhibit a smaller radius, so the inverse radius is higher. The area under this inverse radius versus time curve is determined, and it is called integrated radius. Thus, the integrated radius is higher in softer corneas than in stiffer corneas. Stiffness parameter is calculated based on the difference between the strength of the air pulse at the corneal surface and the biomechanically corrected IOP. The displacement of the corneal apex at the time point of first sublumination is measured. Therefore, the stiffness parameter is lower in softer corneas than in stiffer corneas. Use the force, feel it. Okay, let me share with you cases from our clinical practice, not in galaxy far, far away. Keratoconus is generally present bilaterally, although often asymmetrically. In certain very asymmetric ectasia cases, the contralateral eye may present form fluid keratoconus, FFKC. According to the global consensus on keratoconus.
Shizuka, sorry to interrupt. Like your slides are not moving once again. We can see.
Oh,
yeah.
Really? So what? Which?
We can see the Corvis ST softer cornea slide.
So, which this one? No.
Yeah, we have the different indices depicted.
Oh, okay.
Yeah.
Okay. Which slide number is what? What slide number?
Okay, I cannot see the slide number. You have the softer cornea and stiffer cornea where you have all the indices explained.
I used to be okay. Okay. So just a moment. Can I Can you see the screen now?
Not yet. It says that you're sharing the screen.
Screen.
Yeah.
I think now it is shared. No, it's coming.
Yeah, it says that you just started screen sharing.
Screen sharing.
Yeah, we didn't. We cannot see the slides yet.
Oh, really?
Okay. Yeah.
Did you see the Corvis movie slide? No.
No. We saw that. Yeah, we saw the slides. Those slides.
Those slides. Okay.
Yeah. Okay. In view of time, would you like to summarize so that we can move on to the next talk?
Okay. I think that would be nice.
Because
okay.
we have.
I'm very sorry. Yeah.
No problem. Yeah. Yeah, would you like to just summarize your talk, Dr. Ko?
Yes. Okay. I can. Okay. So.
4 minutes.
Yeah.
Without screen sharing, if you can try, Doctor, to summarize.
Yes. Okay. Can you see my slide now?
Not yet. Yeah.
Not yet. Something is wrong. I'm not sure why
Dr. Ko, if it is okay, you can summarize without screen sharing.
Yeah, you can do that. You can just summarize without the slides.
Summarize. Okay.
Yeah.
Okay. So I can show you the summarize slide. Okay. Can you see now? No, not yet.
No, not yet.
I'm not sure. For some reasons, something is wrong.
Okay, so what we'll do is we have next talk with different cases. So probably you can keep adding your inputs into those cases.
Okay,
It would be
definitely.
great. Yeah.
Okay, I'm very sorry.
No problem. Yeah, I can understand.
Okay.
So now we have Vivek Mahendra Singh, who's our youngest faculty at LV Prasada Institute. He will be sharing with us different case scenarios, and we can discuss a few of the cases before we conclude the session. Over to you, Vivek.
Are my slides visible?
Not yet, Vivek.
Can you share again?
Yes, I'll do that again. Is it visible now?
Yes, Vivek.
Okay. Thank you, Dr. Jagdish. Thank you, everyone. So I have series of 10 cases, but then I think we are short on time, so we can stop at any point of time. So my case one is a 26-year-old lady who presented to us in our clinic, and she wanted a laser vision correction for her marriage, and she had compound myopic astigmatism, and her refractive error was close to minus 5.5 diopter spherically in both the eyes. So these were her scans when she presented to us. You can see there's mild, the scans are slightly on the steeper side. However, the bad maps were appropriately were exactly normal, and if the left eye was also more or less similar to the right eye scans, and if you look at the bad maps, all the bad Ds were absolutely normal. So in a regular case, we would definitely go ahead with the laser vision correction for this lady. However, she had not come to the clinic alone. She got her younger sister also. Her younger sister was 2 years younger to her, and she had a refractive error of close to minus 5.5 in the right eye and minus 3.25 with significant amount of slender in the left eye. However, she also had a scissoring reflex. These were her corneal topography maps. If you can see on the curvature map, you can clearly make out the asymmetric bow tie with inferior steepening, and the steepening correlates with the thinning location as well. And at the same location, you can appreciate the elevated point as well. These were bad maps, and in the left eye, it was even more severe than the right eye, and you could appreciate the keratoconus over here. So my question to the panelist over here is, the question is the same. What the question is the same that the patient had asked me, the elder sister had asked me. Had she not got her younger sister, would you still not operate at me upon me? So my question to the panelist here is, how do we deal with the tip of the iceberg here? How do we, so in general, not all the patients will get their sisters and siblings to the OPD, and they're not getting the scans done. So how do we deal with this problem?
Vivek, one thing about your scan is, if you go back to your patient scan, the left eye, there is a scaving already.
Yes.
You can go back, yeah.
The first patient, right?
First patient, the sister.
Yes,
Look
yes,
at this.
yes.
There is 20 degrees. So this, even though your bad D and all your other parameters are very healthy, one thing is in the curvature maps, this is from our old Placido concepts, which because of the modern day topographers, a lot of us have missed, a lot of us ignore looking at the curvature maps, especially the scaving and all these factors. We just go into the bad Ds and all this. So I feel that when there is some amount of scaving in this kind of picture, even with the healthy one, there are times when we would do a PRK on this patient, even without, imagine that I'm not seen the sister and I don't know anything about the family.
Yes, exactly. My question was, would you go ahead with the surface ablation in this lady as well, or you would want to wait for some time before planning for surface ablation, even for this scaving which is there in the left eye, sir? So would you want to?
She's 25 years, I guess.
Yes. 26
so if she's 25 years and if she's married, then I would give a wait for a year.
Yes.
And see, these people don't really progress very fast. I mean, waiting is a very difficult word, because sometimes, it's about do or don't do. See, I mean, these patients would take even 10 years for them not to do. So this is where sometimes biomechanics really helps. So biomechanics, if the biomechanics is poor with a very normal topography, then you know that the topography is normal, but the biomechanics is weak. So that is where we use the role of a biomechanics here. So especially in this patient, Dr. Suzuka would agree that this patient will have the CBI being abnormal and the TBI will be normal. The TBI uses a lot of data from your topography. So it will still be normal, but I would expect the CBI to be very abnormal. This is one of those conditions. And that is itself a very important point for us to understand that there is something going wrong in this patient. So I would wait for a year or two. And if she finishes a family and everything else, then do a PRK. I would not hesitate to do a PRK if the biomechanics is normal.
Okay, great inputs, Dr. Aris. So I'll just jump to the second case here.
I will let ask the
Yes,
others'
yes.
opinion, Dr.
Yes.
Himanshu and Jagdish, if they have any differing opinion on this.
So I totally agree with you that I would look at the corneal biomechanics, but there are two things which we are looking at here, Vivek. One is if we do surgery, will she get ectasia? Well, that's a $1 million question. Even we know that there are enough studies in form of rustic keratoconus PRK and they've not progressed. So post PRK ectasia, again, not common. We are looking at really rare scenario. So even if she had not come with her sister and you had done ectasia, it's fine. I mean, you had done PRK, it's fine. Now, if she has come with her sister and if at all you do your PRK, you still may be fine. Now, the problem arises, you're talking about ethical issue as well as you are talking about the legality here. So are we on the right side of ethics? Are we on the right side of the legality? And that's where, as Rohit said, that even though we know that nothing might happen by doing PRK for her, but we might as well be on the safer side by waiting for some time and possibly proving it that things are quite okay.
Okay, thank you, Dr. Himanshu. So I'll just move to the second case. This is a case of a 23-year-old doctor. She had a very moderate amount of refractive error, and she presented to us with these kind of topography scans. If you see again, the curvature map here is very steep. The Kmax is about 47.7, and also the lowest pachymetry can be seen as 483. If you go on the bad Ds here, these are all D-range over here. If you compare the left eye, so these scans are a kind of proper enantiomers that you see, and as Dr. RS pointed out in the previous patient, there is a significant amount of skewing also which is present in this patient. The left eye also scans are also kind of similar with the right eye, and there's some amount of derange Ds over here as well. Now, important was to notice that the corneal diameter here was 10.8 in both the eyes. Now, if you have a corneal diameter as small as 10.8, you tend to expect some amount of elevation, falsely positive elevations on your bad Ds. Now, my question to the panelists here would be, if you have a scan like this, and certain elevation points here with a small corneal diameter, what would be your take? How would you proceed? Like, are you going to neglect these false positives, or how do we ensure that these are false positives and not some suspicious values?
So Vivek, I would certainly not disregard that. When you have smaller diameter, we've seen that you do see posterior elevation, but it seldom comes on the anterior surface and does not show up as skewing. It does not show up as low corneal thickness. So look at the number of red flecks which you're getting. Your pachymetry low, steeper cornea, skewing you are seeing, posterior elevation, anterior elevation, your bad D abnormal, exclusion map being abnormal, many red flecks which you're looking at. So I'm certainly not keen on doing a refractive procedure for this gentleman. Now the question arises, do I do anything, treat it as a keratoconus? Well, in that case, possibly if the refraction was stable and a patient is, we are able to follow up the patient, I don't mind following up in this case a little longer and have a look at how the things will be in future. Also keep in mind that we must look at the other parameters of corneal biomechanics if we have things available in our hand.
So if the scans are stable and the refraction are stable for a couple of years, would you still go ahead with the surface ablation?
I've closed the door for refractive surgery for me in this particular patient. Well, somebody can do it, and again, as I said, that surface treatment for many cases may actually turn out to be quite okay, and they may not progress also. But no, I don't think I would want to do it for the refractive purpose. I mean, I'm just going to follow up this case for ectasia purpose and keratoconus.
Hi. Actually, I have the same opinion. So, because some abnormalities detected with pentacam in bad display, so definitely I don't want to do refractive surgery. So, I don't think this patient is not for the candidate for refractive surgery. Keep observation.
Okay, great. So I'll just move on for the third case. This is a case of a 14-year-old female, and she presented to us in October 2019 with complaints of blurring of vision. Now, she had some significant amount of cylindrical error when she presented to us. Her best corrected visual acuity in the right eye was 2050 with -3 cylinder, and it was 2080 with -6 cylinder. These were her scans. She had severe amount of keratoconus. Her lowest pachymetry, as you can see here, is 430 microns, and Kmax was 55 diopters. In the left eye, it was close to 63 diopters. It was even severe than the right eye, and the lowest pachymetry was 406 microns. However, the patient had severe allergy, and we decided, and she was 14 year old, so we decided to wait, treat her allergy, and for some time, and then subsequently, in the next follow-up, plan for collagen cross-linking for the left eye first, followed by the right eye. Now, when she presented to us after 1 month, we followed the patient up after giving anti-allergic medication. When the patient came back to us after 1 month, her best corrected visual acuity in the left eye had improved to 2050 parts. Earlier, it was 2080. She was a bit comfortable. However, some amount of allergy still persisted, and we decided to continue the anti-allergic medications for a few more months, and then called her up for another follow-up after 3 months. So when she returned after 3 months, her visual acuity in the left eye had improved to 2050. However, if you can see, there was significant drop in the amount of her astigmatism as well. And these were her comparison scans. If you see, there's a lot of flattening which has happened in the scans. This is for the right eye. You can see a lot of flattening which has been noted between the two visits. And similar was the picture for the other eye as well. So my question here to all the panelists is, do we overtreat at times? Do we, just in case if this patient did not have an allergy, we would have straight ahead gone with the left eye collagen cross-linking. And
Vivek, your left eye did not show much change. So
yes.
It did not show much change, right? So I think what we are dealing with here is like how Rohit was showing. We are looking at the epithelial changes which occur typically in all these VKCs and all these eye rubbers and all those things. So I think Rohit can take over. Rohit, you want to come in this thing?
Yeah, I agree with you. We've been looking at, we call it as a pseudo stabilization. And we do see a lot of these things. I agree with Himanshu. Epithelium plays an important role. The other thing I want to tell you here is, which is again, Dr. Himanshu's work, it has got published also. Especially in children with a lot of VKT, when they are not able to focus on the scans properly, there are a lot of edge detection. In the pentacam, you can actually go and see. Now it is mandatory in our practice that every case of progression or non-progression, we go to the pentacam, look for edge detection. Because if there are some areas which are not correctly detected by the scan, the machine automatically extrapolates it. So when you do a repeat scan, sometimes you see an aggressive progression, sometimes you do an aggressive flattening. This is one case I would suggest, and this is a take-home point for everybody, that when you see something which is out of ordinary, you may see a 5 diopters flattening without cross-linking or a 5 diopters progression in 1 month. Please go back and look at your edge detection. This is Dr. Himanshu's concept, and we published it, and now it is a mandatory one. So I would request to go back and check the previous edge detection. Even though the quality of scan is saying okay, the machine there would have extrapolated a lot of data. So epithelium and edge detection will be the two important things in this particular case, because I still feel, because it's a 414 microns cornea and is a young patient, I still give him the benefit of doubt and treat him, because it is just like your COVID second phase and first wave, second wave. They were just giving you a little time to comfort, because the second wave of this will be very aggressive.
Totally agree.
Yeah, thank you so much, Rohit, for those inputs. And I think in view of time, we need to close this session. And I thank Rohit, Suzuka, and Himanshu and Vivek for doing wonderful talks. And then, sorry, Vivek, we have to wind up here. Otherwise, you had a lot of interesting talks that would give us a lot of points to all the delegates. So
Thank you, Jagdish. Thank you,
Jagdish.
Thank you, and then thank HOA, and good luck with the next next sessions. Bye bye.
I'm very sorry about my trouble.
No problem. Thank you.
Thank you.
We were just giving you a little bit of time. So the second wave of this will be very important.
Thank you so much. I think in view of time, we need to close this.
Hello, everybody. I'm Dr. Madhukar Reddy. Welcome, Dr. Sharaz Daya. You've been waiting since quite some time. We have less time, so what we will do is we will let the presenters present their cases and have 1 minute of tips by them. And then at 6:45 sharp, we'll give the podium to Dr. Sharaz Daya so that we can listen to his interesting capsules. Is that okay? So, Dr. Murthy, can you please take over? I'll just give me a minute.
Thank you, Madhukar. Can you hear me?
Yes, of course.
All right. So this handsome young gentleman is Dr. Madhukar Reddy, who's my co-moderator for this session. And the first discussant for the next session is Dr. BSR Murthy. Let me quickly introduce him. Dr. Murthy has done his MBBS from Bellary, followed by further training at RP Center or AIMS, and he was a former faculty at LV Prasad Eye Institute. He's a very proficient high-volume cataract surgeon as well as refractive surgeon, and does both pediatric and adult corneal surgery. He has multiple national and international presentations, and as well as more than 40 international publications. He's a member of ASCRS, apart from other societies. So we call him Bala, and we're not related, although at LVP they used to ask, he has done his MBBS from so Bala is going to share some interesting clinical pearl which pertains to posterior capsular rupture and vitrectomy. Cataract surgeon as well as refractive surgeon, and does both pediatric and adult corneal surgery. He has multiple national and international presentations.
Muted.
Despite the advances in the field of cataract surgery, the posterior capsular rent is the most common potentially sight-threatening intraoperative complication. And there are many factors for this, where it can be because of the surgeon-related or it can be because of the patient-related. If you see this, the mature cataract, the intumescent one, you can see the wave actually which passed through suddenly when the hydro was done. We are proceeding with the phacoemulsification. It's very important for us to note that in situations where other eyes has a PCR, when or there is a posterior capsular rent actually which is anticipated, it's always better to do a slow motion phacoemulsification with parameters being very low, such as low bottle height, the phaco being very slow, and no abrupt movements actually inside the anterior chamber. Still, actually, in this case, it's a 1999 video I chosen because actually it shows clearly that there is a difficulty in rotation actually of the nuclear pieces, and as it moves forward, you can see there is an uneven anterior chamber with less movement of the nucleus, which was easily moving, rotating earlier. This is one of the clear-cut signs that there is some disturbance in the anterior vitreous or in the posterior capsule. So we need to stop the surgery. And we have moved on to knowing actually what is there inside. Is there any vitreous strand? And the most important is to put a dispersive or a coercive viscoelastic actually to push the anterior hyaloid face back and to take out the irrigation and see what is there inside actually. So after noting this, the lens fragments are being slowly, gently moved. Ideally, it should not be emulsified inside the anterior chamber or in front of the anterior vitreous. So a scaffold or any anterior lens can be put, and then actually we can do the temporary scaffolding, and then we can proceed with the phacoemulsification. So in this situation, we have a low flow parameters and try to emulsify whatever that is there remaining. And here is the last piece. Most of the OVD was the viscode because it protects both the endothelium as well as the, it is very, very cohesive. Never try to pull the vitreous fragments with the phacoemulsification probe, or try to do a levitation maneuvers or any abrupt movements inside the anterior chamber. Try to do a low flow IA, and if there is no vitreous inside the main wound, then only try to do a dry vitrectomy, though I don't prefer dry vitrectomy nowadays, since it leads to collapsing of the anterior chamber, as you are able to see here. And once the anterior chamber is completely free of vitreous, at that time we used to use a holder and folder. A 3-piece lens is always preferred when compared to any other foldable lenses. If you want to place any lens in the sulcus, actually better to place it, use a 3-piece one, and a single piece should not always be put inside the sulcus. Better to put inside the bag only if the edges of the PCR are clearly seen. I would try to highlight one more case. You can see a spontaneous happening of a posterior capsule rent. The surgeon has not observed it because trying to load the visco. Once he enters inside, there is a sudden deepening of the AC with irregularity in the anterior chamber of that part. So sudden removal of the probe should not happen. In fact, you should have a OVD and then only you should remove it so as to avoid any vitreoretinal traction. A bimanual vitrectomy is always preferred with a maximum cutting rate so as to avoid any of the traction actually being developed. Sometimes you can do a cutter on and cutter off with low infusion so that and low aspiration. So whatever remaining cortex is removed with a single one, and bimanual irrigation aspiration is always preferred. So never panic, try to do it very slowly. And the irrigation should always be directed away from the vitreous. And if the all the components of all the edges of the PCR are being visible, then you can always use a single piece lens inside the bag. Thank you, Somshila.
Thank you, Bala. That was a very nice, concise talk on how to manage a common complication which all of us face. So shall we go to the next talk? Dr. Megur.
I'm ready.
Yeah. Dr. Megur is from Bidar. He's an excellent surgeon, records his cases very well. I really appreciate and admire his documentation. He's the professor there in the college, in the medical college, and he's a member of various organizations, and he has been awarded many times for his videos and presentations. Dr. Megur, please.
Thank you. Thank you, Dr. Madhukar Reddy and Dr. Somshila Murthy for the opportunity. And let me share my video. I'll be speaking on my experience with BX rings.
I'll be sharing my experiences with the BX
Is the audio
ring.
available?
This is one such case
you can hear
of exfoliation, non-dilating pupil, shallow entry chamber, and an intumescent lens in an elderly patient. Although phacoemulsification can be performed without using any pupil expansion device, I would prefer to use one in such a case, and just to reduce the complexity of the case and ensure more safety to the procedure. BX ring is my preferred device over other devices like the Malucans and others, as this is more economical, easy to insert and remove, and probably a little less traumatic to the sphincter pupillae. After injecting the OVD into the pupil is stretched using Y-hooks. Stretching is not mandatory for all pupils, but needs to be done for the rigid variants of the pupils. Then the BX ring is placed over the iris, and using a microforceps, the flanges are held and the first set of notches are made to engage the pupillary margin. Similarly, the second set of notches are engaged. And then, switching hands, the remaining set of notches are engaged onto the pupillary margin. So now we have a decent size of pupillary expansion, although not very wide, but workable. I would like to share 2 important tips. Number 1, using an instrument to stabilize the globe with a non-dominant hand ensures that the eye remains well centered during manipulation of the ring and hence gives better visualization, which eases the process of insertion. Number 2, using the side port to manipulate the ring gives us better control, and also we don't lose a chamber. Using this device on a rigid pupil is tricky. The issues faced is when trying to implant this in an eye with a rigid pupil is that the manipulation of the second and the third set of notches becomes quite difficult, since the ring inherently does not have the strength to stretch the pupil on its own. And even after engaging, the pupil expansion is very limited. So to work around this, we need to perform 2 things. First thing is to perform stretch pupilloplasty and then insert the ring. Stretching makes the pupil less rigid and hence easier to insert. Secondly, stretching provides better overall pupillary expansion. This is one such case with a rigid pupil. This is the maximum pupillary dilatation that could be achieved. After staining the antrocapsule, OVD is injected under the iris. Then using 2 Kuglen hooks, I am performing stretch pupilloplasty. Now is the time to insert the BX ring. I usually prefer to follow a standard protocol for inserting this device. The ring is placed over the surface of the iris. The globe is stabilized with the second instrument, and using the microforceps to the other side port, the 2 opposite sets of notches are engaged onto the pupillary margin. And then finally, by switching hands, the final sets of notches are engaged. The pupillary expansion which we get is around 5 to 5.5 millimeters, which is quite manageable in most cases. Well, to conclude, BX ring is my preferred pupil expansion device, but still, iris hooks continue to remain invaluable in certain situations, which I would discuss if time permits.
That's it. Thank you.
Thank you, Dr. Meghur. That was a wonderful presentation, very concise, very nicely documented, and I always love your videos. Thank you. Thank you. We have next is Dr. Shreyas, a very smart, handsome young man, and I really like his demeanor and the way he presents. So he will be talking to us next. Dr. Shreyas, please.
Thank you so much, sir. Thank you, sir, and thank you, Madam Dr. Somshila, for inviting me over in this session, and everyone at Hyderabad Ophthalmic Association. I've been attending the meeting for the last 3 sessions, and I've been enjoying it very much. I'll be presenting a couple of quick videos on phacoemulsification combined with corneal procedures in certain difficult situations. So now this is not a very uncommon situation which you see in our country. It's a large therapeutic graft which has been performed for fungal keratitis. The graft did well, achieved its goal of eliminating an infection, but visual rehabilitation is now what the patient has come for. Patient has a significant grade 3 cataract, but very poor visibility because of the very hazy and edematous failed graft. So now some of the things which we can do is, of course, debride the epithelium. In these cases, just debriding the epithelium may not be enough because there is a chronic edema. So using some glycerol to cause detergescence over the temporary detergescence really helps. And then I prefer using a chandelier illumination in these cases. The chandelier illumination really gives an excellent red glow. You switch off the operating microscope, and you can almost do the cataract surgery as if you're doing a regular phaco, do your standard chop maneuvers, and do an extremely safe in-the-bag phacoemulsification. The reason for having to do a very good phacoemulsification, the importance is because your subsequent desec procedure is going to depend on how well your phacoemulsification procedure went. If you have a good phacoemulsification done and in the bag IOL which is stable, then the entire desec procedure becomes much more simple, much more easy. All the air manipulation which you're going to do is again going to be very, very simple. So adequate visualization during the procedure becomes very important. And I think the chandelier illumination, especially when you have a diffuse opacification like this, comes in very, very handy in these cases. So that is just one tip which I wanted to convey through this video. I'll just show you one other quick video about wherein whenever we are faced with a significant cataract, we are tempted to go ahead and visually rehabilitate the patient first. But it's extremely important that you adequately optimize the ocular surface before the cataract surgery. This is one such patient with the Steven-Johnson syndrome. The reason I've chosen this is because Steven-Johnson syndrome patients, especially in the chronic period when they present to you with defective vision, you see some vascularization and significant cataract, you're tempted to go ahead with a cataract surgery. But if the surface is not stabilized, if there is a keratinized epithelium, then it becomes exceedingly important that you first do a lid mucous membrane graft, stabilize the surface, and then go ahead with the cataract surgery. By then, of course, this patient, I had waited for 6 weeks after the lid mucous membrane for the mucous membrane graft to take up well as for the surface to stabilize. And then subsequently, you can see there is some opacification, some vascularization, but now the epithelium is absolutely stable. So you can go ahead with the phacoemulsification technique. Yes, you see an opacification in the paracentral region, but the phacoemulsification can be done in the area just away from the opacity. You can ensure your globe is slightly tilted downwards while you're doing the entire maneuver. And a 3-piece lens is usually preferred in these situations. And then all you have to, it's always wise to suture these incisions in such cases in compromised corneas. And these patients do exceedingly well. Another thing we may have to keep in mind is that you may have to use these traction sutures because your speculum may not go in. And these patients do quite well. And with a scleral contact lens, even in these dire situations, the patient had a vision of 612. So this is just a couple of things which I wanted to show. Because of paucity of time, I'm not going ahead with further videos. Thank you once again, Dr. Somshila and Dr. Madhukar Reddy for the kind opportunity.
Good, Shreyas. Good job. So I'll refer all my corneas, difficult corneal cases with cataracts to you. I prefer the simple cataracts, can't handle the excitement anymore. So please go ahead and thank you very much.
Thank you, sir.
Dr. Sharaz Daya, can you please unmute yourself?
Great, my time's up now, is it?
Yeah.
All right.
Dr. Somshila, can you unmute yourself? I think she's there. Give me a minute. I'd like to introduce Dr. Sharaz Daya. Can technical help, please? Vinay, are you there?
Yes, sir. We will call her, sir.
Yeah. So I have a presentation here. How do I go about it?
You can open that and share the screen, sir.
So I'll first, yes, I'm here. Close this. Yeah, I'm here.
You can click on the share screen in the bottom.
Can you see my slide?
Hello.
Hello.
Can you hear me now?
Somshila.
Madhukar, can you hear me now?
Yes, I can hear you. I can hear you. Would you like to go ahead, please? Can you see my slide, Somshila?
Hello.
Yes, sir.
Can I be heard? Can I be heard?
Yes, yes, you're heard.
Okay. Dr. Sheraz Daya is currently the chairman of Center for Sight, and he's from UK, and a very handsome man. And he's been a pioneer in modern refractive surgery, and he does cataract and corneal transplants and refractive surgery. I went through his website, very interesting, very nice website. All of you should go through that. And his areas of interest include high-risk corneal transplantation, lamellar corneal transplantation, refractive surgery, and high-performance intraocular lenses. He's got more than 100 publications, and we are interested in listening to you and looking forward to it. Sheraz Daya, please.
Okay, thank you. I suppose I should share my screen. Well, thanks very much for the introduction. I was intrigued by Dr. Ramamurthy's presentation there, where they have branches in places that I used to go to when I was a young boy. I used to be at school in Uti between the ages of 10 and 15, and they were quite memorable times. So I went to Metropolitan and Coimbatore and all these other places. I have not been there since 1975, and I'm certainly due a trip. Can you see my screen at all?
Yes.
So I'm going to try and, can you, sorry, it's a bit of a mess, the screen. So you can see my main screen there, can you? It's
We can.
Yes, sir. Yes.
All right, so you see the slide presentation there, right?
Yes.
Okay, so I'm going to talk about capsule laser, which I think has a considerable future in terms of anterior capsulotomies. There's as we all know, there's a, why does these slides move? Okay, well, here's my financial declarations. I'm actually involved with Excellence, with the manufacturers of capsule laser. I'll also be mentioning Bausch + Lomb, and I'm the medical monitor for their lasers globally. Anyway, there's been increased interest in laser capsulotomies and automated capsulotomies over the last few years. And the femtosecond laser seems to have been the king in all this. Whether this is something that's should be valid or not is another story. There's a lot of arguments for and against it. There's the radiofrequency cautery, Zepto, which I'm sure you're familiar with. I don't know how popular it is in India. And now we've introduced what we call selective laser capsulotomy, which is another way of using a laser to create a nice circular central capsule. And I shall be talking about this particular device in comparison to others. So what's the ideal anterior capsulotomy? Well, we all want it to be centered, circular, and strong, resistant to anterior to AC tears, which can cause troubles. And they need to be of predictable size and preferably user defined, depending on the type of implant used and the density of the cataract, whether we want to prolapse this into the anterior chamber or not. And it needs to be rapid with little disruption to our regular flow of cataract surgery. So what is capsule laser? This is a device that fits onto most microscopes. This is an example of one on a Zeiss. It consists of this unit here that's added on with a series of optics and a filter. Because this is a dye laser, there needs to be a filter to protect the user. This is the head unit that sits on a floor standing microscope that attaches to it with the fiber optic cables attached, and there's no danger of them being caught up or being pulled. It is also it can also be pushed out of the way, as you can see here, and it is also compatible with retinal devices like the Resight and the Biome. So how does it work? Well, it uses a dye, as I mentioned, the stripeband blue in a high concentration, and the diameter range is from 4 millimeters to 5.8 millimeters. We can actually make it any size we want, but that seems to be the range that people use. The delivery is through a plastic interface, and now the duration, it used to be 1 second. I'll show you some 1 second videos, but now it's gone down to 0.3 seconds. In fact, it's gone down to 0.25, but we're trying to get the sweet spot in terms of energy and speed. This is a more recent video of a capsule laser being done in 0.33 seconds. This is a prototype interface that we were using, and you can see that's fairly dramatic in terms of speed. So in terms of the performance of the capsulotomy, does it perform as it says on the box? We want 5 millimeters. Do we get 5 millimeters? And we compare. This is compared to manual. This is done by Pavel Stadolka in the Czech Republic. And you can see in the blue bars are manual, and there's a great big scatter. The capsule laser was in and around 5.0 millimeters, slight variation, but fairly accurate. In terms of centration of the capsulotomy to the IOL, again, the spread for the majority of capsule laser cases was very narrow compared to manual. And this is the circularity. Again, this was statistically significant in terms of the circularity compared to a manual capsulotomy. This was all published in the JCRS by Pavel Stadolka and Richard Packard and David Mordaunt. So capsular strength is another big issue. As we know, that anterior capsular tears are hazardous. They get involved in the posterior segment in 50% of cases, and I can see that there were avoidance of this of posterior extension in the context of an anterior capsule can be managed by doing low irrigation, cortical aspiration, and so on. But there is also the possibility of lens tilt and decentration. All these are a problem in this new era of high performance lenses, where we don't want any of these things that we're going to interfere with refractive outcome and influence the ability of patients to read and see at intermediate. These are studies that were done. These are basic science studies comparing the capsule strength of capsule laser. And this is done by Sunfik Chi in Singapore and Seng AT as well. They did a lot of experimental work on paired eyes. And the first study they did was looking at capsule size and its influence on strength. And what they found was that the bigger capsules between 5.2 and 5.7 were stronger. This is doing manual capsulotomy. And those capsulotomies that were discontinuous were also weaker. And this is the data that was put together. These are paired eye studies, so there's a very good study. And you can see that the p-values were less than 0.01 in both instances. When it comes to capsule size, again, you can see that these were statistically significant, certainly in terms of distension perimeter. The bigger the capsule, the more it could be distended without tearing the anterior edge. And this was a second study that we published, which was actually comparing capsule laser to femtosecond laser and also to manual capsulotomy. And these were paired eyes. The study groups were SLC, which is selective laser capsulotomy to manual capsulorhexis, manual capsulorhexis to flax, femtosecond, and femtosecond to SLC. The femtosecond laser that was used in the study was the Victus. We also performed scanning electron microscopy of the capsule edge. So in all cases, the cornea and iris was removed for visibility. Circularity was measured using these criteria here, and the size was kept within 0.2 millimeters of the intention of 5 millimeters. If you deviated, that pair of eyes was discarded. The lens was hydroexpressed, and IA of the cortex was performed. And then this wax probe, you can see up here, was put into the capsular bag. And then using the Instron device, which moved at a very, very slow rate, the capsule was distended until it tore. And the distension, the actual extension of the rim, and also the load required to tear was recorded. And the statistical analysis was done using Wilcoxon's Rank-Sam methods. So if in a nutshell, what we found was that even though there was different paired groups, the values, the perimeters were the same, as were the loads in the group. So this is actually a very good study, even though it's paired eyes. from one group to the other, there was consistency. So what did we find? Well, we found capsule laser was stronger than manual capsulotomy with a p-values of less than 0.01 in both cases, both for perimeter and load. And when it came to manual capsulotomy versus flax, manual was stronger. And again, this is certainly in terms of load, statistically significant. And when it came to SLC versus flax, for both load and perimeter, SLC was stronger. So this is basically it. In terms of relative terms, if you take manual as the baseline, the capsule laser was 20% stronger than manual, and manual was also stronger than femtosecond laser. So scanning electron microscopy was quite revealing. This is a manual capsule. I mean, you've seen these many times. We can see a nice smooth edge from a tear. This is a scanning electron microscopy of the Victus femtosecond laser, and you can see that there are aberrant holes here, and the edge is quite irregular. And this is from layers of laser cutting. When it comes to the SLC, the capsule laser, the anterior capsule has a rolled edge. And in looking at high magnification, you can see this rolled edge. And there's also amorphous collagen which has been denatured, which in itself is strong compared to normal collagen. So strength is delivered to the capsule edge by doubling up, and also the curve and the amorphous changes as well. So all this accounts for what we believe to be the reason for the increased strength of capsule laser. So the studies, these were human cadaver eyes, they were paired eyes. And then, if you look at the studies in the literature, many of them are on pig's eyes, which is really not the same. And what we found was the load and perimeter findings between each group of comparisons were the same for the type of procedure that was performed. So in a nutshell, the SLC was stronger than both a manual and a femtosecond laser. And also, as I say, you can account for this by the capsular edge. Now, this is how we've evolved in doing this procedure. This is the 1 second. This is how the procedure was done on the studies. 1 second. The edge is quite thick, and it's been stained with trypan blue, and it's about 100 microns in width. When it went down to 0.7 seconds, it would be 75 microns. That's basically, when you're going faster, you can imagine there's less energy being delivered. And again, less energy still when we're going to 0.3 seconds, 1/3 of a second. So we're hovering now whether to go down lower still to get consistent capsules or not. So this is a case of a patient who needed two implants. She was plus 14 diopters, and I planned on putting 2 implants in her eye. So this is exactly how capsule lasers performed. One of the reasons why I'm showing this. It's good to see Deepak Magoda. He's my hero. Watching his videos inspired me to follow on 4K myself. So this is one of my early attempts. So here I am. The eye has been stained with trypan blue. The trypan blue has been removed, and the capsule is performed. Here we're taking out the anterior capsule. And this is a fairly soft lens in a patient who is about 48 years old. And there was not much hassle there. But if you take a look, that capsule is now ovalizing. This is a high hyperope. And you will know that in high hyperopes, the chance of zonular dehiscence is between 10 and 15%, sometimes up to 25%, depending on who you read. So I'm moving fairly quickly here, putting a capsular tension ring in. And I put in the first implant, which is a trifocal lens. It's a fine vision trifocal lens of 22 diopters. It's actually need 42 diopters. And then I put in a 10 diopter lens, a Sulcoflex silicone lens. And with optic capture too. I didn't put the whole lens into the bag. But I did because overall dimensions are quite small, anterior chamber was quite narrow. I wanted to get this in. And the edge of the blue staining of the edge made visibility very, very good in order to accomplish this. This is the usefulness of capsule laser. This is one of the things, the great things about capsule lasers. When you've got an intumescent lens, because of the speed of the capsule rhexis and also the strength of it, you could probably get away without having an Argentinian flag syndrome. This is not intumescent, but this is a hard lens. It was becoming intumescent when I was told, courtesy of Pavel Stadulka. This is the most recent iteration of capsule laser. Here we're injecting, once the capsule has been stained, you can see it's quite a deep stain. The capsulotomy is performed through this interface. So they were expecting milk to rush out there, but there wasn't. It would be useful to see how this performs in intumescent cataracts. I've used a femtosecond laser in intumescent cataracts, and even though it's fairly quick, it can still cause tear-outs during the process of the capsulotomy. So anyway, you all have you're more used to harder lenses than we are in Europe. So I'm not going to bore you with this video. So that's it. That's my presentation on capsule laser, and it has gone through an evolutionary process, and it's coming to the point where I do really believe it's now ready for prime time, and it'll be useful to see this in use by Indian surgeons who deal with very, very hard cataracts and require good capsular strength when doing their procedures. Thank you very much for your attention.
Wonderful presentation, Dr. Daya. And do you think this will replace femtosecond? Because I think we can't afford femtoseconds, but will this help us? And will this also decrease the cost of doing a nice Rexus?
Well, I think, one of the things about cost is, the device itself is going to be a low capital cost item. There's a bit of optics, there's a laser, and every device, every procedure will require an interface. Viscoelastic will be provided, and trypan glue will be provided. So often, and I know that you use these very often in your procedure, so they'll all come in one pack. I don't believe the cost is going to be massive, and if it's done, if you're using this in everybody, then the cost goes down. The cost per case goes down. It'll be a lot cheaper than a femtosecond laser, that's for sure. So I think it's going to be very useful. And I think one of the things that people sort of reserve these sort of technologies for cases where they are for extreme cases. Well, actually, you're more likely to get a good outcome if you're doing this all the time. So when you've got the abnormal case, it's second nature for you. You're not learning again how to do the procedure. You've learned all the tricks in the box, and you're able to use it in other things too. And people make that mistake with the femtosecond laser too. Then I've observed it. I just use a femtosecond laser all the time, or capsule laser. I just use a laser all the time. And I'll use the femtosecond laser in hard lenses, because I think we've underestimated the value that it provides in chopping up hard lenses, certainly with the laser that I use. So I think it's going to be, it'll have some traction. And there are people who are very cost conscious. This is probably not for them. And there are others that want to deliver consistent results for their patients and be able to use this in intumescent lenses and pseudo exfoliation and so on. I think that has a place for that as well.
Dr. Somshila, you have any questions?
So
any other questions?
So excellent. Yeah, we do have a couple of questions. Excellent talk, of course, and I can see that apart from all the other pioneering that you've done, this also seems to be something that's going to be very new. We do have the Zepto laser, the micropulse laser that we use. So that's like a sort of a lower cost alternative to doing a femtosecond laser for cataract surgery. And we use that quite often. So it is about 1/4 the cost for the patient if you use that. So where do you think this would be in terms of positioning itself between the high-end femto laser and the low-end Zepto laser?
Yeah, I think that it has for people who want consistency, this is going to be inexpensive, and it will certainly be an alternative. For those that don't want to put a huge capital amount into a femtosecond laser and pay the massive maintenance fees, there's very little in the way of maintenance on this device. It's a dye laser that's very simple. The software has been created. There's a per click fee, and with it comes a pack with all the things that you would be using, trypan blue, 2 different viscoelastic, one goes on the surface, one goes inside the eye. So you're in a sense, you're replacing some of the things that you use anyway. So I think it will definitely have a place in between. All these new technologies are slightly more expensive. I think when more and more lenses are produced that are fixed on the anterior capsule, and there are many in development right now, in order to sort out effective lens positioning and prevent tilt and rotation of toric lenses and whatnot, then something like capsule laser will really have a place, because it's a simple way of creating a nice round central capsulotomy to which you can attach an implant. So for high performance refractive cataract surgery, I think in the future, when you've got the technologies that need it, it'll really come into its own then. But it's useful to know you can do a capsulotomy in pediatric cases and so on without much trouble. And then in the laboratory, we've also done posterior capsulotomy. So you can restain and do a posterior capsulotomy halfway through a case and in a very perfect manner as well. So there are some interesting options that are available with this technology. The early days.
Good.
There's one question from the chat box. Maybe you can just take that very quickly. It says that Rishi's asked actually, do we put OVD, I think he means, before finding the laser, and can we use dense OVD for intumescent cataract?
Yeah, so there is a specific OVD that is used. They call it Capsuvisc. It's after trying out a whole variety of different molecular weight hyaluronic acid, we've come up with a particular molecular weight that works well with the laser. Because the performance, you want consistent performance, and to get consistent performance, you really need the same viscoelastic. And that's why the company decided to provide this, as opposed to say use whatever you like, because you're going to get differing results. So it is provided. So there is viscoelastic used. So basically what happens is the first thing we do is inject the trypan blue, which is, I think, is 16 times the strength of what you're normally using. And that is in for about a minute. That's removed, irrigated and aspirated out, and then viscoelastic is added in, and then the capsulotomy is performed. And then once capsulotomy is performed, the viscoelastic is already in there, you continue with doing the phaco. Now, some people talk about trypan blue making the capsule it makes it more rigid and can be fragmented. That's one study. Another study done by Burkhard Dick demonstrated the opposite. It didn't have any effect at all. And certainly using capsule laser with trypan blue of that concentration, those were our studies on capsule strength, which showed that it didn't make any difference. In fact, the capsule strength for capsule laser was greater than other methods without trypan blue. So I don't believe that's a big issue. The trypan blue does not make the capsule easily fragmentable.
So, and can we use it in pupils not dilating? I guess they mean that can you make a normal size capsulorhexis in non-dilating pupil?
Well, no, I mean, you need to dilate that pupil. You need to use the B-hex that was elegantly shown by Deepak, or a Malyugin ring. I think the B-hex is very nice because you can put that through a paracentesis. So you can make a paracentesis, put the B-hex ring in, and then put the trypan blue in and continue. But the good thing about this procedure is you're not moving to a femtosecond laser and back again. Everything's done under your microscope. And if you have retinal surgeons who get upset because you've got more devices on your microscope, it's easy. They can push it away and can still use their resight as well.
All right, thank you.
Thank you.
Great, thank you.
Thank you.
Madhukar?
Yeah.
So do we move on to
Dr. Baskinstock?
Yeah. First of all, thank you very much, Dr. Shears, there for such a wonderful, excellent talk. And following that, we have our second keynote speaker. Second keynote speaker is also an old Hyderabadi. That is Dr. Surinder Basti. Currently, he's associate professor and the director of cataract surgery.
Professor. He's a professor now.
Professor and director of cataract surgery at Northwestern University. And he had done his residency from India. And then he did 2 fellowships in India as well as overseas. He did his residency also in overseas first. And he has also been a pioneer, like the previous speaker, in laser refractive surgery. He has done a lot of research work on the femtosecond laser surgery. He has multiple awards and publications to his credit. So with that, I give you Dr. Basti.
Good evening. Can you hear me?
Yes, of
Yes,
course.
we can.
Okay. Well, like Somshila said, I literally grew up in Hyderabad as far as my career is concerned. And so it's truly a privilege and an honor for me to be part of this meeting. Thank you very much, Madhukar and the organizing group for this invitation. My presentation's on intraocular lens exchange. So I will share my screen so we can keep going. You see the screen there, Madhukar?
Yes, we can see it. Yes, we can see
Okay, great. Okay, great. So I'm going to talk about intraocular lens exchange. This is a procedure that increasingly is becoming more common for many of us prolific cataract surgeons. It's an important surgical technique to be familiar and facile with, because in those instances where you have to use it, it can really make a big difference to the patient. The important thing to keep in mind with this technique is, while it can be therapeutic, it really is a procedure that's nuanced. And so you want to be very familiar with the details of the procedure and take a systematic approach whenever you're doing it. And that's kind of the focus of my presentation today. How do we take a systematic approach? Well, we start with the preoperative examination, and the status of the capsule is an important determinant of how this procedure will go. For instance, is the posterior capsule intact, or is there a posterior capsulotomy? That can make a huge difference in how we approach the procedure. But perhaps of equal importance is the status of the anterior capsule, and the considerations to keep in mind as far as the anterior capsule is concerned is the anterior capsulotomy completely overlapping the intraocular lens, or are parts of the anterior capsulotomy fused to the posterior capsule? And the image to the bottom left shows arrows where the anterior capsulotomy is attached to the posterior capsule, and that area of attachment is behind the lens. So this is an important finding to be familiar with in the preoperative examination, because it'll alter how you actually do the surgical procedure. In situations where the anterior capsulotomy is in front of the capsule, the other consideration is, what's the size of the capsulotomy? In this instance that you're seeing here, this capsulotomy is probably 3 or 3.5 millimeters in its widest diameter. And that's an important factor to keep a note of. It'll be hard to get the lens out through a capsulotomy of this size. So enlarging the capsulotomy is part of the preoperative planning that one has to at least factor in. The other consideration related to the anterior capsule is how much of fibrosis there is at the edge of the capsulotomy. And these are all findings that you can easily assess in your preoperative examination, and it's critical in such cases. So let's start with an example here. This is the pre-op picture I just showed. The first consideration while taking on these cases is to find a plane underneath the anterior capsulotomy so that you can inject a cohesive viscoelastic. And towards finding that edge of the anterior capsule, in the image that I just demonstrated, I used a Sinskey hook to get underneath the anterior capsulotomy. You can use a 27 gauge needle. That's a very simple option. If you attach that 27 gauge needle to a cohesive viscoelastic, the needle will let you get underneath the anterior capsulotomy, and then you can proceed with injection of the OVD. There are many such tools. There's the Pallet cannula. That's a good choice. I really like this cannula. It's called the Wexler femtosecond cannula. And it has a tongue with a groove in it. And essentially, that tongue-shaped edge of the cannula lets you easily go underneath the anterior capsulotomy. And the groove there lets OVD begin to go underneath the capsulotomy. very easily. So I really like this flax cannula, and this is my primary device to enter underneath the capsule. And this is particularly important in instances where you have a lot of capsular fibrosis. And this is one such example. This is a patient who had a hydrophilic intraocular lens that was calcified. And you can see a lot of fibrosis at the edge of the capsulotomy. And again, I'm using the flax cannula. You can see how easily that flax cannula finds the plane between the capsulotomy and the intraocular lens. And that's the first step in proceeding with this case, because that permits injection of OVD all around the intraocular lens. And that's the key. You want to inject OVD to inflate the entire capsular bag. Towards that goal, you may need 2 or 3 paracentesis incisions made in these cases so that you can approach the capsular bag from multiple directions. Important to keep in mind not to overinflate the eye. Intraocular pressure can go up significantly. So intermittently, you want to burp the OVD out so that you're not overinflating the eye. Now, I mentioned to you that in the example I showed you, the capsulotomy was quite small. And so I'm now enlarging that capsulotomy. In this case, there's not a lot of fibrosis of the rest of the anterior capsule. And so we are able to tear all the way around and widen the capsulotomy to about 5 millimeters. And that will permit dialing the intraocular lens out easily. And these are pre and post capsulotomy pictures of the eye that I showed you an example of. But in many situations, there are significant strands of fibrosis of the anterior capsule. In those instances, you can't tear it like the example I just showed you. Wherever you get fibrotic areas, you have to cut with a Grishaber scissors or a micro scissor of some sort. One alternate to opening the anterior capsule in situations where there's a lot of fibrosis is to use the femtosecond laser. And I assume the capsule laser that Shiraz just showed us perhaps can do the same. With the femtosecond laser, these are examples from Sam Maskett. The picture to your top left is the preoperative picture. This is a patient who has a restored intraocular lens. And Sam used a femtosecond laser to widen and create a new capsulotomy. And the picture to the top right is after the intraocular lens has been replaced. So one alternative in situations where there's a lot of fibrosis of the anterior capsule to enlarge that capsulotomy is to use a femtosecond laser, which creates a nice predictable round opening in such instances. So assuming we've gone past the first step of having OVD all around, having an adequate anterior capsulotomy, the next step is to dial the intraocular lens out of the capsular bag. And towards this goal, the important point I want to make is you really want to be able to visualize the tip of the haptic when you're dialing that lens out. And if that means placing capsular hooks, it's something that we should have a low threshold for doing. You really want to visualize the tip of the haptic. And that's important because some intraocular lenses, specifically the intraocular lens from Alcon, has a bulb at the tip. And if you don't visualize that, quite often that's an area where there's a lot of fibrosis around. And if you don't visualize the tip as you're rotating it, you could exert significant traction on the zonules and create a zonular dialysis. So towards visualizing the tip of the haptic, use iris hooks would be a pearl that I want to share. Another consideration to keep in mind is the fact that whenever we're dialing the intraocular lens, we're focused on the haptic that we are close to. And, the key to keep in mind is there's a second haptic which is going to rotate at the same amount that the haptic that you're actively looking at when you're dialing it. And so you want to intermittently visualize the opposite haptic as well. Be aware that you will be creating traction at the opposite end. And in instances where the capsule has fibrosed around haptics, when you're working on one haptic to avoid traction on the opposite haptic, you can use a two-handed maneuver like what you're seeing here. The first Sinskey hook is stabilizing the intraocular lens. And the second Sinskey hook is then carefully maneuvering that haptic out of the bag. And by using that first haptic to steady the intraocular lens, you're not exerting a rotational force on the opposite haptic and inadvertently creating a zonular tear at the opposite end. So this is a maneuver that can restrict any traction you're exerting just to the area that you're focused on. And so using a two-handed maneuver in those instances can help you stabilize the lens and prevent the lens from rotating and creating traction on the opposite haptic. In spite of our best efforts, sometimes the amount of fibrosis around a haptic can be considerable, and injecting OVD in the plane of the haptic using a cystosome to try to free up the areas of adhesion can all go to naught sometimes. And in those instances, you'll have to amputate the haptic, and we are seeing that in the video here. The inferior haptic here, I simply could not free in spite of repeated attempts. And in those instances, it's completely reasonable to amputate the haptic and move on with the surgical procedure. So once you've brought the intraocular lens anteriorly, the next step is to have instrumentation that permits controlled cutting of the intraocular lens. I'm using a Chang-Packard scissors and forceps here, and that's an excellent choice, but there are many other choices. Katina has scissors, so does Alcon for cutting the intraocular lens. So all of these are good options to cut the intraocular lens. One of the maneuvers, one of the little pearls that I find pretty useful is to use a Sinskey hook, because sometimes when you're cutting the intraocular lens, there is torque that's exerted and the lens tends to hob up or down when you're cutting. And if you use a Sinskey hook that extends across a large part of the haptic, you'll find that you're able to prevent any kind of tilt of the intraocular lens when it's being cut. So that's something that is easy to do. Here we're cutting a crystal lens, and by steadying the intraocular lens with a Sinskey hook or even a chopper, you're able to steady the intraocular lens when it's being cut. In terms of cutting the intraocular lens, one of the options is to bisect it, and we saw some examples of it. In this instance, we are using a Pacman maneuver where we've cut 1/4 of the intraocular lens, and then we are rotating the lens out. It's clearly a rational option to remove the intraocular lens. Key to keep in mind in a Pacman maneuver, you have to rotate the lens as it's coming out so that each time 1/4 of the lens is coming out through the incision. And that kind of a rotation can be helpful to remove a lens that's been cut 1/4 of the way. In a crystal lens, you have to keep in mind that the lens, the two halves of the lens are again having these haptics and so forth. So clearly you need a little bit of a rotational maneuver as you're removing the intraocular lens. Important to keep that in mind as you're maneuvering the intraocular lens out through a small incision. And I mentioned briefly at the start about situations where the anterior capsule is fibrosed. In some areas, you want to be very aware of those areas so that intraoperatively, those are areas that again can tear if you're very forceful with your maneuvers. In such instances, you start with the area where you have overlap, like we are seeing here, inject OVD all around, and then use a Grishaber scissor to cut outside of the area where the capsule is fibrosed, so that you're not exerting traction in those areas that are adherent, where the anterior and posterior capsule are fused to each other. Another simple maneuver is to use the flax cannula, the one that I showed you an example of, in those areas where anterior and posterior capsules are adherent. That's what you're seeing me do here. And about half the time, this cannula is able to free up areas that are adherent. In some instances, the fibrotic areas are too densely fused, and in those instances, you have to cut with a Grishaber scissor. The last situation that I want to touch upon are situations where the posterior capsule is open. And like you can imagine, this brings in considerations that can indeed take us down a slippery slope. The goal, if the posterior capsule is open, is to minimize extension of the posterior capsular break. And so being very meticulous with your approach is really key. This is an example of a case that I had operated. Like you can see, the anterior capsule is perfectly round. The anterior capsulotomy is, the lens is perfectly centered. This was a restore lens that I had in place, and the patient simply just didn't like the lens, didn't like the quality of vision she was getting through the lens. And unfortunately, she had a fibrotic area right in the middle on the posterior capsule. And so we indeed yagged that first. And that's, a step that can really compromise how easily you can do an intraocular lens exchange. But again, taking a systematic approach really is the key, and that's what we're doing here. We're using a cystotome to get underneath the rhexis margin. In these instances where the posterior capsule is open, you need to use a dispersive viscoelastic. And the critical consideration here is not to overinflate the capsular bag. Because if you overinflate the capsular bag, the OVD is going to go through the posterior capsular opening. It's going to widen that and make it extend. So in these instances, when you're trying to free the intraocular lens with OVD, you want to minimize, or rather use just enough OVD to get separation, but not overinflate the bag. And with the lens in the bag itself, we are going ahead and bisecting the lens, again, to achieve at least some degree of a scaffold here. We are leaving the lens in place, removing any vitreous adjacent to the posterior capsulotomy, and then removing the cut intraocular lens out. We'll then place a lens in the sulcus and optic capture it in that nice round anterior capsulotomy that we had. So in situations where the posterior capsule is open, the surgery does become more challenging. There's more uncertainty there. But again, with a systematic approach, most important goal, not to overinflate the bag or exert traction forces that can extend the posterior capsulotomy, you can still do an intraocular lens exchange in a controlled manner. So the important take-home points for intraocular lens exchange, in terms of timing, early procedure makes it so much easier. But I want to emphasize that this procedure can be done several years out, and I truly don't think timing should be a major determinant of saying, hey, it's too late to do this procedure. I truly think that this procedure can be therapeutic in so many patients who have a suboptimal outcome. In terms of pre-op considerations to keep in mind when doing an intraocular lens exchange, be very clear about the size, the amount of fibrosis around the anterior capsule, and surely keep in mind if there's a posterior capsular opening already in place. In terms of freeing the intraocular lens, OVD injection all around the lens is critical. Be aware that some haptics will have a knob, and if there is a knob, there's much more fibrosis around it. So when you're dialing the lens out, be very mindful of that and visualize that tip of the haptic as you're rotating it to minimize traction in areas where there may be fibrosis. Cutting the intraocular lens in a controlled manner is really the key here. And you want to make sure you have instrumentation that will easily do that. One of those examples is the Chang-Packard scissors. There's a lot of uncertainty when you go in with such a procedure. And so you want to have a plan B and a plan C, have a backup sulcus intraocular lens, have an anterior chamber lens available as well. And under promise, that can really be a safe strategy in terms of managing patient expectations. If the patient's on board that this is a procedure where there is some uncertainty, you can have an outcome that everybody is happy with. Thank you very much for your attention.
Wonderful, Surendra. Very nice.
Thank you. Thank you.
Yeah, and you are as a perfectionist as usual.
Thank you, Madhukar. Very kind. Any questions that I can take?
So I just was wondering, Dr. Basti, when are you handing over those instruments to us?
You mean IOL cutters and stuff like that?
Yes.
Oh. Anytime. You name it, you'll get it.
That's amazing, amazing collection of cases and remarkable the way in which you've handled them. It's also very interesting to see that despite years since the primary surgery, the lenses actually can be dissected out and can be, removed from the capsular bag. But I think it requires a very high level of surgical skill to do that safely. So thank you for showing that to us.
Of course.
Yeah, patience and perseverance.
Yeah. Well, terrific meeting. Again, truly a privilege to be with you guys. Thank you very much for calling me.
Thank you, Surendra.
Thank you so much.
Thank
You're
you.
welcome.
So thank you very much, everybody. Sharaz Daya, Deepak Megur, Bala, and Shreyas had a wonderful time with you, and thank you for accepting our invitation. It's been a very nice meeting and a good evening for all of us.
And thanks for everybody who accepted and who's part of this meeting, this session, at least a cataract session. And yes, we could have had more discussion time, but I think that the audience must have benefited from all the wonderful clips that each of you shared. So thank you. And the keynotes were just amazing. Thank you very much. Madhukar, we'll hand over.
Yes.
Thank you, Dr. Dayad.
All right.
Thank you, Dr. Basti.
All yours, Rishi and Dr. Nandkishore, Dr. Manoj.
You're welcome, Rishi.
Thank you. Thank you to all the panelists. Okay. So we'll get started with the next session, or should we wait? Welcome, Dr. Terry.
Rishi.
Thank you very much for having me here.
Thank you.
Would you like me to start with my talk now, or?
No, we have 4 minutes. So we'll just wait for...
Rishi?
Yes, Dr. Nandkishore. Are the Hallmark guys, are we transmitting right now?
No, sir. Hall B session is not yet over.
Okay, so we'll wait for it to be 7:30 and then we'll get started.
Yes.
Great. So we have some time.
Yeah, all core group to be on video.
Okay.
You must have got up quite early today, Dr. Terry, to be on this. It's
well,
6 o'clock there, isn't it?
I usually get up at 6 a.m., but this morning I got up at 5 a.m. So
Okay.
it's just an hour earlier. But it is
Thank
on
you.
Sunday when I do try and catch up on a little more sleep. But it's really a pleasure to be with you. How's the conference gone so far today? Has it been a good conference? And
Yes,
good
it's been a very good
participation?
conference. We've had 750 registrations, and all the sessions have been pretty much well appreciated. We did have a couple of technical glitches, but by and large, okay.
Well, it's almost impossible not to have some technical glitches when you're doing a virtual. It's amazing we can do this at all.
Yes.
So Dr. Terry, it's very interesting that we opened the meeting today with Audrey Rostov, and she conveyed her regards and she speaks very highly of you. And I think the final talk that we're waiting for is your oration. So it's been a fantastic meeting from start to finish.
Oh, wonderful. Yeah, Audrey is also one of our premier cornea people here in the Northwest in Seattle area. So we're almost neighbors, Audrey and I. So yeah, she's a very, very good speaker and a very strong ophthalmologist. So I did not stay up late enough last night to catch the beginning of your meeting. I'm afraid I was sleeping during most of it, but if it had been in person, I would have been awake, but I'm afraid virtually I had to be asleep last night in order to be fresher for today. But this is actually the best way to go now that we're confined. It's working out. The virtual meetings are working out. It's not nearly as much fun, but it's working out. So. So my talk is going to be about 45 minutes or so. Is that correct? Or
should be fine.
That should be fine.
Okay. If you need to cut me off, just simply stop the video and just say goodbye. I'm happy to do whatever you need to have done is fine.
This is the most prestigious. This is the most prestigious talk of the conference, and there's no way we can cut you off.
Well, thank you very much. I very much appreciate that. I'm glad to see you're not wearing a tie. I debated whether or not I should wear my tie this morning, but I said it's too early to put on my tie. I'll pretend it's hot here in Portland or something. But
I was in my shorts all this morning, but just now because I have the duty to hand over the oration medal, I thought I'll dress up a little more formally.
Wonderful. All righty. I guess we should go. We should start.
Just a few minutes.
Oh, okay. So
we had a formal function before you start your oration.
Okay.
Whenever you prompt us when we can get started?
Yes, sir. They are finishing up in Hall B.
Okay, okay, sure. So are you playing a video in the meantime for the delegates?
Yes, we'll play.
Okay.
It is pretty amazing how they can have the video going for the delegates while we are here in our own private room talking. It's amazing technology. I still remember when I used to carry around my circle of slides and it would fall on the floor and all the slides would pile out and my whole lecture would be ruined because I tripped and spilled the slides. And now here we are, my goodness. It's just amazing.
You had to make your slides individually and it was so expensive then, each slide.
Oh, yes. Oh, it was ridiculous. In order to share lectures, we had to share slides. And to make each slide would cost $1 or $2 and you'd have 100 slides and you have to pass them out to other people. My goodness, those days are gone. But now we're only 2-dimensional. Someday we'll be 3-dimensional, you see. We'll just beam the whole person there. It can happen.
So the reason we're getting delayed is the other hall is not finished yet. We're just waiting for them to wind up so that the delegates from the other hall.
So you have 2 halls going?
Yes, we have 2 simultaneous halls. And 1 hall is...
What are the topics in the other halls?
So we have a whole range of topics, pediatric ophthalmology, neuro-ophthalmology, oculoplasty, the entire gamut. Right now, there's retina running at this point.
Oh my gosh. That's a huge meeting to be putting on virtually. I can't believe you've done it.
It was an 8-hour meeting. We started at 12 p.m.
Oh my gosh. Amazing. And do you have a whole team of technical people working on it?
Yes, we have the event organizers, the same people who organize Keracon. They're the event organizers and they're doing
Dr. Rishi, we can start, sir.
Great. Are we live?
Yes.
Hello, everybody. I'm Dr. Rishi Swarup. I'm the General Secretary of Hyderabad Ophthalmologists Association. And on behalf of HOA, I'd like to welcome you all for the grand finale of our annual conference, VISTA. And this time it's a virtual VISTA 2020. Without further ado, I'd like to invite the president of HOA, Dr. Nand Kishore, to give us welcome. Just for everybody's information, we've got a very good attendance today, more than 750 registrations, which is kind of a record for HOA, and we're very happy about it. Dr. Nandkishore, are you ready?
No, I'm just trying to see I'm not getting the slide on video, the Narendra Swarup oration slide. Vinay, can you just help me with it? I have saved it on my desktop.
You'll have to open the PPT first, sir.
Okay. It's just a single slide.
Okay, sir. You open that and click on share screen. Open that and come back to Zoom and click on share screen, sir.
In 87-88, he has initiated this Hyderabad Ophthalmology Club, which is today known as the HOA. The present existence came only in 1996. He was a great surgeon, an avid scientist, and also a very, very extremely respected teacher. With these few words, I would like all of us to just stand by for the lighting of the lamp, and then Dr. Rishi would introduce Professor Mark Terry to all of you. Vinay?
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you. This is the first time I've done a virtual lighting of the lamp, but it's actually pretty nice. All right. So without further ado, I'll go ahead and introduce our guest for today. Just going to try and share the screen. I hope my slides are visible.
Yes.
Professor Dr. Mark Terry is the director of the corneal services at Devers Eye Institute at Portland, Oregon since 1990. He's also a professor of clinical ophthalmology at Oregon Health Sciences University. He had his undergraduate degree at Yale University, medical degree at St. Louis University, completed residency in ophthalmology in San Francisco, and following which he had a corneal fellowship in 1985 at the University of Oklahoma under the mentorship of J. James Rossi. He is a profound academician with a vast career in cornea. He's lectured extensively all over the world in over 25 countries, and several of them he's gone several times as an invited speaker. My first memory of Dr. Terry was during my fellowship when he came to one of these lectures to Chanka-Netralaya. I was a fellow and I was given the honor of tailing him and helping him with his conference-related work. And it was a great learning opportunity. First time he taught us DLEC at that time. He has a lot of research published in areas of corneal transplantation, corneal physiology, refractive surgery, dry eye, and endophthalmitis. In 2000, after a year of laboratory development, he began the first US clinical series of endothelial keratoplasty that was named DLEC. These cases began the new era of modern corneal transplantation across the world. Over the past 20 years, he has pioneered developments in endothelial keratoplasty with over 150 peer-reviewed publications on DSEC, DSAEK, and DMEC. He's the president of the International Endothelial Keratoplasty Group, EKG, which was founded in 2002. And this group continues international collaboration in the development of EK. He has several awards to his credit, some important ones being the Lifetime Achievement from AAO, the Patent Award from the Eye Bank Association of America, and he's also a member with thesis of the prestigious and exclusive American Ophthalmological Society since 2007. He is a family guy. He's married to Cindy and has two beautiful twin boys, Charlie and Nicholas, born in 1988, whom he treasures. Dr. Terry, I've seen this every time he gives a talk. The last slide always has a picture of his family, whom he thanks for letting him take time away from them to come and lecture all over the world. We welcome Dr. Terry to give the HOA Professor Dr. Narendra Swarup oration, who very much like him was an avid teacher and was involved in research and academics for most of his career. He was a popular teacher, socially conscious person with a gentle personality, who also happens to be my grandfather. Welcome, Dr. Terry. I'd like to invite our president, Dr. Nand Kishore, to virtually hand over the medal. I'll stop
Professor Terry,
sharing.
it's our privilege to award you this oration. please accept it on behalf of Hyderabad Ophthalmologists Association.
Thank you very much. Thank you very much. Wow, that's quite the medal and the casing.
Yes, and we
Wonderful.
also have a plaque for you. I'm not sure if you can see it. So these will be
my.
coming to you by post, and they
Oh
shall
my
be
goodness.
posted tomorrow.
That's going to be very expensive to send all the heavy weight. Thank you very much.
It will be our privilege, and we are very, very honored that somebody of your stature is giving the oration this year.
Thank you.
Without further ado, I'd like to just ask you to go ahead and give your oration on the topic of the day, which is the continuing evolution of endothelial keratoplasty surgery.
All right, let me get this together here and move this over. Okay, let's see. Just give me one moment here. There we go. Is the screen sharing right now?
Yes, it's fine.
Wonderful. Well, thank you very much, Rishi. I do remember my trip to teach Dilek in India, and how you were such a wonderful host and how you guided me around. You were a much younger man back then. I haven't changed, of course, in those 18 years, but it was my first experience in India, and I remember it very, very fondly. I'd like to thank you, Rishi, and Rajesh Vogla, my dear friend, for inviting me to give this talk. Before I do begin, I do want to go over the fact that I'm honored, very honored, to be able to talk in memory of Dr. Swarup. He was trained in the UK. I don't know if that was made before. And as you said, I understand he was a superb clinician and professor. But one of the aspects of him that got to me was the comment by many that he was loved by his patients and adored by his students. I don't think that a professor could have any better honor than that. All the awards that are given by societies don't compare to the ability to be loved by your patients and adored by your students. He did not go into cornea, which is unfortunate. I'm sure he did some cornea, as he did everything else, but he did specialize in squint and plastics. As was said before, he was a professor, and he founded the squint department and published his clinical research. He did have a lot of charitable and socially responsible work that he did. I found it interesting that he was the founder of the Lions Club in Hyderabad, because I'm very much involved with the Lions for the past 35 years. And it's a wonderful organization, and the fact that he helped to get it going in Hyderabad is very important. And then the work that he did when he supervised the camps and the rural eye camps was very important. My favorite of all the pictures that was sent to me was the fact that he had a family tradition. Family should always be a priority. We get so caught up in our work that I think that we need to always recognize those that support us. And he certainly supported his family. He founded the Swarup Eye Hospital. And I do believe that the distinguished service of ophthalmology is now carried forward by second and third generations of distinguished Swarup surgeons. It really is an honor for me to pay tribute to this incredible man, and I'd like to once again thank you for your kind invitation. Now on to our lecture. First, the disclosure is that I do have some financial interests. I received royalties on the Dilek instruments that I designed. Since no one in the world is doing Dilek anymore, those royalties no longer exist. I do get some financial unrestricted educational grants for my endothelial keratoplasty breakfast that I hold at the Academy each year. Well, I'm going to tell you something that's been my passion for the past 20 years, and that is the revolution in corneal transplantation, where we have the selective endothelial replacement. We're going to talk about going from Dilek to Dissect to Dissake and then to DMEC, and then something extra at the end. The evolution of endothelial keratoplasty has been truly remarkable. When you look at these OCT images of the evolution, we can really get a sense of where we were and how far we've come. If you look at the Dilek, this was a hand-dissected donor placed in a hand-resected bed. And the operation took about 3 hours, the first one that I did. And by the time we had done several hundred Dilek surgeries, we had it down to about an hour and a half or so. but it still was one of the most delicate surgeries I've ever performed and remained that way even as I gained my skills. It was much improved when DISSEC came along, and no longer did we have to dissect a recipient bed. We could simply strip off Descemet's membrane, a far easier maneuver, and then just place the DISSEC graft on the back of the cornea like a wart. But when DMEC came along, there were new skills to be learned, but also we ended up having perfect anatomic replacement. If you look at the DMEC OCT looks exactly like a normal cornea. If I showed you two OCTs, you would not be able to tell the difference between one that had DMEC surgery and one that was a normal cornea. That's how beautiful this surgery of selective endothelial replacement has become. I'm going to show you now a video, which is the very first endothelial keratoplasty surgery ever done in the United States. It was the second surgery in the world. Mellis had already done the first case in Amsterdam. And this is a video that I made in March 2000. That's 20 years ago, over 20 years ago. And I made this video, and it truly was a videotape that we made in those days, because I knew this was an historic moment, that we were doing the very first endothelial keratoplasty. And I want you to compare this, this technique of deep lamellar endothelial keratoplasty to DMEC surgery and see how far we've come in terms of the level of experience needed for the DLEC versus the DMEC.
Patient surgery was performed March 14th.
There's audio on this, so I'm going to let the audio go.
Portland, Oregon. This is a video of the very first patient done in the United States. The preoperative ring topography incision is made 1.0 millimeters posterior to the limbus with a guarded diamond knife.
Very large incision back then. 9 millimeters.
A stat incision is made through the limbus into the anterior chamber. In this patient study, Helon has been injected into the anterior chamber to fill the chamber and maintain pressure.
This is a Devers dissector we designed especially for the surgery. It's in the stroma. This is not in the anterior chamber.
Care is taken to ensure that the lamellar pocket reaches to every edge of the limbus.
So I'm creating a total lamellar dissection, limbus to limbus, in the deep stroma.
The trephine is entered into the lamellar pocket. It can sometimes be a tight fit.
This is a specially designed instrument to get a trephination similar to what you would trephine on the surface, but to do it intrastromally.
And once centered on the cornea, the rotation along the arc of the incision is performed. Once the anterior chamber is entered, Helon can be seen to exit from the superior wound, and the trephine is gently removed. A 75B replaced.
And these are the original Cindy scissors that we used to cut out the posterior layer.
These scissors can take us to the mid-distal area, but then special low-profile scissors are necessary to complete the distal cut. Once the disc is free, it is then pulled through the pocket and again placed upon the corneal surface to check for uniformity of cut and edge smoothness. A Sicko needle is then used to completely evacuate the Helon from the anterior chamber and the pocket.
This donor's been
The
prepared.
Owsley insertion spatula is then coated with Helon, and the healthy endothelium donor disc is carefully separated from the overlying anterior stromal tissue and placed endothelial side down onto the Owsley spatula, protecting the endothelium with Helon.
That was
the
hand
Owsley spatula
dissected
is
as
brought
well.
into the operative field, and with air in the anterior chamber, it is gently inserted through the pocket into the anterior chamber, then brought up anteriorly until the donor and recipient interfaces adhere, and the spatula is gently retracted out of the eye, slide on the layer of Helon, protecting the endothelium. Air is immediately injected into the anterior chamber to stabilize the tissue into its MSS, and the pressure is normalized. An air bubble of approximately 90% the size of the graft is then left in place to maintain it. Immediate postoperative topography is seen to have a very round. This patient's postoperative recovery was quite rapid, and here we see on post-op day 13 that the central graft endothelium was working quite nicely, with a clear graft and a very stable interface. Indeed, the central cornea is clearer than the peripheral recipient tissue. The superior wound is healing nicely, and the compressive forces of the limbal sutures diminished considerably by the 3rd week. Of the Netherlands for his original work and development of this procedure.
So that surgery was very delicate and took a long time, and I was nervous during most of it. But it was so important to show the American Academy of Ophthalmology that at that meeting in 2000, that this surgery was possible and that we could move on from all the problems of penetrating keratoplasty to a new era of endothelial keratoplasty. Now, this is not the same eye that you just saw in the video. It's actually the 5th case in the United States that I did. And it's 20 years post-op. I saw this patient just a few weeks ago. And the vision was 20/25. The patient only had 3 diopters of astigmatism, and that's because of that very large incision superiorly. It was against the rule. But the endothelial cell count was 708. Now, the first 4 cases in the United States that I did, those corneas were clear until the patients passed away. The average age of these patients was 77 years old, and this is 20 years ago. So this patient did survive the 20 years, and now we have data, information, that these endothelial keratoplasties, even with DLEC surgery, survived at least 20 years. Well, we were very excited. I was extremely excited about this procedure. I knew that my DLEC results would be better, just simply because of the physiology of it and the anatomy. And what we found was that the visual rehabilitation for DLEC was in 2 months, not in 2 years, like it would be for a PK. Most importantly, these patients did not need a gas permeable contact lens needed. They often didn't even need spectacles. The average vision on these patients, because it was a hand-dissected deep lamellar resection, the average vision was about 20/30, 20/40, but only 8% achieved 20/20 vision. They had a much improved quality of vision compared to PK because they didn't have that irregular astigmatism. This is something that surprised us, is that the rejection rate was reduced to 9%, whereas before it had been 18% of rejection rate in penetrating keratoplasty. And the endothelial cell loss was comparable to what PK was. Now, I went on to train over 70 surgeons, many of them from India, to do DLEC surgery. But actually only about 15 of the 70 surgeons performed DLEC surgery. And when I asked them, why aren't you doing this surgery? It took so much time to train. And they said, well, we do agree that it is better, DLEC is better than PK. However, it's not easier and it's not faster. It took until 3 or 4 years later that DISSECT surgery came on the fore through the efforts of Garrett Mellis. And in DISSECT surgery, as you all know, the Descemet's membrane is simply stripped off the recipient. No longer did we have to do that very tedious and very delicate dissection in the deep stroma, limbus to limbus, on the recipient. We now could simply just strip off the back surface of the cornea. And then we had to still do a hand dissected donor. But then with the use of microkeratome, that eliminated the need for the delicate dissection of the donor. And now we had DISSECT, or Descemet stripping automated endothelial keratoplasty. And this enormously improved the ease of the surgery. This is our standardized DISSECT surgery. And we've done the same technique since 2004. We make a scleral incision because we want a larger incision for insertion of the tissue. And a scleral incision induces very little astigmatism compared to a corneal incision. And they strip it under Helon. It's not necessary to use an air bubble to strip the tissue. And then we scrape the periphery in order to create a rough surface in the periphery that allows greater adhesion of the tissue. We leave the central cornea very clear. We keep the cornea as small as we can, the pupil as small as we can. And this is our donor tissue. It's been cut with microkeratome. And there's the layer that we're going to transplant, the posterior layer. These are Charlie forceps to insert the tissue. We insert through a larger 5mm incision in order to not crush the tissue. And then the air bubbles put in place. We get rid of the interface fluid by sweeping the interface with a Cindy sweeper. And then we close the wound with 3 dissolvable sutures and cover it with conjunctiva. We leave an air bubble in there that's smaller than what we do with DMEC, and the operation is over. Now, what has the literature taught us about DISSECT inserters and DISSECT surgery? Well, we have now the definitive study, the corneal preservation time study. And this study, led by Jonathan Lass, has taught us a lot about DISSECT surgery. it's shown us that the method of graft insertion doesn't really matter. So there was a lot of controversy about, well, should we use forceps? Should we use pull through? Should we use injectors? And the CPTS study, looking over 1,300 cases by very experienced surgeons, found that it doesn't really matter in terms of graft survival or the endothelial cell count of the tissue. But it doesn't matter what type of inserter you use. It's just important that you do it well. Now, there were other advances that made EK more acceptable than DELEC. DELEC never came to be a popular procedure because it was so difficult and took so long. And DESEC now started to take hold as a popular procedure because the surgery was vastly easier than DELEC. The other aspect in the United States, at least, was that we had to develop a new code, a new procedure code for this new procedure. It was so different from everything else, we couldn't code it as a penetrating keratoplasty. So once we obtained a code and we went through the bureaucracy of the American Academy of Ophthalmology and the bureaucracy of the American Medical Association, we finally got a new code for EK. And this allowed us now to actually bill for the procedure and be paid by the government through Medicare. And then other insurance companies follow. The other aspect that made DESEC take hold and become popular in the United States is that two eye banks in the United States, our eye bank here in Oregon and the North Carolina eye bank, they learned that we taught the technicians to pre-cut the tissue. So the surgeon no longer had to take the microkeratome into the operating room and cut the tissue and possibly destroy it and ruin the operation. We could now have technicians before the surgery, day before the surgery, pre-cut the tissue. And this eliminated the risk of the surgery. It took the risk to the eye bank instead of to the operating room. So when we look at that comparison again, from the surgeon's perspective, before we compared DELEC to PK, and now we have the perspective DESEC versus PK or DELEC, and the surgeons all said it's easier, it's faster, it's better. And that's what was necessary to get endothelial keratoplasty become an accepted operation. DELEC was an endothelial keratoplasty procedure, but it could not be accepted until it was easier and faster, even though it was better for the patient. And so the factors for getting any new operation into acceptance is it has to be not only better for the patient, but it has to be easier for the surgeon and faster. And when DESEC became easier and faster than penetrating keratoplasty or DELEC, that's when it took off. The pre-cutting and the acceptance by of the code had a turning point in 2011, where you can see DESEC started taking off and PK started going down. And it was 2011 they crossed, and now DESEC in the United States, or endothelial keratoplasty in the United States, is a preferred procedure for endothelial disease. But what about DMEK, Descemet's membrane endothelial keratoplasty? Once again, if we look at the evolution of endothelial keratoplasty, the OCT shows us that we went from something that does not look at all like a normal cornea to something that looks much more like a normal cornea, but not quite because of the edges and the thickness, to some post-op result that looks exactly like a normal cornea. So the primary reasons for learning DMEK as opposed to staying with DESEC is that DMEK represents exact anatomic replacement. As I've always told my students, you know, we should always strive for what is been created. We should strive for what God and evolution have told us is best. If we can have what is the normal state, then we've really accomplished our goal of returning the patient to a normal vision, a normal life. We found that DMEK gives us better visual results than DESEC. We may not measure it all the time in Snellen visual acuity, but we do know it's better in terms of aberrations. We do know it's better in terms of color perception. All the qualitative aspects of vision with DMEK is better than DESEC because of the normal anatomy now. There's definitely a faster visual recovery with DMEK than with DESEC. And what was surprising again was that we had a lower rejection rate than DESEC. If we look at the rejection rate, it's less than 1% in the first 2 years after DMEK surgery. What's even more remarkable and more compelling about DMEK surgery is that we can get 94% of our patients off steroids at 1 year, and that's huge. Now, there's been explosive growth in DMEC in the United States, and it's catching up to DSAIC. However, when we look at least 2018 and still 2019 of the Eye Bank Association of American Statistical report, we do see that EK now far outstrips PK in terms of enthel replacement. However, when you look at DMEC, DMEC only makes up 21% of the corneal transplants, and DSAIC makes up 38% of all corneal transplants. And if you look at the popularity of DMEC in the United States in terms of the total EK procedures in the United States, 30,000 cases of EK procedures, DMEC only makes up about a third of those, even though it's now 2020 and it's still stuck at about a third, maybe slightly larger. Well, this is odd to me because I've always wondered why do surgeons do what they do? Why do some surgeons do one operation and others will be an entirely different operation for the same condition? Why aren't we all doing descemetous membrane endokeratoplasty when we know it's a better procedure for the patient? Well, let's go back to this question. And we've asked it of DLEC versus PK, and then we asked it of DSAIC versus DLEC and PK. And from the surgeon's perspective, when you ask them about DMEC versus DSAIC, well, they'll say, yes, we agree with you, Mark. We agree with you that it's better for the patient to do a DMEC than DSAIC, but it's not easier and it's not faster. And so once again, as we go through the evolution of any new procedure, you have to make it easier, you have to make it faster, or surgeons will not accept it. And you have to make sure that it's paid for. Well, at Deborah's Eye Institute, Lions Vision Gift, or Eye Bank, we've been trying to make it easier, faster, and standardized, as have others around the world. And so what we've found is that if we have pre-stripped tissue, just like when we had pre-cut tissue for DSAIC, having the tissue already stripped for the surgeon by the eye bank is a huge barrier to acceptance, overcoming a huge barrier. We then put a stamp, either an S or an F stamp, and this is also provided by the Lions Vision Gift or the eye bank before the surgeon even gets the tissue. The technique, we've learned things from our colleagues. Friedrich Cruz has taught us that if we overstrip the recipient by just a little bit, we will have a bare stromal surface to put the new graft on, and that preventing that overlap will help to prevent rebubbles. We've learned from Mellis that we need to have a glass injector to have the easiest time of it, and Mike Stryko, my associate at Devers, has developed a wonderful glass injector, as have others. There's many techniques for unfolding the tissue. We found for Edvil Uric developed a technique years ago of a no bubble tap unfolding technique. And Jose Guel from Barcelona has shown us that if we use SF6 instead of using air, we have longer support of the tissue, and this can reduce our rebubble rate. So this is what happens now in the United States for most of our surgeons now. We make DMEC even easier and faster by having pre-stripped, pre-stained, pre-marked, pre-trephinated, and now pre-loaded tissue, so that when I obtain my tissue, it looks like this. It comes already in the glass injector, already stained, stamped, ready to go. Patient ready. So now what is DMEC surgery like for us? Well, it's a clear corneal incision instead of a scleral incision. Instead of that large 9mm incision we were doing for DLEC, it's now a clear corneal incision. It's 3.0 millimeters or less, depending on the injector you use. Most of the other steps leading up to injection of the DMEC tissue are the same as DSAIC. You score and strip descemetous membrane. We do this over Helon, not over an air bubble. It's much easier over Helon. And we overstrip, not understrip. We do place an inferior peripheroidectomy because this is needed to avoid pupillary block. Even with an inferior PI, you can sometimes get a reverse pupillary block, but that's very rare. We prevent upside down grafts, and this is critical because even in the best of hands, a surgeon can sometimes mistake the DMEC tissue for being right side up when it in reality is upside down. And that's a terrible surprise to have the next day. So we never have upside down grafts at the end of surgery because we have a mark showing us which side is which. We use the SF6 gas, and the gas bubble size is 90% fill of the chamber. And we always make sure that the peripheral iridectomy inferiorly is uncovered when the patient's in the upright position. If I were to give one tip on how to avoid complications to DMEC, I'd say go to this website. This is a free website. It was developed by a former fellow of mine, Peter Feldman, who's now at the University of Chicago. And in this website, he has beautiful drawings and live videos or videos demonstrating the common tissue conformations of the DMEC tissue. After you inject the tissue, it can take these shapes. And he gives you a step-by-step method of unfolding the tissue, unscrolling the tissue, so that you can have successful surgery. So I can't emphasize enough that this patientready.org website, I find, is just a superb teaching tool. Now here's an example after the tissue's already been sent to us. This is when we were stripping our own tissue, but I've stained the tissue, I'm aspirating it up. I want to show you in this video some of the tapping techniques that we do. And so we take this glass injector, we're putting it through the incision. And once we're in the eye, we tend to rotate the injector so we can get it right side up. And then we'll inject slowly, inject the tissue. Now the key on this is to make sure that the chamber is shallow before you take this out. But we can see we've already had shallowing from the peripheral paracentesis sites. I don't always suture the wound first. I'll sometimes leave it open. And then we're going to get this tissue to unscroll. We'd like to make sure it's in the proper position. And so I'm releasing some fluid here to shallow the chamber, The key to the surgery, in my mind, is a shallow chamber. Now, this would be easy to unfold, but I went for a double scroll. I'm shallowing the chamber. If you don't have a shallow chamber, you can't unscroll the tissue well with this injection technique. We're tapping the periphery to open by pushing fluid through the scroll to open it up. We're compressing and releasing at the other side to move the tissue over. So we're creating fluid waves to move it one way. Now we moved it too far, so now we're going to move it the other way by compressing. And this is just creating fluid waves to move the tissue about. I can release some fluid from the main wound gently, and that opens up an edge. I can tap at the at the periphery and these fluid waves, or I can compress and release the periphery. I can shimmy. I can create a vibration of fluid waves. And once I'm getting it all centered up, if I like the centration, then I can put a very small gas bubble and then expand it as we go. We want to keep, I released a little fluid there to open that edge. And we want to keep the eye in primary gaze, and we have that open. This edge can be taken care of over here by simply releasing some of the gas and then tapping that out. Now here's that same case. This is 3 weeks post-op, and the vision was 20/20 + 1 with no glasses at all. And this is the kind of result that you can get with DMEC. Obviously, it's a great example of a great case, but we don't see 3-week post-op vision like this very often with DSAIC or with other forms of endokeratoplasty. Now there are challenges and complications with DMEC. It is a new skill set. DSAIC skills do not transfer. You gain a little bit of appreciation of air bubble use and gas bubble use when you're doing DSAIC. However, if you think that if you're a great DSAIC surgeon, it doesn't mean that you'll be a great DMEC surgeon. You still have to learn new skills. You need to learn to open the graft with tapping and fluid waves, which you don't need to learn with DSAIC. And you need to keep the chamber very shallow with DMEC, whereas you would like to have a deep chamber with DSAIC. Postoperative interface fluid with graft edge separation is common in DMEC and not with DSAIC. You get a higher rate of rebubbles with DSAIC, but it's much easier to do because with DSAIC, the tissue is floating in the anterior chamber. When you go to rebubble, you have to reposition it, get the interface fluid out. With DMEC, the tissue only has part of it down from the cornea and the rest of the tissue is attached. So it's simply a matter of just putting another air bubble in there. And DMEC challenging is challenging in complex cases. So I do not do DMEC in aphakia, ACI wells, and tubes using an injection with tapping technique. You need to use a pull-through technique in order to be using DMEC in those cases, or you can simply do it as sake. Now, there are other popular techniques of DMEC that I mentioned. One is the endo-in pull-through DMEC, and the other is PDEC, which is very popular in India, and Amar Agarwal has been a proponent of that for many, many years. I'd like to thank Rajesh Vogla for this video of an endo pull-through technique using an IOL injector. I could probably have Rajesh right now give the narration on this. But as you see on this, after the tissue's been stripped, you pull it in, and you might have a little helon on the endothelial layer. This is then pulled into an injector. Good morning, Daddy. Good morning, Nicholas. And after the injector is put in the eye and is pulled through with the anterior chamber maintainer, and then with simply tapping and keeping hold. And the key on this is to make sure you don't let go of that tissue until you have an air bubble to support it, and then simply tapping. And this was a case, I believe, with an ACI well. And then the air bubble is placed. Now, this is the endo-in technique, the video courtesy of Donald Tan, using his endo injector. And this, he's taken the sake tissue that has also got the pre-stripped DMEC over it. And he's using the sake posterior stromal layer as a carrier for the endoglide. So he's pulling both the posterior stroma and the descemet's membrane into the endoglide. And pulling it across. Notice that the fluid has been evacuated now. Now he's got an anterior chamber maintainer, as you can see, and he's going to pull both the stroma and the endothelial layer toward the anterior chamber, but then he's now going to grasp just the descemet's membrane, and he's going to pull it off of the posterior stromal layer and pull that into the anterior chamber. Got the anterior chamber maintainer on, and once again, the key is do not let go at any time. And then when he pulls out the injector, a little bit of fluid, a little bit of tapping, and then he puts a gas bubble or air bubble underneath it. And now you can let go here. He's going to actually get the edges open. And then let go of it. And your tissue's in place. With the pull-through technique, you are allowed to do more complex cases. Well, which technique is better? I mean, we've got people that do pull-through, people that do tapping. There was a beautiful article by Marianne Price in Cornea 2018, where they looked at 754 cases, about half and half of the tapping technique and the pull-through technique. And the rebubble rate was the same, the endothelial cell loss was the same, and their unscrolling time was the same. So the bottom line on this is either technique works well. The surgeon's comfort level is the most important. Now, what about PDEC? I'm sure in India that there's been much more presented on PDEC than I can ever present. And you know that it's Dua's layer with descemes and endothelium of the donor tissue. The tissue is prepared using posterior layer air injection, staining, and scissors. And the insertion technique is similar to endo-in DMEC with a pull-through technique. It can also be injected as well. Now, some advantage of PDEC over DMEC. DMEC can be used in all types of cases, endothelial replacement, routine cases, and very complex cases. PDEC allows easier opening of the scroll tissue because it has that posterior layer, which gives it a much stiffer conformation. And PDEC allows even very young donors to be utilized. In our practice, we do not do DMEC with donors that are younger than 40 years old. Now, we have occasionally used a 20-year-old or a 28-year-old, but it's much more difficult with those younger tissues, whereas PDEC allows very young tissue to be used. Huge advantages. There are some advantages of DMEC over PDEC. DMEC tissue is pure anatomic replacement. And I still believe that if we have just Descemet's membrane replacing just Descemet's membrane, this will give you less higher order aberration than donors that carry any stroma, even Lewis layer. There's less risk of interface optical distortions. DMEC donors now can be completely prepared and preloaded by iBank and then sent to the operating room for use by the surgeon. We do not have that capability at all the iBanks for PDEC in the United States. Stripping of DMEC tissue is less complex than preparation of PDEC. If you look at the way PDEC is produced, it is a more complex technique of harvesting that tissue. DMEC surgery is now standardized with an easy learning curve, and DMEC now has a large volume of peer-reviewed literature. And although the literature is growing for PDEC, there's much more peer-reviewed literature on DMEC than PDEC. Well, what about treating endothelial dysfunction? We talked about endothelial keratoplasty, the progression of that, but now we're moving even further. What about endothelial dysfunction that's treated without a transplant? Well, there's Descemet stripping only, DSO of the central, excuse me. Cindy, could you turn that down, please? I'm sorry, my family. So Descemet stripping only is where we strip the central 4 millimeters, and we use a ROCK inhibitor, Repositol drops, which is medical stimulation of endothelial migration and mitosis. Now, the big limitation of DSO is that it's not effective in pseudophakic bullous keratopathy odds. You must have that peripheral reserve. And I know that in India and many other countries outside the United States and outside of Europe, that the primary need for endothelial replacement is pseudophakic bullous keratopathy. But in the United States and much of Europe, when we're looking at Fuchs dystrophy as our primary cause of endothelial dysfunction, we can do Descemet stripping. And it's important to recognize that it doesn't work in all cases, and probably because not all Fuchs dystrophy is equal and the endothelial reserve is not all equal. In this case that I did a phaco first, and this is my capsulotomy line right here. And the Descemet stripping line is right here. And it's very simple to fill the chamber with Helon. And after we've done the phaco through the same wound, just strip off the central 4 millimeters. It's important to mark the center of the cornea at the slit lamp before the patient is dilated. Place a mark on the center of the cornea in the center of the pupil, and then you will be able to use that mark for your Descemet stripping only. And to strip just 4 millimeters, maybe 5 millimeters, but much more than that, and you start getting failure with DSO. Well, this is that same patient you saw the slide on. This is 1 week post-op. And the vision without glasses is count fingers. And you have to really prepare the patient for that. You have to let them know that you cannot have vision until the stromal edema is gone. And the stromal edema is severe. And look at the macrocysts here. This is a function of Repositol. Little microcystic edema of the epithelium will turn into macrocysts with Repositol on board. This can be quite irritating the eye. But then 4 weeks post-op, look at this cornea. This is a normal cornea, and the endothelial cells have filled in all this massive area of edema. And the patient now has 20/20 vision with his own cells. The endothelial cell count at 4 weeks post-op is 625, and I just saw that patient 1 year later now, and the vision is still 20/20, and the cell count stands around 600 to 700. But these are his own cells, and he'll never have rejection, and etc. You know, all the reasons why DSO is a good idea for selected patients. Now I'd like to move on to the final very section on here and just talk to you about an innovative transplantation technique for endothelial failure, and in the setting where there are multiple limbal melts. So I see some of the most fascinating complex surgery videos I've ever seen in the world coming out of India. And I'm probably bringing complex procedures to people that are already doing a lot of this. But for me, I think that a new approach to very devastating cases where it's not only endothelial failure, but there's extensive necrosis and extensive thinning of peripheral cornea. This technique that I've been working on the last couple of years has been helpful. And I think this is a hybrid transplant. And this is where, when I say it's hybrid, because we're combining DALK surgery with PK in the same operation on the same eye. But it's not the donor tissue that we're doing the DALK and the PK on, it's the recipient bed. So when do we do hybrid surgery? Well, it's for cases that require a 10 millimeter or larger graft. So I'm not advocating this hybrid surgery for standard cases, ventral replacement or melting, but it's for when you have extensive melting and you have extensive extreme recipient corneal thinning that involves areas in the periphery where you normally would be passing your sutures for a PK or a DALK, and there just isn't enough tissue out there, or there's a big hole in the periphery. And these are the kind of cases that are just total disasters. In addition, these cases have marginal central endothelial function or even central necrosis and holes. So for instance, what do you do with a cornea that looks like this? This is a patient that had strep ulceration and was treated for a couple of days with vancomycin and fortified antibiotics. But then she perforated. And when we look at this, there's very little limbus left. And if you look at a schematic, it could be extensive thinning where you don't have anywhere you can suture, and you have to do a very large transplant. So what if you just do a full thickness transplant? Well, here's what happens. If you cut out in the sclera, after you recess the conjunctiva, if you cut a full thickness scleral trephination or near full thickness, and then you take off all that necrotic tissue and you put on a full thickness transplant with the endothelium, what happens is the iris will come up, and the iris will come up and obliterate your angle. It'll also steal all of those endothelial cells from the center, will migrate onto that iris, and you'll get absolute glaucoma and absolute endothelial cell loss, forcing you to do a penetrating keratoplasty later after you've already treated the patient then with glaucoma tubes and trabs and everything else. So if you do a full thickness penetrating keratoplasty on a 10, 11, 12 millimeter bed, you're going to end up with multiple operations in the future. So what is a hybrid transplant? Well, it's not about the donor tissue. A hybrid transplant is about the recipient bed. So a better way to treat these disaster cases is to cut down to about 100 microns left of the stroma or the sclera. Carry out your dissection as you would with a DALK, creating a flange, creating a peripheral area of corneal tissue that is only 100 microns or less of tissue. It doesn't matter if this is healthy endothelium or not. Just create a stromal bed of tissue for 360 degrees. And then take a donor that is, if it's a 12 millimeter bed, a 13 millimeter donor, not the same size, not even a half a millimeter, but a full millimeter larger. And keep all of the endothelium on the donor, keep the entire thickness of the donor, and place this into the bed and suture it in the sclera. So when we're thinking about doing these large transplants, we have to evaluate what is going on with the recipient. If the recipient endothelium is healthy all the way across, and there's no central scarring and no central necrosis here going through the endothelium, then we can simply do a large lamellar graft and rely upon the endothelium of the recipient to detrigest our large graft. That's just simply a very large lamellar transplant. But if you have endothelial cell loss, or you have holes here and here and here, then what we can do is create those flanges, the DALK in the periphery and the PK in the center, and put the entire graft on top. And this will now allow the angles to remain open. So 13 millimeter full thickness donor with endothelium
onto a 12 millimeter bed, leaving these flanges to preserve the angle. And if you do this, your final result will be that the flanges will adhere, or sometimes they don't adhere to this, but they don't come down onto the iris either. They simply are sticking out into the aqueous. And we leave our angles open, and we have the endothelium of the donor now to give us a beautifully clear cornea. So the characteristics of the hybrid transplant are the endothelium is retained on the graft, the entire area of the graft. The graft is 1 millimeter larger in diameter than recipient bed, and we don't modify the edges of the graft. We simply just take the entire thickness of that. Whatever recipient limbal epithelial stem cells can be saved. So I didn't mention this, that we do want to save, if we have a graft that's not purulent all the way through, if we have a recipient bed that doesn't have necrosis everywhere, we want to save whatever epithelial cells are on the surface of the recipient and recess those back before we do our large trephination. It is necessary to use 9-0 nylon sutures to those scleral edges to approximate them, because 10-0 won't hold. Then we cover the edges with the recipient conjunctiva and the recipient stem cells, and I also put an amniotic membrane on top, and oftentimes a tarsorrhea in these very sick eyes. So let's get back to that case. Here's this horrible looking case. And we recess the conjunctiva, saving whatever stem cells there might have been up here as much as we can. A 12 millimeter diameter deep trephination and deep lamellar dissection, leaving 2 millimeters of the flange here. So this is 2 millimeters. And then the 8 millimeter penetrating trephination. And then we take off all this stuff and we put on a 13 millimeter graft, suturing the sclera down and then bring the conjunctiva over it. And what happens is you can take an eye that looks like this, and 3 months later, you get an eye that looks like this, where the vision is now 20/60 without glasses, because these are far peripheral sutures and they have very little compression of the central cornea, very, very little induced astigmatism. And importantly, the angles are open. So you see that this flange here, this Dowk area of the periphery has allowed the iris to stay back. And now the pressure is 16 on no medications. Well, the advantage of the hybrid transplant over the PK is the 13 millimeter hybrid transplant will preserve the angle. A 13 millimeter PK will not preserve the angle. The hybrid transplant avoids extensive iridocorneal adhesions. You get retention of the transplant endothelium, and this allows corneal clarity. Even if the peripheral flange does not adhere and the flange is coming down, you can still have corneal clarity all the way across because you preserve the endothelium on that donor all the way across. The astigmatism is low because of those minimal compressive sutures, and you have a rapid edge healing scleral edges because it's a vascularized edge. The big question, obviously, in all large transplants is what is the rejection rate going to be of these large lamellar grafts? We can tell you that we have had 1 out of 5 had rejection, and we were able to reverse that rejection by using heavier topical steroids. We have not been using systemic steroids or systemic immunosuppression for these grafts. That certainly can be done if we find over time that our topicals do not work. Well, to conclude this large lecture on endothelial evolution, endothelial replacement evolution, I'd like to give the final comments that we truly are in the most exciting age of corneal transplantation there's ever been. The rate of innovation, think of this, just think of this. The rate of innovation in surgical techniques has accelerated exponentially in the past 10 to 20 years. And I truly, as an older ophthalmologist now, I envy today's residents and cornea fellows. I mean, my God, you've got the brightest future in cornea that's ever been in the history of cornea. And it's also challenging, but it's so exciting. And what I would recommend to the residents and the fellows is you should embrace this challenge. Think of where you can make a difference and make that difference. As Swesha said, I always pay tribute to my family because they're the ones that allow me to be here and talk with you and spend time away from them. So thank you, Charlie. Thank you, Nicholas. And thank you, Cindy, for allowing me to have this early morning giving the talks. And I thank them for supporting me all these years. And I thank everybody at the Congress for your kind attention to this lecture. Thank you. It's been an honor to be here with you, even if it is virtual. Thank you.
Thank you, Dr. Terry. That was a fabulous oration. It's just no words to express how amazing it was. And I think the last message you gave for the younger new cornea specialists who are coming into the fray, I think it's a very good message. And it's truly an exciting time to be a cornea specialist. Thank you for honoring us with this oration. And I'd like to let Dr. S.K. Mittal, who is part of our organizing team at HOA, give the final closing comments and word of thanks.
Good evening, everybody. I, Dr. S.K. Mittal, Joint Secretary, HOA, feel privileged to propose vote of thanks on this occasion on behalf of HOA and HOA VISTA Organizing Committee. I extend my sincere thanks to distinguished national, international faculty for sparing their time in spite of their busy schedule and odd hours in various countries because of the difference in the clock. A special thanks to Dr. Naren Sarup Oration Awardee, Professor Mark A. Terry. I extend my sincere thanks to all national faculty, keynote speakers, session coordinators, panelists, and all speakers for providing this academic feast by sharing their experiences in their respective field and making this event interesting and memorable. I thank all the participants, delegates for making this HOA VISTA 2020 a very successful event. My sincere thanks to our digital partner, Hallmark Events, for with their support, we could get connected with all of you. I wish from my core of heart, my thanks to our business associate sponsors. With their support, this event has reached to a new height. In the last but not the least, I express my deep sense of appreciation to our president, vice president, advisor, secretary, and whole organizing team. We wish and we hope to meet you all in our subsequent meet, and I wish you all a very happy New Year 2021. Thank you.
Thank you, Dr. Mittal. I think that is perfect. And
Malika is missing.
Yes, Dr. Terry, we'd just like you to hold on for a minute. We want to take a picture with you, virtually at least.
Okay. Done, doctor.
Perfect. Thank you so much.
Thank you, Rishi. This was
Thank
really
you,
a
Dr.
pleasure.
Terry.
Thank you, Professor Terry. It was great having you with us. Wonderful lecture.
Thank you
one of the
so much. It was nice to see all of you, even if it was virtual. I hope the next time that we can spend together having some coffee and some smiles.
Sure, sure.
Thank you, everyone.
All right, take care now.
Thank you, everybody.
Bye-bye, Rishi. Thank you again.
Bye-bye. Bye-bye, everyone.
Thank you. Good night, all.
Good night.
Are we offline?
Thank you, doctor.
No, we are still online. I think on behalf of HOA, I think it's my duty to mention special thanks to the Hallmark team, Sheshadri, Vinay, Peshwa, and so many others, Deepthi and all who have been with us throughout. Done a wonderful, great job, and I think we encountered much less glitches than a physical conference. So I think it was a great effort overall. I think you have found us equally comfortable to work with.
Yes, doctor. Yes, doctor, very much.
Anybody wants to say something? Please add.
Yeah, I just wanted to say that the support was excellent, and thanks for prompting us and putting up with all our nakras and last minute demands and commands. And I think you guys have just helped made it so comfortable. Thanks for all the posters. I think they were very well done, and continuously following up. I think we got a lot of registrations because we had you. On our own, I think even if each of us had individually pushed it, I think it wouldn't have reached the stage. So it was seamless in that way. Yeah, thank you.
Thank you. Thank you, doctor.
Thank you, Hallmark. Thank you, Sheshadri. Thank you, Vinay.
Thank you. Thank you. Thank you, sir.
Thank you so much.
Thank you, doctor.
Thank
Bye,
you.
everyone. Bye.
Bye.
Hi, Grover team. Hello.
Yes, sir.
Thank you so much, all of you. I think Anup, I know from Hall B, and who was in Hall A?
Pratap, sir.
Pratap, Naresh, and your boss, Abhishek, everyone. I mean, whoever was with you to make this HOA successful. I mean, Hallmark says thanks to you.
Thank you, sir. Thank you so much.
Wonderful, wonderful support, wonderful cooperation. You know, last minute of our giving of guarantees and things, good support, and we continue our relationship. It goes on.
Thank you so much, sir.
Thank you, thank you. Bye.